is whatever the lectures are done in Brussels, Belgium. Out of that, almost 50 lectures will be selected and the speakers will be called upon here. Thank you.
Thank you, Abhijit sir. I think Abhijit sir had explained us a very basic part from the part of ABC to NIV and even to the advanced hemodynamic monitoring. A big applause for the Dr. Abhijit Deshmukh sir. If anyone has any queries or questions, just please stand up and raise your hand. We'll provide the mic. This CM is not just based upon the theoretical points, it will be based on practical points, the clinical scenarios, the daily problems that we get on a OPD basis or hospital basis. We can always come forward and ask the questions to our expert. Now we'll move for, now I request Dr. Vikram Agarwal sir, CEO of Qrs Hospital, to felicitate Dr. Abhijit Deshmukh sir. Please sir. Yes. It is our Meyer MIT's tradition to felicitate with shawl, a Gnaneshwar Mauli photograph, and a memento. Thank you, sir. Thank you, sir. Thank you. I request Lokare sir to be seated on the dais. We'll move to the next lecture. Our next lecture is on acute chest pain approach by Dr. Suraj Ingole sir. I request Dr. Suraj Ingole sir to come on the dais. Dr. Suraj Ingole sir has done his MBBS at DNB Medicine from Coimbatore. He had done his IDCCM from Ruby Hall Clinic. He did his DNB cardiology from Jahangir Hospital, Pune. He worked as a consultant cardiology in Sai Cardiac Hospital, Kolhapur, and Baroda Heart Hospital, Vadodara. He has a special interest in bifurcation and C2 angioplasties. He is currently working as a consultant in the cardiology department in VIH since last 1 year. Please, over to you, sir.
Thank you. Hello, am I audible? Thank you, sir, for this introduction. And it's always pleasant to present after Abhijit, sir. I had an opportunity to work as a registrar under him initially, then as a colleague after my medicine. Truly a gem of a person. Pune has its own identity in critical field. Stalwarts from Prayag sir to Borauke sir, Lokare sir, and Abhijit sir has identified internationally as well as nationally Pune in critical field. I am happy that Vishwaraj Critical Care has also developed to up to the standards within very short span of time. Because of this backup, we can do so many complex cases in cardiology without stress and without any problems. So our guidance is Dr. Borauke sir, and our critical care has done very well in recent years. So we'll go to our topic, chest pain. The goals will be like seeing pathophysiology, diagnosing, and treatment of life-threatening causes of the chest pain. As pathophysiology diagnosis we'll see for the whole, and we'll see few life-threatening causes of chest pain which can be treated immediately. Chest pain is 5% of all emergency department patients present with the chest pain. Approximately 5 million visits are for the chest pain per year. In the pathophysiology, visceral fibers generally have the poorly localized as a poorly characterized pain. So any angina or heart-related pain, patient cannot pinpoint the pain. He will keep his hand on the left side of the chest, or he will show the fist on the chest, that is called as Levine's sign. He cannot pinpoint the chest pain during the angina. The visceral fibers provide to heart, blood vessels, esophagus, and visceral pleura. These chest pains are not poorly localized as well as poorly characterized. Dorsal fiber generally overlaps, so any chest pain can produce, it can go up to the jaw as well as epigastrium. So angina can start from the jaw up to the epigastrium. In contrast to that, parietal pain is generally sharp. It's localized to the superficial dermatome, which is the pain site for the painful stimulus. Dermis as well as parietal pleura is innervated by parietal fibers. If patient comes with the chest pain, we should initially first look for the CAB. Is there immediate intervention needed for the patient? If patient is gasping, does he have Vt or does he have cardiac arrest? Does he require CPR or immediate intubation? These things should be first assessed. Then look for the cardiac and vital signs monitoring. Take a ECG while talking to the patient, while taking the history. Do not waste time. If you are suspecting the ECG or even if in all the patient of the chest pain, while taking the history, take a ECG simultaneously so that you will not miss that time. If ECG is showing something problematic or patient is in severe pain, give him pain relief medications. For the cardiac patient, maybe it should be sorbitrate, or for other patient it will be a painkillers. After that, he will be slightly relaxed, and then you can take in the detailed history as well as physical examination. So these initial steps are very important when patient come with acute chest pain. Pain history we can assess with this OPQRST, or second one is the Socrates. That is the site of the pain, onset, what is the character, where is the radiation, associated symptoms are there, what is the duration of the pain, relieving and exacerbating factors, and the severity of the pain. These 10 points should be assessed in every patient of the chest pain. These 10 points will give definitely a very valuable information about the chest pain, where from it is originating. Now, for the chest pain, site of the pain is very important. Cardiac pain is generally central one. It may radiate to jaw, neck, both the arms, mostly left arm. Respiratory chest pain generally, if it is infectious or pneumothorax, it is localized to the site of the pathology. Asthma, COPD may have the central chest pain, but may not be similar to the cardiac one. Musculoskeletal pain localized to the site of the injury. Peptic ulcer pain is generally lower chest, epigastric in nature. Nature of the pain is important. Cardiac pain is generally dull-like sensation. It is not pleuritic, but respiratory or pleuritic pain or musculoskeletal pain are sharp and pleuritic one. Pericardial pain is also sharp and pleuritic one. Nerve root pain is band-like shooting and comes from the back towards the anterior. Gastrointestinal reflux is generally sharp and burning, like patient complains of the burning sensations. Radiation of the pain. Cardiac pain generally radiates to the jaw, back, neck, both the arms, as well as left side arm. Aortic dissection pain, peptic ulcer diseases and pancreatitis radiates to the back. Nerve root pain, it's like a band-like pain, radiates from back to anterior side. We should take detailed onset, duration, and frequency or progression of the chest pain. Precipitating and relieving factors are also important. Exertion increases the cardiac pain. Deep inspiration, respiratory as well as musculoskeletal pain. Pericardial pain will be increased due to respiration movement. Generalized movement will increase musculoskeletal pain. Eating, peptic ulcer diseases will be increased. GERD, position, pericarditis, pancreatitis, gastroesophageal reflex worsens on the lying down. Relieving pain, cardiac pain generally relieves on the rest. Nitrates, esophageal spasms also relieve sometimes on the sublingual nitrates. Antacids relieve peptic ulcer diseases, gastroesophageal reflex. Simple analgesics will relieve musculoskeletal pain, respiratory pain as well as pericardial. Bronchodilators will receive tightness of the asthma and COPD. Change of the pattern of the pain is very important, whether it is static, increasing or decreasing. That will tell the status of the disease. Associated symptoms, dyspnea, exertion, diaphoresis, tends toward the cardiac pain. Fever, cough with expectoration, pneumonia, vomiting, heartburn or burning sensation, food intolerance, GERD. Past history, diabetes, hypertension, coronary artery disease past, COPD in the past, medical history, social history of smoking, tobacco, alcoholism, family histories, all are important. Differentiation between the non-cardiac and cardiac pain. Generally, cardiac pain is central and diffuse one, while the other one is patients. While during my residency, patient was admitted for the angiography from the emergency. He had chest pain, T-wave inversions and everything. When we went and I just removed his shirt, there was a scar of herpes zoster, and it was a post-herpetic neuralgia, and his angio was not done, TMT was done. And now after becoming a cardiologist, I know why my cardiologist was not very happy, even if I diagnosed very good decision. Then comes the auscultation, murmurs, rubs, gallops. Murmurs, we have to see for the acute mitral regurgitation, aortic regurgitation in case of the aortic dissection, ventricular septal rupture in case of in case of acute myocardial infarction, rubs in pericarditis as well as pleuritis, gallops in case of the heart failures, breath sounds, we have to see if there is absent breath sound on one side, is there consolidation or is there any other Krebs or patient is in failure. Percussion, dullness or resonant node, dullness, consolidation, very much resonant, we have to see for the air in the chest. Palpation, we see the tenderness, localized tenderness. Heave, for the seeing right ventricular heave we can get in the pulmonary embolism. We have to see the apex beat. There can be point of maximal impulse and apex beat different in case of the pericardial effusion. JVP, whether JVP is raised or not. Bruit in case of the aortic dissection, whether it is extending to the aortic carotids or whether there is a hypercholesteremia signs, see for the bruise. Abdomen, extremities, whether there is a swelling, there is pulses, lower limb pulses, tenderness, Homan sign. Our teacher used to usually say, if you don't touch the feet of the patient, you will not be blessed. We have to touch the feet of the patient. We have to see all the peripheral pulses, see for the tenderness, for the Homan sign. These are differential diagnoses, so many differential diagnoses for the chest pain. This is the distribution percentage-wise, 42% present with the gastrointestinal chest pain. Ischemic heart disease will be present in the 31%. It's a quite large number. Chest wall syndrome in the 28%. Others are low, but very important also. So we'll focus now on the life-threatening causes. If the patient comes, we first will rule out these life-threatening causes. Acute coronary syndrome, definitely. Why we should suspect? Any male more than 30 years, any postmenopausal female complaining of the retrosternal chest pain should be suspected to have myocardial ischemia until and otherwise proved. All of us during our internship or during our learning phase have seen that patient comes with the chest pain. We have seen the ECG is normal. We send the patient of the home and comes back after the 2 hours, 3 hours with a frank myocardial infarction. This is the learning curve for everyone. Experience teaches the best of the things, and so we should be suspecting each and every person more than adult, more than 30 years and postmenopausal female as a myocardial ischemia until and otherwise proved. Acute coronary syndrome, what is the epidemiology? In the emergency population, more than 30 years of age, 15% will have acute myocardial infarction, 25% to 30% will have unstable angina, those who present with the chest pain. Typical chest pain, pressure like it will be a squeezing type, crushing, worse with the exertion, shortness of breath, diaphoresis, left arm pain or jaw pain. Majority of the patient do not present with the same typical symptoms. They will have different kind of symptoms, and so chances of missing the diagnosis are more. Cardiac risk factors are, we should consider that his age, diabetes, hypertension, family history, smoking and hypercholesteremia. Acute coronary syndrome, diagnosis will be on the ECG, ST elevation MI with the more than 1 mm of ST elevation, new onset of LBBB, T-wave inversions or ST segment depression will suggest subendocardial ischemia. 5% will have normal ECG. That's what we say. Diagnosing ST elevation MI is very easy, but saying you are normal to a patient with the chest pain with the normal ECG is a difficult thing. This is a typical ST elevation anterior wall MI. We see the ST elevation in the anterior leads. This is the inferolateral MI with some posterior reciprocal changes. Then comes the role of the cardiac markers. When the ECG is normal, then chest pain is there. You still suspect there is something wrong. we don't have a echo, then go ahead with the cardiac markers. First is the troponin T, which increases in the 2 hours, peaks around the 10 to 24 hours. Next is the CPKMB, 3 to 4 hours and 10 to 24. Nowadays, highly sensitive troponin also is used. Both are sensitive and specific. CPKMB not affected by renal failures. This is the chart. The spectrum of acute coronary syndrome is generally stable angina converts into an unstable angina, and then acute coronary syndrome starts. It's unstable angina. We don't have the evidence of necrosis. That means the CPKMB, trop T will be normal. ECG will show the subtle changes of ST depression on T wave inversion. There won't be a Q waves at the last. Non-ST elevation MI, ST depression will be there, T wave inversion will be there, cardiac enzymes will be positive. ST STEMI, that means the artery is totally occluded, ST elevation will be present, cardiac enzymes will be present. If you have a echo, that's a very good thing. Peripheries don't have echo. Those who have echo, that's a very good thing. Regional wall abnormalities occur within the minutes. Echo will detect 80% of MI. Still there is a doubt for the 20%. It is an operator dependent test, as well as sometimes it is missed. Normal echo in the setting of the chest pain has very low probability of MI. Early screening for the complication should be done, like aneurysms, acute mitral regurgitation, cardiac rupture, VSR or cardiac tamponade. This is LV contraction and the other one is not contracting. Acute coronary syndrome treatment, we all know that if STEMI is there, we should rush for the thrombolysis or the primary PCI, whichever available. Best is the obviously primary PCI. Non-stabilization MI, we go ahead with the anticoagulation, stabilize the patient. If PCI availability is there, we go ahead with the PCI. Unstable angina, we do the risk stratification with the scores like Gray score or other scores. We do stress echo, we can do the treadmill test if patient is stable, and then decide regarding the angiography or other things. Why not missing acute coronary syndrome is very important. Mortality is twice high in the missed MI. Patient has a twice mortality in the missed MI. Missed MI is most litigated claim against USA, against physicians in USA. 3 to 5% of MI are missed by even expert physicians, and this accounts for the 25% of malpractice. In India, it is different. 20% is the beating doctor, and 5% is only litigations will be there. So other things are, single set of cardiac enzymes will not rule out the acute coronary syndrome. We have to do the 2 sets of the troponin CPKMB, whatever we do. This should be 6 hours apart from each other. Combination of physical history and examination, combination of history and physical examination, ECG biomarkers is the best. No single globally accepted algorithm is there. We can do the risk scoring by TIMI score, Gray score, Pursuit score, but there is only thing that is more important is the clinical judgment of the doctor. Next is the pulmonary embolism, which is very fatal also. Thrombosis in the pulmonary artery. 90% of the pulmonary embolism arises from the DVT. Clot generally travels to the venous vasculature, to the pulmonary vasculature. Dyspnea is present in the 90% of the patient. Its pain is sharp, pleuritic, as well as syncope might be present. There might be a history of immobilization, neoplasm, or hypercoagulable states. Once you see the patient of pulmonary, you know something is wrong. Something is wrong, I'm not picking up. Must be tachycardia, tachypnea, diphoresis, hypotension if the large clot is there, hypoxia, low-grade fever can present with the pulmonary, anxiety. It's a great masquerade. Pulmonary embolism can be present like anything. Patient has just a dizziness and comes to you, nothing else. But we can find out the pulmonary embolism. Diagnostic testing, first and foremost important sign is the sinus tachycardia, unexplained tachycardia on ECG. Suspect pulmonary embolism. S1 QT3, our resident generally come, sir, this is S1, this is QT, this is T3. 20% of the ECGs only will have this typical sign. Others will not have. Don't go on for the S1 QT3. Sinus tachycardia, suspect pulmonary embolism. RV strength, suspect pulmonary embolism. D-dimers, definitely for ruling out as a very good tool. It's a very important tool. This is the score, well score, which gives the probability of the pulmonary embolism. Less than 2 is the low risk, 2 to 5 is 2 to 6 is moderate risk, more than 6 is a high risk. Pulmonary embolism treatment, unfractionated as well as low molecular weight heparin. Thrombolysis, if cardiovascular collapse, hypotension is there. Depending upon the patient condition, we can keep him on the ward or in the ICU. This is the Hampton's hump, which denotes the necrosis or the hemorrhage due to the pulmonary infarction. This is the other signs of the pulmonary embolism. This is the Westmark sign, which shows the pulmonary oligemia. Other signs are like Fisher's signs, Pallas sign, prominent right descending pulmonary artery, as well as cutoff of the pulmonary artery. This is typical S1 QT33, which is present only 20% of it. This looks like a echo. RV, RARV is largely dilated, TR is present, LV is compromised, RARV is enlarged than the LV. On the CT, this will look like this. Now next, very devastating condition, aortic dissection. Intimal tear of the aorta leads to the dissection of the layer and leading to the creating false lumen. This pain is generally tearing. Patient tells that it's a tearing radiating
Last
to the
5
back.
minutes. Last 5 minutes are remaining.
Yes. Risk factors are hypertension, connective tissue disease. On examination, he might have hypertension, hypotension. Pulse difference, very important. Touch the feet of the patient, you will always be blessed. Neurodeficient if it involves carotids. Wide mediastinum on X-ray, CT angio will definitely give the diagnosis. Echo, you can find a flap. Early screening should be done by echo if there is flap or aortic regurgitation. This is the widening of the mediastinum. There are DBK signs. DBK classification, type 1, type 2, type 3. Type 1 just involves the ascending and descending aorta. Type 2 is involving ascending aorta. Type 3 is involving descending aorta. Very interesting story of DBK. He is the father of aortic dissection surgery. He himself developed aortic dissection. He resented the surgery, he did not undergo surgery initially. Then he collapsed due to aortic dissection. His colleague performed surgery. 2 years after, he died of complications of aortic dissection. Father of aortic dissection surgery, it's a fate that. These are the types. Type 1, both involving ascending and descending aorta. Type 2, ascending aorta. Type 3, descending aorta. Type 3, we can treat with the medical management if the patient is uncomplicated. Medical management should decrease the blood pressure as well as velocity of the left ventricular contraction so that the dissection should not extend further. The best ones are nitroprusside. Beta blockers are the best drug of choice. If not tolerated, calcium channel blockers. Ascending aorta dissections, type 1 or type 3 should be treated surgically. Life-threatening complications can be aortic regurgitation, cardiac tamponade, myocardial infarctions. Tension pneumothorax, collection of the air in pleural space causing collapse of the ipsilateral lung and then cardiovascular collapse. Patient generally have a history of COPD, connective tissue disease, recent instrumentation, positive pressure air ventilation. COPD patient with the bulla, ruptured bulla can present with the tension pneumothorax. Typical absent breath sound unilaterally, hypotension, distended neck veins, tracheal deviation to the opposite side. This is the X-ray. Air in the lung, trachea developed to the deviation to the opposite side. Emergency treatment, tube thoracostomy, generally now it is done. Esophageal rupture, tear in the esophagus leading to leaking of the gas into the mediastinum. Inflammation generally are followed by infection and deterioration and sepsis and death. It's a rare but very devastating cause. We had recently 2 weeks back a patient, angioplasty 2 months back, suddenly developed chest pain as well as hematemesis, came here. Everybody must have suspected initially that it must be MI or ulcer which is with the hematemesis. But our emergency as well as ICU team diagnosed definitely it is a esophageal rupture and he was treated endoscopically and discharged very well. 2 weeks back only we had this patient. Risk factors are iatrogenic, heavy retching behavior syndrome, Mallory Westier we everybody know, foreign body, toxic inhalation, we get the mediastinal air on plain film or a CT, we can see the air under diaphragm. This is the rupture, leaking of the material through the esophagus. Antibiotics, supportive care, small tears can be managed conservatively, surgical treatment should be taken care. Endoscopic treatment nowadays for the small tear also is there. So take-home message is generally first check, first stabilize the patient. Do not take the history properly. For the chest pain, history will give most of the diagnosis. Have a low threshold for missing the MI. Do not miss MI. that is very life-threatening for patient also, for the doctor also. Rule out life-threatening causes which we have discussed. Thank you. Thanks a lot.
Thank you, Dr. Suraj Ingole, for a good differential, giving a good differential diagnosis of chest pain. The most important is the clinical history in the patient of chest pain. Most of the patients are diagnosed with a good clinical history. And if you are in doubt, admit the patient. Don't miss the patient of a chest pain. Means if you are highly suspecting, admit the patient. Thank you. I can share one experience of my patient. Around 35 years old male. Actually, he was just came to see me, and his mother was admitted with me for a COVID. Means he was sitting outside the CT scan room, and he just had a giddiness. So I took a history. His mother is admitted in the COVID ward. So I did his CTP, and immediately D-dimer was done. He was diagnosed with a pulmonary embolism. So good history is important. If you be calm and take a good history, 90% of the patient can be diagnosed of a chest pain. Thank you. And most important, admit the patient if you are in doubt. Thank you.
Thank you, sir. Dr. Suraj Ingole, sir, has explained us in a very simplified language about approach to the chest pain, and he was given some clinical scenarios. Now, I would like to request Dr. Rakesh Narimeti, sir, General Manager, Medical Operation, Hospital, to felicitate Dr. Suraj Ingole, sir. Dr. Suraj Ingole, sir. Thank you, sir. I request Dr. Rakesh, sir, to felicitate Dr. Nitin Lokare, sir. Thank you, Dr. Lokare, sir, for moderating this session. Now we'll move forward to the next lecture. Our next lecture is on rhythm disturbances on ECG in ICU patient, how to identify and treat. For this session, I would like to request Dr. Shalaka Lonkar ma'am to come on the dais for moderating this session. Dr. Shalaka Lonkar ma'am done her MBBS from KIMS Karad. She had done a DNB medicine from KM Hospital Pune. She worked in a KM Hospital as an intensivist for 3 years, and she is currently working as the director of Mahalakshmi Multispecialty Hospital in Daund. Very warm welcome, ma'am. I would like to request Dr. Samir Nanavade, sir, to come on the dais to moderate for the next session. Dr. Samir Nanavade, sir, had done a BMS, EMD, Ayurveda. He is the director of Sri Ganraj Hospital, Urdi Kanchan, Pune. He is the director of Ganraj General Hospital. He is a consultant physician in Ganraj Hospital. He had recently received a COVID Warrior Award by State Home Ministers of Maharashtra. A very warm welcome, sir. For our next topic, that is rhythm disturbances ECG in ICU patients and how to identify and treat. Dr. Sachin Lakde, our senior cardiologist, was going to be here for this during this lecture, but because of some personal reasons, another issues, he is not here. So whenever we get this sort of troubles in our hospital, in ICU or in anesthesia section, we always approach one person, Dr. Kapil Borake, sir, always. And regarding this, I called yesterday evening at the 11th hour to Kapil sir. And yes, he is always there and will be always there to rescue from these type of conditions. Sir humbly basically accepted to deliver this speech. I would like to request Dr. Kapil Borake sir to come on the dais to deliver this speech. Dr. Kapil Borake sir is MBBS, DMB Medicine, and an IDCCM. He is a past secretary for the ISCM branch, Pune. He is a teacher for DMB Medicine and IDCCM. He is the director of Critical Care Medicine and Medicine Department in Hospital. Over to you, sir.
Thank you very much. At outset, I would like to thank all of you for participating into this critical care update. Probably critical care is a very important aspect of any hospital, and I don't think we can think of any hospital from here now which don't have a critical care beds or ICU beds. So it's always a pleasure to be at Vishwaraj and be a part of Vrh Gyaan. And actually, I'm really thankful. We have our guest of honor also, Dr. Ganesh Boke. He has also arrived. And we have Dr. Mantri sir also, who is our MMC speaker. As rightly said, intensivist is all the time required in ICU. Why we want intensivist in the hospital? I think COVID has now and then proved that before COVID, the term intensivist was not existent probably. And I think after COVID, our entire world has realized importance of intensivist in the hospital. So as rightly said by Vijay, when nobody is there, it's physician and intensivist who is going to take care of your patients. So the entire theme of today's update is how do I manage? When we see something in ICU or some critical scenario, actually question arise in front of us, actually how we are going to manage it, what we are actually going to do at that point of time. So here I am trying to just brief and just pick up few arrhythmias which are very common in ICU. So if you look into any arrhythmia, for a simplified reason, what you do, you divide them into two. Either they are Brady Arrhythmias or tachyarrhythmias. So Brady Arrhythmias is where your heart rate is practically less than 50, and tachyarrhythmias where your heart rate is more than 120. So before looking into ECG or before looking into monitor, if you are very clear in your mind what you are looking for, things becomes much more easier. So probably what we can have, we look at Qrs complex. Everybody knows about P, PR interval, QRS and T wave. So whenever you are treating arrhythmia, look at Qrs complex. Okay. Now what will happen, either your QRS will be wide or your QRS will be normal or narrow. Okay. Then you look at the rhythm, whether rhythm is regular or rhythm is irregular. If you can keep this chart in your mind, most of the things probably you will try to simplify and treat your patients. If you have narrow QRS, that means when we see any tachycardia patient, sinus tachycardia, how is the QRS? It's narrow QRS. And if your rhythm is regular, you boil down to only these four conditions: sinus tachycardia, AVNRT, that is in short supraventricular tachycardias, or atrial tachycardias. So most commonly what we see in ICU is sinus tachycardia. Okay, most of the ICUs, if you walk in, most common thing what you see is a sinus tachycardia. But at the same time, if your rhythm is regular, but if your QRS is wide, that means by again and again looking at ECGs, you will realize there's no need to measure whether QRS is wide or not. By just eyeballing, you can get to know whether this QRS is wide or not. If your QRS is wide and rhythm is regular, then probably you are into more trouble. Either you are dealing with Vt or you are dealing with SPT with aberrancy, and most of the times we get confused when we see patient of SVT. Okay, when we see SVT ECG, we feel whether this is SVT or Vt. So always remember, if any patient had a history of previous any heart disease or a myocardial infarction and coming with a ECG which looks like SVT, assume that that is VT. That is the best way to save that patient. Okay. Then coming to irregular rhythms. Suppose your QRS is narrow, that means near normal, and you have irregular rhythm. So most common what we see is atrial fibrillation. So in first chart we will see sinus tachycardia, SVT. In next you will see AF, and in wide with regular you will see VT. Then we have wide with irregular, then probably you need a bit more experience to diagnose that atrial fibrillation with aberrancy. Now remember this in your mind. Now this is a ECG, diagnosis is already given. It is sinus tachycardia. Why it is sinus? Whenever you say a sinus rhythm, remember that every P has to be followed by QRS and then T. So if you have every P waves which is followed by QRS, then probably you are dealing with a sinus rhythm. Okay, so this is sinus tachycardia. This is most common rhythm. Now what happens in ICU? When we walk in, we see heart rate of 150, 160, 140, 130. We get panic. And we, as a intensivist or as a person working in ICU, we always want our numbers to be normal. Why like that? I don't know. We want oxygen to be more than 95. We want heart rate less than 100. We want blood pressure 120/80. We want urine output normal. But all the time just correcting number is not correct. Now this is one condition where you have to be a bit cautious before going ahead and treating that number. Why? Because you have to think in ICU what is the cause for that increase in the heart rate, rather than blindly treating. Or when some cardiologist, with due respect to him, a cardiologist will come, he will tell you start beta blocker, start ivabradine. Ivabradine is very fancy drug. They say, okay, start ivabradine. Don't do that. First you have to analyze why heart rate is more. And most of the time in ICU, you will not require anything to treat tachycardia, because tachycardia is always secondary to something. So whenever you see a tachycardic patient and restless patient, I'll be more worried, because I might be dealing with some unidentified pain. Probably I am ignoring hypoxia, tissue hypoxia, what patient is having. Or might be patient is hypotensive. All the times our monitor, we will have non-invasive BP cuff there. Hardly we check blood pressure in ICU. We have to be very truthful to ourselves. How many times we actually check manual blood pressure in ICU? So that monitor will say BP which was half an hour. If you are set it 30 minutes interval for that BP check, might be in last 15 minutes your patient's BP has dropped, and that might be the cause for tachycardia. So whenever in a doubt, try to see whether you can re-evaluate what is the blood pressure. So never forget that. Then another entity we should never forget in ICU when you see tachycardia is pulmonary embolism. So how do I manage? When I see heart rate, I will reassess my patient and to understand why my patient's heart rate is more. Okay. That doesn't mean that some patient has come after a plasty and his heart rate is 130. Don't say that, okay, Dr. Borauke has said, don't do anything. Now heart rate is 130, I will not do anything. If you don't find any obvious cause for that tachycardia, yes, you have to go ahead and treat that, because particularly in post-cardiac procedure patients, keeping your heart rate low is very, very important, because it's going to increase your cardiac oxygen consumption, and your myocardium is already compromised, and we have done a plasty or some procedure to increase myocardial oxygen supply. So our job is to reduce myocardial oxygen demand. And how can you do that? By reducing heart rate. So only in a special situations we should be able to do it. Then never ever forget new onset myocardial infarction in this subset of patients. Okay, so these things you should keep in the mind. The next common thing that comes in ICU is atrial fibrillation. Now you can look at this ECG. Here, here you can see it's very chaotic looking ECG. Rhythm is very irregular. And I think this is the easiest rhythm abnormality what we see. Now what happens, you should always keep a watch on the monitor, because might be 15 minutes ago rhythm was normal, but subsequently when you actually arrive, you can see rhythm like this. You can see this is R wave. The distance between two R waves is varying. It has no correlation with each other. And if, as I said, that every QRS has to be followed by P waves. Now here there are no P waves. So how to identify AF? First is irregular rhythm. Second is no P waves, no isoelectric baselines, and variable ventricular rate. Now, whenever you are in doubt, always palpate patient's pulse. So how will be pulse here? Pulse will be irregular. So whenever you have to examine patient, that is not that you will not touch the patient and just look at the ECG. And see, taking ECG in ICU is again, a lot of interference will be there, a lot of disturbances will be there, a lot of wires are already there. So you may not get an ideal ECG in ICU. So remember this. So when you look at such ECG, what next you will do, that you should look at the blood pressure. And you should try to understand how long this atrial fibrillation is there. Don't get panic, first of all, in ICU, never get panic. Suppose new onset AF has come, relax. Why AF has come? Try to understand. Second thing, see whether my patient is hemodynamically stable or not. If your patient's blood pressure is 130/70, relax. That means you have more time. Don't jump and do something to this patient. No immediate quadron. Wait. Assess. Okay. This is important. Now, suppose the same patient we have again, along with AF, what we have something, these kind of waves which was not, I'll go back to the previous ECG. Here we are not seeing that kind of waves. In next ECG, you are seeing some fibrillatory waves. So these are fibrillatory waves. So we have to keep in mind that you may sometimes come across such fibrillatory waves as well. Go back. So when I am treating I'll go to the next slide, that is the simplified slide. So look at this slide. First, you see whether patient is hemodynamically stable. If your patient is hemodynamically stable, then probably you analyze what is the reason, try to find out the cause, then you can definitely use drugs. Probably what drugs? Probably beta blockers, again the first choice of drug where you can use metoprolol, you can use oral, you can use IV metoprolol, 2.5 milligram first bolus dose, depending upon what is the potassium levels as well. If your patient is not responding to beta blocker, you can use amiodarone. Now if you look at this, the amiodarone is second line drug. Okay. Now if you look at this chart, which is 2020 AHA guidelines, the first choice of drug is always beta blocker for treatment of new onset atrial fibrillation. Now it depends upon how old your atrial fibrillation is. If your atrial fibrillation is recent and your patient has got hemodynamic compromise where blood pressure is less than 70 or 90 systolic, there you have to think beyond drugs and you have to think about cardioversion. Why? Because this is an emergent situation, you don't have time, you have to do cardioversion, because remember 20 to 30% of the cardiac output is actually given by atrial kick. Now what happens in atrial fibrillation, instead of pumping nicely, your atriums are fluttering like this. So effective pumping of blood through atrium to ventricle is not there. That means your ventricles are not getting adequate blood. That's why your cardiac output is going to drop. And now your patient is hemodynamically unstable. That means you have to increase your patient's cardiac output. And in that, those 20% push by atria means a lot. So there you should have a cardioversion for these patients. And if you are very sure and you have done an echo and you have seen there is no thrombus around, first you should anticoagulate and then you should cardioverse these patients. Now suppose you don't know how long this AF was there, and some previous discharge cards have seen transient AF in between. Then there you have to be a bit cautious before going ahead with immediate cardioversion, probably, or before going ahead with an anticoagulation. So in that cases, anticoagulation is very, very important, because by doing this, sometimes you may dislodge the thrombus, and probably that might be the cause for future cerebrovascular accidents. So this is very important when you are doing some intervention, because first priority in critical care is cause no harm. You have to be very sure why we are doing certain things. Now in the same chart here you can see, if you have got reversible factors like electrolyte imbalance or ventilator dysynchrony or transient myocardial ischemia, or you have volume depleted state, or you have some new onset infection. So you should first treat that as well, along with correction of your atrial fibrillation. Or what happens, you will start a cordron, and then probably after 6 hours it will be sinus rhythm. Then again somebody will come. What is normal scenario? What happens actually in ICU? Somebody picks up AF, then orders for cordron immediately, 150 milligram bolus dose over 10 minutes, followed by 900 milligram infusion over next 24 hours. 3 o'clock somebody has started this, 6 o'clock, 7 o'clock somebody comes, sees heart rate is 50, he comes and stop that cordron infusion. This is a common scenario. Then again morning person will come, he will see again AF has come. Now never ever abruptly stop infusions like this, number one. Second, you can reduce, reassess, recheck electrolytes, and then try to document why you have done that intervention. Secondly, if your AF is persistent, your first, either you can have in AF management two aspects, either you can have rate control, which is very important at that moment, and second is rhythm control. Now both the strategies have their equal benefits and disadvantages. We may not achieve both at the same time. So first priority is control rate, second priority is control rhythm. So by giving cordron, you are trying to control rate. Over the time, suppose you have control rate and you will be shifting to oral cordron after 24 hours, always make it a point to overlap oral cordron with IV cordron. Okay, so when you are using IV amiodarone, remember that at least 6 hours prior to stopping your infusion, you should start oral therapy. Second is rhythm control. Now rhythm control will be achieved only in a cases where patient doesn't have structural heart disease. Suppose I have some patient who has got myocardial infarction in the past. Suppose somebody has got mitral stenosis in the past. There I have to be very sure that I am trying to achieve rhythm as well, but whether this is really possible or not. Why this question is important? Because future therapies. So this is the next slide. What is the future therapy? So what are our aims for AF management? As I already said, stroke management. Don't think about that particular moment only. Then think about rhythm control, access care, disease awareness, and primary prevention. This is very important. So you should tick all these squares when you are treating atrial fibrillation. Don't just think about that particular day. In future, you should evaluate by CAT score what is the risk of future stroke in these patients, and try to put this patient on oral anticoagulants. So this is crime. If you identify atrial fibrillation and your patient is discharged, and if you are not assessed him for future stroke probabilities, probably we are causing more harm, and probably it's more criminal. In a more simplified way, I'll say ABC pathway. A is avoid stroke, optimize stroke prevention. B is better symptom management, treat symptom. C is cardiovascular, other comorbidities, and manage risk factors. So this is 3-step approach what you should have for atrial fibrillation. So this probably the way we look at AF has to be more broadened rather than just looking at that particular day. This is probably a take home what I wanted to get. So 5 domains I have already said, the repetition of same: acute management, manage precipitating factor, assess stroke, assess heart rate, and assess symptoms. So these 5 things you should be able to do. Now very less commonly we come across something called atrial flutter. Now I have already said atrial flutter is neuro-complex tachycardia. The rate is at around 300, and again a loss of isoelectric baseline. But this sawtooth pattern of inverted flutter waves in 2-3 AVF. This is lead 2. Okay. And upright flutter waves in V1. We don't have V1 here. So probably what we have here, rate is very high, and we have something called sawtooth pattern waves. So just to going back again to wide complex tachycardias. So whatever clinical scenario we have in ICU, we can divide that into two. One is stable patient or unstable patient. Suppose I have a wide complex tachycardia and unstable patient in shock, probably that is best to shock him. Okay, so this patient is in shock, unstable, shock him. If you are not able to identify the rhythm, best is to start with 100 joules. If your patient is stable, again sit down and relax. Now this is classical monomorphic Vt with uniform Qrs complexes. Now if you look at the overall rhythm, it's very regular rhythm. Look at here, distance between the peak of two R waves is very regular rhythm. So this is Vt. Now this picture you should copy and paste it in your brain. I don't think any criteria are required to diagnose Vt. Either you know Vt or you don't know Vt. Finished. If you start to apply, take ECG, how is QRS, how much is the QRS duration, where is P wave, by that time you will feel DC. Okay. So you have to act fast. Remember this. This has to be printed onto your brain. This is Vt. Then there is something like this. When you see two kind of ECGs, when you don't know anything, probably three things. When you don't know what is this ECG, very chaotic ECG, or if you print out that ECG and give it to cardiologist and he starts thinking, sometimes it happens, even cardiologist starts thinking, then think of three things. One is polymorphic Vt, second is digitalis toxicity, and third is hyperkalemia. So these three things which puzzle everybody. So in that simplified is polymorphic Vt, because you can see the changing axis. In simple words, forget about axis, see the height of QRS, see here how it is. It's probably revolving around, it's like cloth is been twisted, that kind of, we can see twisted axis. So this is polymorphic Vt, and we call it as a Tors Edipointes. Now why it is important to identify this? Any of such rhythm should never die in the hospital. Vt, polymorphic Vt. You have to act in time. So what happens, what are the risk factors for polymorphic Vt or Tors Edipointes? Remember this: prolonged QTC, use of QT prolonging agents, heart failure, MI, hypokalemia, hypocalcemia, hypomagnesemia, bradycardia. So whatever abnormal things you know of in cardiac patient or in ICU are there. Okay. If you don't know the answer also, most of the things are there. So remember this, hypokalemia. So most bad out of that is hypomagnesemia. So anybody ask you, or whenever you see Tors Edipointes kind of ECG, always think first about magnesium. Because how do I manage? First you should think about giving magnesium. Major drugs, okay. I have given a list of drugs which can cause QT prolongation: quinidine, sotalol, terfenadine, macrolides, very much culprit, fluoroquinolones. Macrolide patient will be on clarithromycin, suddenly patient coming to you, there's a high chance. Patient on azithromycin, still there's a chance. So you have to be aware of these risk factors as well, the drugs which prolong QTC. So recently in COVID, I think we have forgotten to calculate QTC. I think COVID's first 1 month, we were doing that exercise. We were giving chloroquine to every patient and we were analyzing QTC because we don't have any drug that time. So I think after long time we started measuring QTC in all patients. Thanks to COVID, because probably they have taught us basic critical care again. Now here, this is a rhythm where potassium was 1.7. So whenever you see Tors Edipointes and potassium is 1.7, just don't correct potassium. You have to correct potassium along with magnesium as well. Okay? So if you try to correct potassium only, then your patient will again and again will have this polymorphic Vt. So what is this? Any guesses? Anybody? Any guess? This is again the same. This is Tors Edipointes. So what? There's no point. You have not pasted in your brain. This is polymorphic. When you don't know polymorphic, see, look at QRS here, here, here. Every wave is looking different. So different morphology. So what is the protocol? Let's just go back. What is the protocol? Load with 4 grams of magnesium infusion over 1 hour. Okay. Then start 1 gram infusion per hour for next 24 hours. And your target should be 3.6 to 4.9. Now remember, your serum magnesium doesn't correlate with your magnesium levels in that. So what you do, don't say that patient is torse but his magnesium is 4, I will not give magnesium. No. Our aim is first to correct the electrolyte abnormalities. That is the rhythm. So do that. Okay. Then check for serum magnesium levels. Then this is the rhythm. See here you can look, it's a very chaotic, irregular rhythm. No P waves. Qrs complex is also not clearly formed, and rate is around 150 to 200. And varying amplitudes. So when you see such ECG, you are in trouble. So this is VF. Again, ventricular fibrillation, you have to remember this figure in your mind. Very, very chaotic, irregular deflections of varying sizes. So here, there is only one treatment, shock. So whenever you see ventricular fibrillation, first you have to shock it, 200 joules. Now here, I think he has already put diagnosis. In ICU, what else we can see? T inversions in prominent, probably U waves. So what happens, we see a patient coming with breathlessness, we check ABG, then we'll say, oh, PCO2 has gone up, patient has never history of COPD, never smoked, no history of bronchial asthma, and you take electrocardiogram and you see such a kind of U waves. So this is a sign of hypokalemia. So probably this patient had hypokalemic periodic paralysis. We have seen patients where we need to intubate also. How to correct? Correct potassium. Then as already said, whenever in doubt, this hyperkalemia is very bad, because hyperkalemia, now potassium levels well correlate with the ECG signs. 2 more minutes. So whenever you see such a kind of tall T waves on ECG, again QRS broad or varying size, there you have to use an pentatherapy. So whenever you see hyperkalemia, first treat hyperkalemia with pentatherapy. What all the drugs you will give? Give 25% dextrose with actraprid or insulin, regular insulin. Give nebulization with beta-2 stimulant. Give calcium gluconate. And what calcium gluconate actually does, it acts as a shield. What we are using, mask in COVID, same calcium gluconate is a shield to avoid effect of potassium on a myocardial electric circuit. So by just giving calcium, you are not going to stop. Don't feel that you are given calcium now. You have to do some other measures to shift that potassium into the cells. And for that, probably what we need beta-2 stimulant and glucose insulin drip. That's very important. Then to avoid absorption, you can use K-bind enemas or oral K-bind sachets to avoid absorption, and stop all the drugs. Most commonly what happens, diabetic coming with ARBs, diabetics with beta blocker. Now these two categories of patients will have, probably the reason for their hyperkalemia will be drug induced. So always look at the drug chart, what medications they are getting, and stop those drugs, and along with that treat patient. I'll just keep this complete heart block. There is no correlation between, they are like what our present state government is doing, PVO is doing their own work, QRS is doing their own work, no correlation with each other. Similar way, complete heart block, there is no correlation between P and QRS. Probably here you have to intervene fast. That might be a candidate. Cardiologists will be very happy when you call them that you have a complete heart block. If you say first degree and second degree heart block, they will say I will see tomorrow. If you say complete heart block, they will say okay, I am coming. So probably unless patient has got MI, they will say don't thrombolize, I am coming. So probably these are the patients where you have to be very much aware of. We'll just keep that. Thank you. So probably, because this was how do I manage. For first degree heart block, don't do anything, stop drugs. Second degree heart block, evaluate whether it's Mobis type 1 or type 2. Type 2, definitely we have to take a help of our cardiologist friend. And if you have a complete heart block, try to identify whether your patient has got myocardial infarction, inferior wall myocardial infarction or anterior wall myocardial infarction. If your patient has got myocardial infarction, inferior wall with heart block, most of the time, because RCA is a culprit, that supplies SA node. When you thrombolize these patients, they don't require any treatment for complete heart block in future. That's not so for anterior MI. Sometimes you may require definitive treatment for that complete heart block. But maintaining heart rate at that point is important. So there you have to, I have avoided talking about atropine here. There probably you have to use drug called atropine to increase your heart rate. Okay, thank you.
Thank you, sir. Thank you once again, Dr. Kapil, sir, for basically accepting to deliver this speech on 11th hour. If someone has any queries or questions from the audience, if Chairperson, Dr. Seminare, sir, Dr. Shalaka ma'am, if you want to add something.
Extremely elaborate lecture on arrhythmias. Arrhythmias are very commonly seen in ICUs, and we have to be very vigilant as intensivists while we are there and we're seeing this. One basic thing what sir insisted was increasing our bedside time with patients, trying to assess what is the basic reason behind the arrhythmias. And one more thing what sir said about the monitors, it's true that we should sometimes pick up a BP apparatus when we are seeing our patients and try to see it ourselves, what hemodynamics the patient is on, what BP he is on when we are seeing any arrhythmias. Cannot agree less on that. One more thing, Ingole sir, extremely good lecture, and you just talked about one thing, touching the feet of patient when you are assessing a patient. Like yesterday, I had one patient with mitral stenosis and operated replacement done. She was admitted in ICU outside, complained of severe leg pain and was referred to our radiology department for a MRI LS spine. Actually, she came to the casualty because she had very severe pain. We saw her pulsations and pulsations were absent. Laris syndrome was there. We thrombolized her. So as both these solvers have already told us, it's very important that we clinically assess our patients, whether it is our OPD patient or whether it's an intensive care patient. Thank you.
Thank you, ma'am. Thank you, sir. Now I would like to request Dr. Khature, sir, a consultant physician, to come on the dais and felicitate Dr. Kapil Borake, sir. First, I would like to request Dr. Khature, sir, to felicitate Dr. Shalaka, ma'am. This is our Meyer MID's tradition to felicitate with giving a shawl, a National Mawali photo, and a memento. I request Dr. Khature, sir, to felicitate Dr. Sambina, sir. Thank you, Shalaka ma'am. Thank you, Nanawe sir. Now I request Dr. Khature sir to felicitate Dr. Kapil Borake. Thank you, sir. We'll move forward to our next lecture. Our next lecture is on my patient drop urine output and develop kidney injury and how do I manage, by Dr. Mahesh Rokade, sir. For this session, I would like to invite on the dais Dr. Ketakumba, sir, to moderate this session. Please, sir. Welcome, sir. Dr. Ketakumba, sir, has done his MBBS, BMS and MD from Sumatibai Shah Ayurvedic Mahavidyalaya, Pune. He is working since last 8 years and is the director of Space Hospital in the Loni Kalbor. Welcome, sir. Now I would like to request Dr. Satish Sarode to come on the dais for moderating this session. Dr. Satish Sarode has done his MBBS, MD Anesthesia from Tata Institute of Cancer, Mumbai, and did his FNB Critical Care from Dinanath Mangeshkar, and he is working as a Chief Intensivist in Vishal Hospital since last 2 years. So we'll move forward to the next lecture part. I would like to request Dr. Mahesh Rokode sir to deliver this lecture. Actually, Rokode sir is not feeling well since yesterday, but still he has came forward that yes, the show must go on. And once again, a big applause for Dr. Rokode sir for delivering this lecture. Over to you, sir.
Good afternoon, everybody. Today I'll be talking about acute kidney injury. See, why is acute kidney injury important? Because we see that in hospital admissions, almost 5 to 7% of all the admissions are due to acute kidney injury. But the same number, when we see all the ICU admissions, it is almost up to 50 to 70% of those patients are suffering from AKI. Usually most of these patients are a part of multi-organ dysfunction. So it is not only acute kidney injury which we are going to commonly see in ICU patients, but what makes it more important and why we should be going into details of acute kidney injury is the mortality rate. When we see patients of acute kidney injury which are routinely admitted in the ward, the mortality rate is only 10%. Whereas if we see the patients in the ICU, the mortality rate is as high as 50%. And if the same patient goes on to receive any form of renal replacement therapy, the mortality rate may go as high as 80%. And that is why it is very, very important to identify acute kidney injury at an early stage. The best way to treat acute kidney injury is to prevent it rather than actually treat it. So what is the definition of acute kidney injury? Hello? Acute kidney injury initially was called as acute renal failure, and it is a clinical syndrome denoted by abrupt decline in GFR leading to decreased elimination of the nitrogenous waste products, that is urea and creatinine and other uremic toxins. Also, it leads to inability of the kidney to appropriately regulate the fluids and the electrolytes homeostasis. And there have been a lot of attempts to exactly define what exactly is acute kidney injury and what are the various stages of acute kidney injury. So there have been attempts by the Acute Dialysis Quality Initiative, which is ADQI, and there was another AKI network also. And there were various classifications of the acute kidney injury which came into play. The first which came into play was the Rifle criteria, which where R is risk, injury, failure, loss and end-stage renal disease. And Rifle was the criteria where they determined the decrease in the GFR primarily. The creatinine increase was, R was, which was risk, where there were two criteria. One was the creatinine or the GFR criteria, and the second was the urine output criteria. In the creatinine criteria, the risk was when the creatinine increased by 1.5 times of normal or the GFR decreased by 25%, and the urine output criteria was when the urine output dropped to less than 0.5 ml per kg per hour in subsequent 6 hours. Injury was when the creatinine increased to 2 times of normal or the GFR was declined by 50%. And urine output less than 0.5 ml per kg per hour for more than 12 hours duration. And failure was when the creatinine increased by 3 times of normal, or there was a decline in the GFR of more than 75%, and the urine output was less than 0.3 ml per kg per hour for more than a day, or there was a complete anuria for 12 hours. The acute kidney injury, or the AKIN criteria, they had made slight changes. In this, the loss and end-stage renal disease part of the rifle criteria was completely removed. The creatinine criteria was more or less the same stage, but it was instead of RIF, it was converted into stage 1, stage 2, and stage 3. And the creatinine was, we can see in this figure that the creatinine rise. Is the slide clear, or it is blurred slightly? Blurred. Or the creatinine criteria was a rise in the creatinine of more than 1.5 times in stage 1, more than 2 times in stage 2, and more than 3 times in stage 3. Here it is important to note that patients who needed renal replacement therapy, irrespective of the creatinine criteria, were considered in stage 3. The urine output criteria remained the same as the rifle criteria. Similarly, there KDIGO also came up with their criteria, and which was more or less similar to AKIN criteria. The urine output criteria was also similar. Whenever we are dealing with patients with acute kidney injury, we need to first try to identify whether the patient is oliguric AKI or non-oliguric AKI. So there are certain definitions for that. Whenever the urine output drops to less than 400 ml in a day, it is considered as oliguric AKI. If it is more than 400, it is considered as non-oliguric AKI. And if someone is having urine output of less than 100 ml in the day, the patient is considered anuric for practical purposes. Now, in this figure of etiology of AKI, it looks like a very fancy figure, but if you try to classify the causes of acute kidney injury into 3 types, it becomes very easy. It has been classified as either pre-renal AKI, renal AKI, or the intrinsic AKI, and post-renal AKI. Now this figure starts making sense. See, in pre-renal AKI, either you are dealing with actual volume loss or hypovolemia, or if decreased effective arterial blood volume. So actual blood loss or actual volume loss, as in the case of dehydration due to any reason, or decreased effective arterial blood volume, as in the case of congestive cardiac failure or in liver cirrhosis. We are primarily dealing with patients with pre-renal AKI. The major chunk, which is the intrinsic or the renal AKI. In the kidney, there are 3 compartments. One is the glomerulus, second is the tubulointerstitial compartment, and the third is the vascular compartment. So, based on what involvement is there, it is going to be the cause of the acute kidney injury. So, primarily, if there is glomerular AKI, we are dealing with patients with acute glomerulonephritis. Like whenever we are seeing patients with ICU, patient has reasonably good or higher blood pressure, but sudden onset shutdown in the kidney. And if you see the urine routine of such patient, you see proteinuria, then you see RBC CASP, then RBCs are also there, then you should start suspecting some glomerular disease is there in such patients. We'll be coming to details of that in subsequent slide. Then tubulointerstitial compartment also. In the tubulointerstitial compartment, the primary cause can be either acute tubular necrosis or acute interstitial nephritis or intratubular obstruction. Intratubular obstruction can be because of cast nephropathy, drugs, or crystalluria. ATN can be because of several things. Either it can be drug induced, it can be because of ischemia, it can be because of rhabdomyolysis, or even radiocontrast agents which are commonly used. Acute interstitial nephritis again can be because of drugs, infections, or systemic diseases. The glomerular diseases which I just mentioned, either it can be HUS TTP kind of thing, anti-GBM disease, then lupus nephritis, or post-streptococcal glomerulonephritis can be there. All these can present like rapidly progressing GN. So RPGN is the subset of patients which will usually present in the ICU with sudden renal shutdown, directly requiring renal replacement therapy. And if we consider the vascular compartment, again, the thrombotic microangiopathy primarily will come under this compartment also. So if there is a small vessel disease, we can see either renal embolism or small vessel vasculitis may lead to AKI, and major vessel occlusion, that renal artery occlusion or large or medium vessel vasculitis, may lead to renal failure or acute kidney injury because of vascular involvement of the kidney. Then post-renal involvement is very easy. Anything outside the kidney, usually leading to causing obstruction, is post-renal. So this can be because either, let's start right from the pelvis. So if there is a bilateral staghorn calculus causing significant obstruction and patient is anuric, it is a post-renal. Similarly, if you have a bilateral ureteric obstruction, or lower down if there is a bladder outlet obstruction either due to an enlarged prostate or simple urethric stricture also can lead to bladder outlet obstruction. So all these will be due to post-renal acute kidney. All this will be post-renal acute kidney injury. So now that we know that acute kidney injury is so important, it is, and as I told you before also, that the best way to treat AKI is to prevent it. And for that we should have a very high index of suspicion. We should be proactive, try to find out if the patient is going into AKI, and also diagnose the patients with AKI early so that we are able to take corrective steps at an early stage. So understanding the etiology is also important, as different etiologies, as we just saw, that whether it is a pre-renal, renal or a post-renal. So it is very important to identify the etiology of the AKI so that we can treat the patient accordingly. And at times there can be patients who are already having chronic kidney disease and patients are presenting with acute over chronic kidney disease. So it is very important to identify such patients also. This usually is important because for prognostication also, so that we can know that this patient is not going to recover completely. Second important thing is fluid management may be important in such patient, because if the patient is having chronic kidney disease, it is important, it may be that this patient may be having fluid overload already. So fluid management needs to be changed in such patients. So all in all, our approach to diagnose AKI should be early detection of AKI, sorting out the etiology and establishing whether it is a simple only AKI or acute over chronic kidney disease. So mainly early detection is important in high risk populations, and this high risk populations are the patients which are already there in the hospital, like patients who have recently undergone a post cardiac surgery or a vascular surgery or any major surgery, patients who are in the hospital who have recently received contrast agent for some important investigation, or the patient who has come into the hospital in the ICU following a severe trauma. Blood urea and blood urea nitrogen or creatinine usually start rising very late in the course of acute kidney injury. So we need to have some marker which is going to diagnose this kidney injury very early in the stage, even before the kidney, the creatinine and urea starts increasing. So what is an ideal biomarker? So an ideal biomarker is something which causes rapid and reliable increase in response to kidney disease, which is highly sensitive and specific of acute kidney injury, which shows good correlation with degree of renal injury, which provides risk stratification and prognostic information, like which patients are going to need dialysis or the severity of the kidney disease. Sites specific to detect injury also is important, and identify pathological changes in specific segments of renal tubules, applicable across different races and age groups. So here we can see that commonly used serum GFR markers, which we use in day-to-day life, like urea, creatinine are already used. These are also biomarkers, but these do not have the sensitivity or specificity to detect kidney disease early in the stage of or early in the course of the illness. So There are certain glomerular injury markers and there are certain tubular injury markers specific for detecting injury to the proximal tubule or specific to detect injury to the distal tubules. And mostly used in the in the practice are urinary tubular injury markers. And the primary role or the use of these biomarkers is primarily in patients who have undergone cardiac surgeries, primarily to detect course of the kidney failure early, very early, so that we can predict which patient is going to need dialysis, where you should go very aggressive about diuretics, and where we should be preemptively hydrating the patients. So the novel biomarkers for acute kidney injury which fit all these criteria and which are commonly being used in clinical practice are the NGAL, kidney injury molecule 1, interleukin 18, cystatin C, and the L-type fatty acid binding protein. So these are the common novel biomarkers for acute kidney injury. Here, if we look at this NGAL, see, whenever there was, this is a patient of cardiac bypass, and immediately within 3 hours, the NGAL levels started rising, where there was AKI. And when there was no AKI, the level, see, this is the AKI threshold. So it has increased significantly within 3 hours of surgery, whereas there was no AKI, it hasn't increased much. So such should be the role of the biomarker, where it can tell us which is the patient who is going to go into severe AKI, where we can anticipate dialysis therapy. Similarly, where I mentioned that urinary biomarkers like insulin-like growth factor binding protein 7 or tissue inhibitor of metalloproteinase 2, these also are very sensitive and specific to predict moderate to severe AKI within 12 hours. Just give me. So as I just now mentioned that early diagnosis is important. How should we work it out based on the etiology? So obviously the questions which we should be asking should be trying to find out what is the etiology of AKI. So first thing we should be trying to find out, is this only AKI or acute and chronic kidney disease? Then if trying to find out whether it is just pre-renal, we should try to see if there is a true hypovolemia. Is there any history of volume loss? Is there any history of any blood loss? Is there any history of, say, abdominal trauma where we can suspect some loss in the blood, in the abdomen? And whenever we are dealing with patients with congestive cardiac failure or liver cirrhosis, where there will be decreased effective arterial blood volume. So these are the patients primarily pre-renal, having pre-renal AKI. Then for the intrinsic renal failure, we should try to find out if there is a major vascular occlusion, or is there any clinical scenario where there can be acute tubular necrosis, where there is a significant hypotension or a significant volume loss for a prolonged period of time which has not been corrected. So such patient now may not remain pre-renal AKI, they have gone into acute tubular necrosis. So we should initially give fluid challenge to these patients. But if despite give a good amount of fluid challenge, the patient is not responding to even boluses of diuretics, then we should identify that this patient has already gone into acute tubular necrosis, and we should stop the aggressive fluid management at that point. And post-renal AKI is usually very easy to identify because nowadays, even before a urine routine is done or urine routine report is available, a sonography is already done and the report is in the hands of the consultant. So any obstruction usually will not be missed on a sonography. So post-renal AKI, a simple history and ultrasound will be enough to guide us. Then the good old physical examination, which nowadays is not in our busy practices, is not, we are not looking, having a thorough general examination. So it is very important to have a quick, rapid general examination where we can get small clues which can lead us to the diagnosis of acute kidney injury, or at least give us a hint. For example, when we are looking at a patient, either a very young male or a very young person or a very old person with a palpable purpura, it can point towards the diagnosis of systemic vasculitis, where we are suspecting diagnosis of allergic interstitial nephritis, where there is a history of recent drug ingestion, a maculopapular rash. It may give us a hint towards that diagnosis. Then presence of uveitis may again indicate the syndrome of Tinu syndrome, again, which is very rare, but we should start looking at signs. Hearing loss may lead to Alport's, hearing loss may indicate towards Alport disease and aminoglycoside toxicity. And other systemic examination is also important because in the ICU, it is very important to, or right in the start, in the casualty also, it is very important to see if the patient is volume overloaded already before we start or decide fluid boluses for that patient. So it is very important to see the pulse, along with the pulse oxygen of the patient. It is very important to see if the patient is having bilateral crepitations in the lungs, and if it is justifiable to load the patients with huge volumes of fluid right away in the casualty. Then other things like cardiovascular examination showing murmurs or pericardial friction rubs, S3, which may indicate heart failure. All this should be important in the diagnosis of the or the treatment of the acute kidney injury. Another important thing I would like to make a point here is whenever you are suspecting having a patient with fever, high grade, and giving a history of low urine output, there you should always suspect if the patient is having any pyelonephritis. So you should always check for renal angle tenderness in these patients and see if there is any evidence of pyelonephritis, which can be subsequently confirmed with the help of either a CT, KUB or sonography. Another important thing which can be missed is a distended bladder, because many a times patient comes with a history of anuria, and our first knee-jerk reaction can be either load the patient with fluid or give Lasix. But we also need to see that if the patient has got bladder outlet obstruction and acute urinary retention. So simply palpating the bladder, especially in elderly population, where we can see that the patient had no classical history where we can think that this patient can go into renal failure, like no history of diarrhea, no hypotension, nothing is there, but suddenly patient relatives come with that this patient hasn't passed with urine for 12 hours or more. So such patients we can palpate the bladder, try to see if there is a distended bladder, and rule out urinary obstruction. Okay. See again, urine routine normally is again just now I mentioned that urine routine examination is not routinely advised. Sonography is directly advised, but small things which we can see and can give us indicators of acute kidney injury or the etiology of the acute kidney injury. Like if we see RBC cast, it can either give us an pointer towards either vasculitis, TMA, or malignant hypertension. If you are seeing WBC cast, either it can be a case of acute pyelonephritis or acute interstitial nephritis. And in acute tubular necrosis, you can see classical brown muddy casts. And eosinophiliuria again can be seen in acute interstitial nephritis. These are a few examples or figures of showing classical casts in the urine examination. Before we when we see patients with high urea nitrogen levels, we should, other than dehydration, you should also see that if you see very high urea values which are not responding to fluid, you should also see that many a times patients with septic shock, they are receiving low dose steroids, or some patient is there who is having an upper GI bleed. So these may be some reasons which are responsible for high urea, and continuously high urea if you are seeing and which is not responding to standard treatment, then you should see if there is other things like upper GI bleed or steroid use, or if the patient is hypercatabolic, continuously having high fever, or if the patient is on very high protein diet also. Increased creatinine may be seen in patients with large muscle bulk, rhabdomyolysis, or reduced tubular secretions who are due to drugs which are like cimetidine or trimethoprim. Decreased creatinine doesn't necessarily mean that the patient's kidney function is well preserved. You can see a low creatinine in a, like if you can see a patient with creatinine 2.5 or 3, but if you actually calculate the GFR of the patient, his GFR may turn out to be just 15 or 10. And this classically is seen in patients with who are very thin and frail, elderly ladies who are weighing hardly 35-40 kgs. So low creatinine may be there in this patient, but there may be significant amount of kidney injury. This may be true for both acute kidney injury as well as CKD. In diagnosis, renal biopsy is usually reserved for patients with renal failure, classically acute kidney injury, where you are not getting the diagnosis. That is one thing. But usually biopsy is not resorted to straight away. Whenever you have a kidney failure and you are suspecting acute tubular necrosis, usually we wait for 2 to 3 weeks, and if despite 2 to 3 weeks there is no renal recovery, a biopsy is done. Or if we are suspecting directly vasculitis or thrombotic microangiopathy or severe rapidly progressing glomerulonephritis, then straight away kidney biopsy can be done to diagnosis for diagnosis of that etiology of the acute kidney injury. Now, normally for all the things of acute kidney injuries or for CKD also, there are guidelines being issued by KDIGO, and there are very subtle, very specific things which are being told by KDIGO, which we sometimes are not following in our day-to-day practice. And I'm going to take you through few certain guidelines specific for acute kidney injury. One thing we all know that there is no specific treatment for majority of AKI, rather than only thing is you should manage the specific treatment. Like if it is pre-renal, manage it by fluid volume, resuscitation, etc. So second important thing is elimination of nephrotoxic agents. Like you should, whenever we are finding a patient is having AKI, then we should first assess if the patient is taking any nephrotoxic drugs like ACE inhibitors, ARBs, whether he is receiving any aminoglycosides, amphotericin B or NSAIDs. That should be eliminated from the prescription of the patient. Then second thing is we should be quick enough to identify which patient is going to be managed conservatively and which patient is going to require renal replacement therapy. And wherever indicated, we should start renal replacement therapy in these patients. And in absence of hemorrhagic shock, KDIGO suggests using isotonic crystalloids rather than colloids. So there was initially a lot of debate that which IV fluid should be used as a fluid resuscitation. Simple normal saline 0.9% can be used for fluid resuscitation. Only if there is a problem with hyperchloremic acidosis, then we can think of a buffered plasma light can be used. And there is no added advantage of using albumin. Mainly, there are no, the trials have also not suggested that there is patients receiving albumin or other colloids, they have lesser incidence of renal failure or lesser incidence of mortality. And isotonic crystalloids should be used, and in certain situation colloids should be added to these patients, but colloids cannot be the primary fluid for management of shock. Then KDIGO recommends the use of vasopressor in conjunction with fluids in patients with vasomotor shock with or at risk for AKI. In critically ill patients, KDIGO suggests insulin therapy targeting the blood glucose level between 110 to 149 milligram per deciliter. Then KDIGO suggests achieving a total energy intake between 20 to 30 kilocalories per kg per day in any stage of AKI. And this last thing is very important. It avoids restriction of protein intake with the aim of preventing or delaying initiation of RRT. Whenever you are dealing with AKI, never restrict protein. Protein can be given normally. In fact, if you are dealing with patients who are hypercatabolic or patients who are on CRRT, the protein should be increased as high as 1.7 gram per kg per day. And patients on intermittent hemodialysis should be receiving protein between 1 to 1.5 gram per kg per day. Then many a times diuretics are started as a knee-jerk reaction even when there is no indication. Diuretics role should be used only for hypervolemic AKI. Otherwise there is no role of diuretics. It does not prevent AKI. It does not prevent the need for dialysis. Then all these fancy things which were tried, low dose dopamine, phenyldopan, ANP, recombinant human growth factor, none of these have been useful in preventing or treating AKI. Similarly, contrast-induced AKI, we should identify high-risk patients with pre-existing CKD, diabetes mellitus, old age, advanced congestive cardiac failure, and patients who are going to require a procedure where high dose of contrast media would be necessary, and patients with hemodynamic instability. And in such patients, first thing you should try to see if any alternative imaging method is possible. If not, you should use the lowest possible dose of contrast medium or use a isoosmolar or low osmolar non-ionic contrast media. Only thing which has been proven which is of proven benefit to prevent contrast-induced nephropathy is giving isotonic sodium chloride or sodium bicarbonate solution. Oral hydration is not sufficient, and another thing which is important is using N-acetylcysteine. N-acetylcysteine can be given oral, but IV hydration is important. IV hydration should be at least 1 ml per kg per hour, to be started at least 12 hours before the procedure and to be continued for 12 hours after the procedure. And again, there is no role of using hemodialysis to remove the contrast agent. The contrast agent is not completely removed, and even if you are doing dialysis, it is not going to prevent the renal failure. So if someone has to develop acute kidney injury because of the contrast agent, doing dialysis after giving contrast is not going to help. So it should not be a standard practice. This is the... So most important thing is aggressive hydration, minimizing nephrotoxic, and maintenance of adequate mean arterial pressure. When dialysis is required, one is if there is severe metabolic acidosis with a pH less than 7.15, whenever there is severe hyperkalemia which is having ECG changes or hemodynamic instability, whenever we are suspecting poisonings, whenever there is fluid overload which is refractory to diuretics, and whenever we are actually finding signs of uremia. So these are specific and acute indications for dialysis. The modes of dialysis are either use intermittent hemodialysis or slow low efficiency dialysis or continuous renal replacement therapy. PD also is a useful tool where that can be used usually in periphery or where cost is a factor. Intermittent hemodialysis usually is cost effective. Then small solute removal in acute life-threatening situations is there, where and it can be done heparin free. So wherever there is risk of bleeding risk or acute hyperkalemia.
Excuse me, sir. Sorry to interrupt. So we have 2 minutes because of time
Yeah.
constraint. Okay. Sir.
Just 1 minute left. This last slide I'm going to say. First, vascular access for renal replacement therapy. First choice should be always right interjugular vein. Second choice should be a femoral vein, either femoral vein. Third choice should be left jugular vein. And last choice should be a subclavian vein, because there is a very high chance of subclavian thrombosis. Thank you. Sorry for overshooting the time.
Thank you very much, Dr. Sir, for the elaborative lecture. As sir mentioned, the kidney is very notorious organ. We see the create levels actually, and when the creat is less than 1.2, less than 1, that we think that the patient is not having AKI. But we also see the trend also when the patient is having creat of 0.5 only, and the change is by 0.3, that is also called as the AKI. Okay. So thank you for the lecture, sir.
Excuse me. Yeah? Sir has some queries.
What is the role of creatine albumin ratio in diagnosis and prognosis?
Urinary albumin creatinine ratio. No, there is no role for diagnosis. That will just tell you presence or absence of proteinuria or the extent of proteinuria. So it is not going to be helpful in diagnosis of AKI. See, in AKI we are primarily interested in knowing if there is a decline in the kidney function. So this is going to just tell you if there is presence of proteinuria or absence of proteinuria. It was asked in the diagnosis of AKI, actually, because you can have proteinuria in the absence of renal failure also.
Any biomarkers to differentiate acute from acute on chronic, or any specific test? Spot test.
Is there any biomarkers that can differentiate between AKI or AKI on a CKD? Any different biomarkers are there in these two categories?
No, I am not aware of that.
How to differentiate? Yes, it is acute or it is acute on chronic?
See, usually chronic can be diagnosed if we are dealing with a chronic kidney disease patients. See, biomarkers role primarily is there, and it has been studied primarily for patients who are undergoing cardiac surgeries, where we want to know beforehand, like as early as possible, the severity of AKI. So that one slide which I had shown, within 3 hours that NGAL level is rising. So that is going to tell us the severity of AKI. Second thing, it is going to help us to identify whether we have to be aggressive in fluid management, maintaining the maps of the patient. Then also we should be preemptive in starting dialysis for such patient. Chronic kidney disease, usually you are going to have a prior history of that patient. The sonography is going to help us if there is shrunken kidneys are there, or if a pre-existing proteinuria is there. So to diagnose CKD, that much is sufficient. See, and biomarker main role, the idea of a biomarker is to identify acute kidney injury early in the stage so as to take fast action in the management. So basically, I don't see there should be any role of biomarker in trying to rule out CKD, because that can be identified by other simple tests also.
Thank you, sir. I would first like to thank Dr. Mahesh Rogade, sir, that he is not feeling well since yesterday, but despite of that, he continued to give a lecture. Actually, we tried to intervene 2 times, but he just continued his lectures and finished the part once again for his passionate speech. I would like to request Dr. Sushant Shinde sir, our head of the department, Emergency Medicine and Medicine Department, to felicitate Dr. Satish Sarode sir first. Chairperson. I would like to request Dr. Sushant Shinde sir to felicitate our next person, Dr. Ketan Kumba sir. Thank you, Ketan sir, Dr. Satish for moderating this session. Now I would like to request Dr. Sushant sir to felicitate Dr. Mahesh Rokade sir. We will finish this session over here. I request Dr. Satish and Dr. Ketan Kumba sir to be seated on a sofa. It's time for the inauguration program. I request Dr. Kabir Borake sir to convey about inauguration. Sir. Over to you, sir.
Thank you, Dr. Rokade sir, for a very illustrative lecture. For next 15-20 minutes, we'll keep our inauguration ceremony as short as possible. See, the entire thought process of starting Vrh Gyaan is to probably dissemination of knowledge or sharing of experiences and sharing of knowledge. And in our culture, all this probably we are trying to lamp the light in, or we want to ignite the young minds for future development. That's the entire theme on which this Vrh Gyaan has been started. So we will have today's inauguration ceremony with the lamp lighting. It's my pleasure to have here the dignitaries which have traveled from Solapur, Akuluz, Baramati, and it's our pleasure because see, whatever dignitaries we have chosen for today's program over the time, over last 10 to 15 years, they have proved that it doesn't matter where you are working, which area, which part of or which district, which taluka you are working. If you are passionate enough to work towards your specialty, what you can achieve. So I think big round of applause to all our guests of honor and speakers. I'll request all of you. First, I'll request Dr. Nirmal Taparia sir to be on the dais. Dr. Nirmal Taparia sir has come from Solapur. He is head of the Department of Critical Care of Ashwini Hospital, an experience of more than 20 years. Welcome to you, sir. It's a pleasure to welcome Dr. Ganesh Boke sir from Baramati. He's got huge hospital, seeing more than 100-150 patients every day, still keeps on smiling and managing all types of difficult to treat patients, ICU patients, single-handedly. Third, I would like to welcome Dr. Nitin Rane sir. He's the director and owner of Apex Hospital from Akuluz. Again, probably an Akuluz is a medical hub where most of the places, around 150 villages across Akuluz are connected. He has also devoted his time to critical care as a specialty and always interested into academic programs. So, welcome you. This program would have been not possible without support of Indian Society of Critical Care Medicine Pune branch. As been rightly said by Dr. Abhijit Deshmukh sir that before critical care started anywhere in India, Pune is the city where first critical care started in India. and father of critical care we call Dr. Shirish Prayag. He has started critical care in 1992 as a first critical care. Actually, it is called Society of Critical Care Pune that time, but later the name was changed as a first city branch of Indian Society of Critical Care Medicine, Pune branch. And without support, when I asked Dr. Abhijit that we want to have such academic program, within less than a minute he said, go ahead, we are always there with you. So it's a really pleasure to be associated with ISSM Pune branch. I welcome Chairman of ISSM Pune branch, Abhijit Deshmukh sir, on the dais for this program. We have with us Dr. Khalid Khatib sir, who is the secretary for ISSM Pune branch. Welcome you, sir. See, without these dignitaries, all this would have been never possible, because when we try to plan something, what we all need is support and finance to run such shows. And with these ideas are many, but to cultivate this idea and to make it happen, actually, we need a support from our own hospital's management team. So I'm really thankful, Dr. Vikram Agrawal sir, that he has supported us, and without his approval for budget, this program was absolutely not possible. So big applause for him as well. Because we will think a lot, but I may think of buying a plane, but it's not possible. So this is all made possible with the dignitaries on the dais, and I'm really lucky to have such a big people with me for today's program. And I hope probably this will be a new beginning for Vrh Gyaan program. What we want to achieve ultimately is the dissemination of knowledge. So I really thank all of you and thank for being in the dais. Over next 10 minutes, our program schedule will be, we will have first lamp lightning by our dignitaries. Then we will have our Vishwa Shanti prayer. Then I will request Dr. Nirmal Taparia sir to deliver his speech on his experiences over last 15 years, how difficult it was. When he first landed to Solapur, critical care specialty never existed in Solapur. From there, he has traveled till today's day. And it's very proud to say that it's very inspiring to all of us that being in Solapur, he was not just happy being a head of one intensive care unit, but over the years, I remember him 5 years back studying after whole day's work throughout the night, and he has cleared his EDIC exam, I think 4 years ago. Am I right? So I think at this age, he has this much gist for a knowledge that, and he has showed that nothing is impossible when you decide. So pursuing European Diploma in Critical Care is not easy, and I think he's the first from Solapur district to pursue European Diploma in Critical Care, which is a very big achievement, and still very humble. When you can talk with him during lunchtime, you will realize that. So I think first I'll request all the dignitaries to proceed for lamp lightning. Now I am in a role of anchoring. So let this Vrh Gyaan will help to enlighten each other like these lamps, and probably we will share our experiences, and probably we will be much more wiser in coming days. Dr. Shalaka madam. I will request Dr. Tabrez. Yeah, I'll request Dr. Vikram Agrawal sir to first felicitate our guest of honor, Dr. Nirmal Tapadia sir. Thank you, sir. I'll request Vikram Agrawal, sir, to felicitate Dr. Ganesh Boke, sir. So after these two felicitations, I'll request all of us for Vishwa Shanti prayer. Thank you, sir. So I request all of you to please stand for the prayer.
नमो जीयाद्या वेद प्रतिपाद्या जय जय स्वसंवेद्या आत्मरूपा देवा तूचि गणेषु सकलार्थमतिप्रकाशु म्हणे निवृत्तिदासु अवधारि गोदी गुरुर्ब्रह्मा गुरुर्विष्णु गुरुर्देवो महेश्वरः गुरुः साक्षात् परब्रह्मा तस्मै श्री गुरवे नमः। पूर्णमदः पूर्णमिदं पूर्णात् पूर्णमुदच्यते पूर्णस्य पूर्णमादाय पूर्णमेवावशिष्यते। ॐ शान्ति शान्ति शान्तिः।
Thank you. This is a vision of our patron Vishwanath Karar sir ji. Entire life he has been devoted to education and for world peace. And those who have not yet visited the largest world peace dome what we have in our MIT, I'll request to definitely have a visit to this world peace dome. Now I'll request to cut it very short, I'll request Nirmal Taparia sir to please enlighten us about your journey of critical care over last so many years. Over to you, sir.
Okay. Good afternoon, everybody. First of all, thanks for inviting me to this CME by IICCM Pune branch, my friend Dr. Kapil Burake and the organizers. I am very glad to be here. Now, when I had a call from Kapil, first I was stunned that somebody coming from the periphery for an inauguration in Pune is something which does not usually happen. तर मी त्याला विचारलं की बाबा गंगा उलटी कशी काय वाहते आज, म्हणजे व्हॉट्स द why are you calling me here basically? And then he said he's a very good gentleman, he's a doctor, he's a very good doctor, and we have an association since long. So he said, I want you to come here. And since I have worked a lot in ICUs, because critical care is my passion, since my residency days, I was very fascinated by critical care. And right from the day I completed my MD, I have been in this critical practice. So I have seen all the journey. I have developed the, not I, we as a team in our Ashwini Hospital have developed the ICUs. Now to begin with, all of you know that according to the guidelines, we have levels of ICU. Level 1 is there, 2 is there, 3 is there. So after struggling for these 15 years, at the best we could develop level 2 or slightly something more than that ICU. Now to run a successful ICU in a hospital, not just cubicles or not just glass doors and you have monitors and all sounds and full AC, that does not make an ICU basically, that makes an structure of the ICU. So teamwork is required. Basically you have your intensivist, you have doctors, then you have your medical staff, you have paramedical staff, you have laboratory, you have microbiology team, you have a radiology team, and this, when it works in tandem and when it works together perfectly with an understanding, that gives the best output. My seniors, when I went there, they were old physicians who were practicing medicine for years, and that time we had critical patients. Okay, we had one 10 to 12 bedded single ICU in the ground floor where all the patients were kept. It is medicine, it was cardiologist. We did not have super specialists in those days. They were just incoming actually. The concept had just started and they were percolating in Sholapur one by one. So physicians used to manage all the critical and ICU patients. Even today they do. But it was a single ICU, medicine, surgery, gynecology, then you have complicated cardiac patients, nephrology patients, so 10 to 12 beds were there. In the name of ICU, we had cubicles, we had monitors, then we had oxygen, and at the most we had X-rays and ABGs. Cultures and all these newer gadgets were out of question in those days because we did not have the flow either. And we started to work there. We used to work there for hours together. I was on duty there, and then as the patients came, we worked. We used to upgrade ourselves. We used to upgrade the knowledge. We used to see the patients clinically. We used to treat them. We used to understand how to run the ventilators, how to do an ABG, because at that time doing an ABG was just when the patient was gasping, and putting the ventilator was towards the end basically, when we know that nothing could happen. We used to put a tube and take the patient on the ventilator. As the patients increased, as we understood the ICU concept, as we were going to the conferences and as we learnt about the critical care from the critical care books, we expanded our ICUs from a single ICU to a unit specialty, and ICUs of every system we can call it as. We had then respiratory ICUs, neurology ICUs, cardiology ICUs, PICU, gastroenterology ICU, okay, and separate medical ICU. All were around over the years. Each is about 10 to 14 bedded ICU. At present, we have some around 70 to 80 beds of ICU in our hospital. So then the question came, just letting in the beds and letting in the patients does not work actually. We need to treat patients and we need to deliver results to the critical care patients, and you just cannot do whatever you think is best at that time. So we again learned the process, we learned the protocols, we learned the guidelines, we learned for each and every system. We trained the staff, we trained the housemans. Housemans, we don't have registrars or post-medical students there. Last 3-4 years, I think we have that IDCCM diploma in our institute. So we have students, we have post-PG students also. But at that time, we did not have this benefit. Then we used to have BMS and BHMS housemen. We used to have non-BSc nursing staff. To train them was easy, but to get the work done from them was very difficult actually, because they used to understand to a limit. Out of the limit, they did not understand because the necessary knowledge and the insight of medicine was not there in them. So we used to take rounds. I used to take very frequent rounds. In those days, when my OPD was still at the initial phases, I remember every 4 hourly, every 5 hourly, I used to go to the ICUs. At night, between 12 to 1, I used to go to the ICUs. In the early morning, just to see the patients clinically and just to see whether nothing is being missed out. Since the input they give to us, even today, okay, are not best of the inputs. Today we have gadgets like WhatsApp. We can get a video of the patient with a video of the patient of his condition basically. But in those days, only phone call was there. When I started, there were pagers actually. So we used to have just messages and then phones. We used to see the patient personally there, because what for our houseman, what was a patient respiratory arrest or a patient going into sudden hypotension and shock, many times it used to turn out to be a pneumothorax. Many times it was a simple tube, ETT tube block basically. But when I used to go there and see the patient and attend the patient, that time I understood that critical care is not just writing the orders and just maintaining the patients and just giving all the connecting the patient to the machines and just giving the best of investigations and drugs. It is someone who needs to stand there and monitor whether the things are going properly, appropriately, and in a way the patient is requiring. Second problem in our area is our economical problem. Solapur district is an economically backward place. People there are not very affording. ICU treatment needs lot of investment. It needs lot of drugs. It needs money for the treatment basically. Most of our patients cannot afford that. After 3 to 4 days, they say, "Ki, sir, we cannot afford this treatment." Leave apart shifting the patient to another higher center. We just could not maintain the patients there. So what I thought, or what we thought, was to devise some way where the patient should be managed, they should be treated, and the cost should be low basically. As a clinician, I have been developed as a clinician. I believe in clinical examination first and then the investigations, the opposite of what is happening today. Okay. So we used to treat the patients, we used to treat them to an extent just out of the danger, just patient was extubated or he's in BiPAP with low O2 or his vasopressors have been tapered. And then we used to treat the patient in wards or some special ward we used to call. Now we have converted it to semi-ICU basically. And then as we see in metros, it is very easy basically. You have all the super specialists, you have the investigations, you have the facilities, you have the gadgets. In peripheries or in district or taluka places, we don't have all these things actually. And so every year we used to update ourselves, like critical care developed in our part or in this part of Maharashtra. I can say it is not an exaggeration that it is a replica of what critical care is in Pune. ISCCM Pune or my friends and colleagues here have been of immense help to us in developing the critical care concept, developing the critical care model or the ICUs in our area. We have been updating ourselves year by year basically. We had ABG machine. At that time we did not have HRCT chest. Then we had those things. We did not have higher investigations like culture, PCT. We developed all these things. And now we have multiple investigation modalities like BACTEC. We have biofire tests available basically. We have PET scan recently set up in Solapur. All these things come to us with a lag time. What comes to metros, B or A grade city, after I think 1, 2, 3 years, we have that in lower tier cities actually. So, but things cannot stop. The patients keep on flowing. You have to treat the patients. Every patient cannot be referred to a critical care center in the or higher center basically. So while treating, I found number of things basically. Guidelines and protocols are good, they have to be followed. Your errors and mistakes are reduced, and you can give an even treatment to all the patients. Agreed. But every time this cannot be followed, because a live patient in an ICU is a different set, is a mixture of all the things actually. And with a financially restrained or economically burdened relative, you cannot deliver all these book treatments or guidelines. So while treating, I realized that only being a physician is not sufficient. We need to know something more so that you can defend what you are doing. Maybe just when you do out of the guidelines, or when you do some little less investigations, or somebody asks you, why have you done this and why have you not? So I pursued my further education basically, and after doing my IDCCM, I think 6-7 years ago, I then again I thought, or I like education basically. Okay, so I pursued my EDIC degree basically. But then now the question about me, nobody blames me, or nobody doubts on my abilities now in my area as a physician or as a critical care specialist. But over the years, we had to do a lot. We had to devise methods basically. So what I used to do, while treating the patients in ICUs, I kept the ICUs open. Relatives can come, they can see the papers, they can see the investigations, they can take the photograph of the investigations, then they can send the investigations, talk to the doctors who are their relatives or distant doctors, whoever are there. But I always made a point that the papers are well completed, enough time was given to every patient, and the investigations and his conditions, so that no loopholes are there. So I could do this. The friction between patient and doctors, which we see nowadays, okay, this was an attempt to reduce the friction. When you open the case, when you start maintaining the transparency actually, relatives, they know that you are trying to treat the patient, you are giving your efforts to treat the patient. What happens if you keep some suspense? As you all know, doctor-patient relatives are not very healthy nowadays basically. So if there is an error or there is a mistake, or if the case goes wrong, there are very likely chances that you may face the brunt of the relatives, or there may be violence, which we see nowadays. So what I used to do, I used to talk to the relatives, I used to give them free hand. I used to discuss about the drugs which were given, the investigations which were done, and I used to explain them why all the investigations are not being done, or why only simple few investigations are being done with not a very frequent repetition. Okay, and I used to give maximum time to the relatives when, not used to, do it now, to the relatives while counseling. What I believe, or what during EDIC I learned, that your verbal language is only 10% of your body language. It is 90% non-verbal language which is important. The way you stand, the way you talk, the way you give the reasons. They don't understand your medical language, but they very well understand what you are trying to say, what is your language and what are your intentions. So many things I thought go wrong there. Enough time was given to the patient. We explain in the language which the relatives understand. I call the relatives in the patient, near the patient bed. I talk to them basically. Even while doing any emergencies, okay, and while intubating the patient, or while doing any procedures, or even while doing the CPR, I give option to the patient's relatives that if you want to stand near the patient and if you can see the scenario, you can stand there and you can see what is being done, so that a transparency is maintained, and the things which may go wrong after the death of the patient or when the case fails, you can certainly, not to all extent, but to some extent, avoid them. ICUs in periphery or ICUs in district hospital or taluka places are, I may say, primitive ICUs. We don't have all these facilities and all the required gadgets or treatment at hands. Okay, we do only basic treatments. So another thing which I realized was we need to choose the cases while keeping them in ICU. You cannot keep all the patients which are coming to you in the ICUs. You should know your limitations, you should know your staff, you should know your hospital, you should know what instruments you have and to what extent you can manage these patients. Okay, at the outright you can say this is not our ICU to be managed, you may shift the patient, or you can talk to the relatives frankly, basically you can do till this much. The things which we could do in our ICUs basically after 50, now we have almost all the instruments, we have best of ventilators, we have arterial lines basically, we have PCTs, we have biofires, we have all the things. But somehow only doing the investigations and writing orders on the paper in ICU does not work. I'll give you an example. Few days back, one of my relatives was admitted. She had fever since last 2 months, which was not being responded. On PET scan, it revealed giant cell arteritis of the aorta, so treatment was started. Then she developed some infection. She was again admitted. Number of doctors attended the patient. Infectious disease patients were there. Then you have the cardiologist was there since she had breathlessness. Then you had the rheumatologist since it was giant cell arteritis. Then you had the endocrinologist. But what the granddaughter of that patient studying in second year MBBS asked me was, "Uncle, what I am being taught nowadays is that you should first take the history, clinically examine the patient, talk to the patient and then write down the investigations." She was there for 4 days. She said, unfortunately, none of them examined the patient, none of them saw the pulse basically, they were all taken before only. No consultant auscultated the patient. She had moderate aortic stenosis. And her investigations were written, all the tests were done, including CT thorax, angiography was done. So the message is somehow in the run of technology advances or in the run of giving the hi-fi treatment to the patients, we are missing the basics of or it is killing the clinical medicine. So it is very important that a mixture of the two, clinical investigation, clinically examining the patient in ICU, then the most important, every time you need not worry that what the relatives will say, I will have a medical legal case, I will have this, I will have that. If you do it in a proper way, with a proper intention and rationally, most of the time I think you can dodge these problems. Okay. We are happy that many new ICUs have been opened in our interiors and micro interiors. They are doing a good job. And recently what I learned was the projects for, because in India we have 2.5 beds per lakh population in ICU. In Western countries it is 10 per 1 lakh. So more ICUs need to be developed. All people cannot afford metro or our ICU expenditures basically. The journey or transportation is also very long. So a theme has been started that like Tehsil ICU chain has been started. One is in the Tamil Nadu by Dr. Raju Amarnath in the name of Sipaka. Another is in the Tumkur district of Karnataka by Dr. Jain, then Dr. Fernandez. Okay. And they are going and setting up ICUs in government rural hospitals, in government setups, in taluka places, in every 50 to 75 kilometers of area. And they are giving some specialties, they are giving some instruments, equipments funded by NGOs and the government to run the ICUs at a minimum cost, where the poor people or the village people, which comprises 70% of the Indian population, can be treated at a cost which they can afford basically. And these things need to be supported by government also, because everything in ICU is not free. Everything needs a cost basically to run the ICU. And lastly, the trends in ICU have changed over time. Over last 2 decades, critical practice has evolved from all-inclusive, like a single physician used to do, to all-exclusive. There are multiple specialties which are involved in the treatment. People's mindset is rapidly changing. With developing technology, expectations in ICUs are very high. ICUs are temples to save human lives and not money minting machines. Their bed should be judiciously used to most needy patients so that proper utilization of manpower, money and machines can be done. Thank you.
Thank you very much, sir. In today's era, when people look at the intensive care units, probably your insights and your inputs will be definitely an eye-opener, and it will probably set good goals in our young intensivist mind. Thank you very much. Sir has asked की उलटी गंगा काय आहे, सोलापूरचा अकलूजचा माणूस काय ह्या कार्यक्रमाला. तर मला असं वाटतं की see the amount of actual work what probably these 3 people are doing, and with Dr. Shalaka is also here, the amount of work what they are doing, suppose they are doing that work in 3 months time, same work we are doing in 1 year time. So that much huge work actually they are doing. So what happens, by being at periphery, that doesn't mean that they are not doing their best. They are doing their best, and actually it is more creditable to do this with same passion at the centers, and that to that successfully. And I always feel that if I have to learn critical care, I have to see the entire spectrum of patients. If I am at the best hospitals in Mumbai, or I am at a periphery hospital, suppose at Apex Hospital, Akluz, probably I will be learning more at these small setups. And probably that is the reason, that's why they are here on the dais, because of their work and not because of anything else. And that itself shows that again and again, nothing is impossible. We can't say कि यार अपन लोणीत हे करू शकत नाही, लोणीत ते करू शकत नाही. It is probably, this is just into our minds. Being here also, we can still at VRH also, we can do n number of things. If these people can do, why can't we do it here? And probably that is a very important message what these 3 dignitaries with Dr. Shalaka will give us, or probably will motivate us to move ahead, because we have everything. So what more we should have, that more mind, we need more sweat to be put into our practice. So I thank sir for a wonderful lecture. Now to conclude today's this program, I will request Dr. Vikram Agrawal sir to say a few words, then we will move on to the next lecture.
Thank you, Dr. Kapil. All the dignitaries on the stage, I would say, all the dignitaries on the stage, Chalu. It has been a great learning experience for all of us, specifically all my junior doctors who are here. It's after a long time that we are having such a nice offline event, and thanks to Dr. Kapil who helped arrange all these things. The scientific program that they have made is wonderful, starting from the inflow of the patient to the critical care to handling various emergencies, various issues. I will not stand much between your scientific program and the scientific program and between you. So thanks again to all of you, Dr. Kapil, Dr. Tabrez, Dr. Khandale, Dr. Sushant, right, and all of the dignitaries who have come from far off areas, taking time from your practice, right. Thank you once again. Hope it will be a good learning experience for all. Thank you.
Thank you, sir. There is one announcement. We have one selfie contest. I'll put it as a photograph contest. There's a selfie stand outside. The rules will be explained to you there. You have to click your photograph on that selfie point. You keep it as a WhatsApp status. And the best 3 entries, first entry will get 5,000 rupees plus a gift, second is 3,000 rupees and a gift, third is 2,000 rupees and a gift. And one lucky winner will be getting a complimentary registration for Best of Brussels workshop and a conference. Best of Brussels is a landmark event in Pune, started by Indian Society of Critical Care Medicine Pune branch, where all the lectures, what happens in Belgium, Brussels, those same lecturers and same lectures are delivered in Pune. We have that conference in July. So one lucky winner will get complimentary registration for entire conference for 3 days and one ventilatory workshop. So definitely all the delegates, you should try that and you should try your luck because you may be among those 4 best. At the end of the day, we have one ventilatory workshop also for 1 hour and some 15 minutes just to brush up on the basic concepts of ventilation and high flow nasal cannula, which we were not aware of much before COVID, but I think we are using more and more, and we have that hands-on training as well with intubation training. So I thank all the dignitaries, and probably I'll hand it over mic again to Dr. Vijay Khandagai sir for the next lectures. We will have 2 lectures, then lunch, then we'll break and we'll gather after lunch. So we will have back-to-back 2 lectures after this session. Thank you sir. And I thank Dr. Ganesh Bokeh sir also. I told him that we are short of time, so I request him not to deliver lecture, and he agreed. For big applause for him as well.
I am very thankful to Vishwaraj Hospital organizing committee and especially Dr. Kapil inviting me as a guest of honor, and it will be boost me as well as working people in a rural area, so that our work is appreciated by people like him and Pune people. So I am very thankful to him and all organizing committee. Thank you. Thank you.
Thank you, sir. We'll move on to the next session. Our next topic for the lecture presentation is metabolic acidosis on ABG. What to do the next by Dr. Khalid Khatib, sir. For this session, I would like to invite first Dr. Nilesh Kadakdar on dais to moderate this session. Dr. Nilesh, sir, please welcome. Please have a seat, sir. Dr. Nilesh Kadakdar, sir, has done his MBBS from Government Medical College, Miras. He is working as an intensivist since last 15 years. He worked in the Ruby Hall Clinic at Naval Hospital, Hadapsar. Currently, he is an ICU in charge in Vrh Gyaan Multi-Specialty Hospital, Mandavagan, Farata, since 2015. Now, I would like to invite Dr. Ramjan Spencer on the dais to moderate this session. Welcome, sir. Dr. Ramjan Spencer has done his MBBS, MD, DGO. He is a consultant at OD Kanchan, working in a gynecology department since last 25 years. He had completed his MD in 1996. His active practice in virtually all aspects of specialty, particular interest in urogynecology and reproductive endocrinology. You are most welcome, sir. Now I would like to invite Dr. Khalid Khatib, sir, on the stage to deliver the lecture on ABG. Dr. Khalid Khatib, sir, has done his MBBS from D.Y. Patil Medical College, Kolhapur. He has done his MD Medicine from GMC Miras. He is a teacher and examiner for MBBS, MD, and IDCCM. He is currently the secretary of ISCM branch, Pune. He has more than 35 publications in national and international journals. Over to you, sir.
Thank you very much. Let's start straight away. I'll be talking on metabolic acidosis, a bedside approach for the practicing clinician. The way you approach interpretation of the ABG is, first step is validation of the ABG. Second step is you will see what is the pH. The third step is you will evaluate the oxygen. The fourth step is you will evaluate what has happened to the CO2 or the ventilatory status. And the fifth step you will come to is acid-base status. So if you look at primary acid-base disorders, you have metabolic acidosis where you have too little bicarb, metabolic alkalosis where you have too much bicarb, and respiratory acidosis, too much CO2, and respiratory alkalosis, too little CO2. Once you have a particular disorder, the organ, if you have metabolic disorder, primary metabolic disorder, the lung is going to start compensating for that metabolic disorder. Or if you have a respiratory disorder, then the kidney is going to start compensating for that disorder. So if you look at all the simple acid-base disorders, you have acidosis and alkalosis. In acidosis, you have metabolic acidosis and respiratory acidosis. In alkalosis, you have metabolic alkalosis and respiratory alkalosis. If you look at what happens to, how do you come to a diagnosis of these various disorders is you evaluate the pH, then you will look at bicarb level and the PaCO2 level. So if you have a patient who has low bicarb and low PaCO2, then also has low pH. So all three are reduced. So his pH is low, so therefore he has acidosis. His bicarb is low, therefore the cause of acidosis is metabolic acidosis. And his CO2 is also low as a compensation for his metabolic acidosis. So if all these three are present, if pH is low, bicarb is low, and PaCO2 is low, then you will call this disorder as metabolic acidosis. As against this, if you have respiratory alkalosis, in that the pH will be high, that is telling you that the patient has alkalosis, the bicarb will be low, and the PaCO2 will be low. If all these things are there, then you will call it respiratory alkalosis. Okay, now a pH which is less than 7.35, you will call it acidemia. If it is associated with a PaCO2 which is more than 40, you will call it respiratory acidosis. But if it is associated with a low bicarb less than 24, you will call it metabolic acidosis. So let's look at this case. A patient presents with breathlessness since one day. He is given oxygen as is the usual. His ABG was analyzed and it shows the following figures. Anybody? His FiO2 is 0.4, his PO2 is 165 because we have already given him oxygen. His pH is 7.26, therefore the pH is showing acidosis or acidemia. If you look at his bicarb is 12, therefore bicarb is low. So he is having metabolic acidosis, and as a compensation CO2 is also low, but it is not a primary respiratory alkalosis because he has acidemia. Therefore this is metabolic acidosis. So what are the causes of metabolic acidosis? Renal failure, diabetes, renal tubular acidosis, convulsions, alcohol intoxication, lactic acidosis due to septicemia. So how do you come to what is the cause of his metabolic acidosis? So let's look at one case. This is we had this patient just last week, a 20 years female. She was a student. She had come from Vita in Sangli, and she was a student. So she had history of multiple vomiting and loose motion, pain in abdomen, and she had history of fever 2 days ago. When she came to the casualty, she had toxic look. She was having very high heart rate, 150 per minute. BP was not recordable. RR was 35. So she had tachycardia, tachypnea, hypotension. On examination per abdomen, there was tenderness all over the abdomen. She was also complaining of tenderness all over her limbs. So we sent investigation, HB 9.6, TLC was all right, platelet was low, 88,000. PT-INR was high, INR was almost 4, urea was 97, creat was 6.5. She had history of just 2 days fever. Total CPK was 697, bilirubin was 3, OTPT was marginally increased, her sodium was 134, potassium 3.4 and chloride was 105. So she had fever with anemia, thrombocytopenia, AKI, hepatitis, myocarditis, myositis. So almost multi-organ dysfunction, multi-organ failure she had. Send her ABG. AB showed pH of 7.38, PO2 127 because she was already on oxygen. PCO2 was 19 and bicarb was 11. So she has ABG 7.38 around, so towards acidosis. Bicarb is 11, so low. CO2 is low, so this is metabolic acidosis. So metabolic acidosis is not a disease per se, it is just a manifestation of disease processes. So the differential diagnosis that we had was leptospirosis or dengue, hemolytic uremic syndrome, AGE cholera with multi-organ failure, or some perforating colitis because of her pain in abdomen. So we'll look at not the other parts, we'll just look at the metabolic acidosis part. It can be because of a decrease in plasma bicarb, or it may be because of excretion of bicarb containing fluid, or because of utilization of the bicarb which is there in the body. So there is a concept of anion gap. Once you come to a diagnosis of metabolic acidosis, you want to know whether this metabolic acidosis is associated with an anion gap. So this anion gap can be either normal or it can be high. So how do you calculate anion gap? It's very simple. You take the positive ions and the negative ions to one side. So positive ions you have sodium, potassium. Negative ions you have bicarb and chloride. Also you have some unknown or other cations and anions. If you ideally when the body is in homeostasis, you want to have equal cations, equal anions. So the pH is normal. You don't want either acidosis or alkalosis. The body tries to keep the interior milieu in homeostasis. So if you take sodium, add potassium to that and add the unknown cations, and on the other side chloride, bicarb and unknown anions, they should be equal. So anion gap is, there is a calculation, sodium minus chloride plus bicarb. The sodium is in the order of 130, 140. Potassium is in the order of 3 or 4. So you need not look at potassium when you are calculating anion gap. On the other side you have chloride and bicarb. If you add them and minus them from sodium, you get the anion gap. So if you have a high anion gap metabolic acidosis like lactic acidosis and ketoacidosis, what is happening is you are adding something to the unknown anion sites. You have what is chloride, what is bicarb that you know you have calculated or you get from the reports. What is added is unknown anions. On the other side, what happens when the anion gap is normal is what? There will be an increase in the chloride. So hyperchloremic normal anion gap metabolic acidosis. So what are the causes of high anion gap metabolic acidosis? So there is a mnemonic by which you can remember the causes. It is mud pilers or methanol, uremia, diabetic ketoacidosis, ingestion of paraldehyde, isoniazid or iron, ingestion of increase in the level of lactate, ingestion of ethanol or ethylene glycol, rhabdomyolysis causing renal failure, and ingestion of salicylates. So mud pilers is the mnemonic you can remember for causes of high anion gap metabolic acidosis. What are the causes of normal anion gap metabolic acidosis? You remember by the mnemonic hard up, hyperalimentation or TPN, use of acetazolamide. Why will you use acetazolamide? For treatment of glaucoma, or people use it nowadays when they are going to high altitudes. So Chardham Yatra, or when they go to Everest base camp, they will use acetazolamide. Another cause is renal tubular acidosis, diarrhea, acute uremia, or in post-ventilation hypocapnia. So if you have, once you have diagnosed metabolic acidosis, you have calculated the anion gap, and if you find that the anion gap is normal, then the next step is you check what is the urinary anion gap. For that you have to do urinary sodium, potassium and chloride. If the urinary anion gap is more than 20 or 30, then the diagnosis is, so a normal normal anion gap metabolic acidosis in the ABG and elevated anion gap in the urine is an indication, or the cause is renal tubular acidosis. That is, the kidney is unable to manage the acidosis which is there. So if it is associated with low potassium, it is diagnosis is proximal renal tubular acidosis, while if it is associated with hyperkalemia, then it is a aldosterone deficiency or a type 4 renal tubular acidosis. So depending on the type of metabolic acidosis, if it is normal anion gap, then the next step is urinary anion gap calculation. In some conditions, if there is reduced serum albumin, you have to adjust the anion gap. For every 1 gram reduction or increase of serum albumin, you have to reduce or increase the anion gap calculation by 2 milliequivalents. So again, going back to that case, now we have come to the step where we had metabolic acidosis. Now we are given that sodium is 140, chloride is 99. So we will calculate the anion gap. 140 minus 99 plus 12, so that is 29, almost 30. And expected anion gap was 12 minus 2, because of we have to reduce 2 for acidemia. So that is high anion gap metabolic acidosis. For people who want to go into the depth, there are concepts like delta anion gap, delta bicarb and delta gap, but that is for higher learning. So if you have high anion gap acidosis, metabolic acidosis, the next step is to calculate the osmolar gap, that is measured osmolality and calculated osmolality. Measured osmolality, you will get the report from the lab. You have to ask them, please tell me what is the measured osmolarity of the blood. And calculated osmolarity, you calculate by the formula 2 into sodium plus glucose divided by 18 plus BUN divided by 2.8. So after you have come to the diagnosis that this person is having high anion gap metabolic acidosis, the next step is calculation of the osmolar gap. So what are the, if the osmolar gap is, normally it is less than 20, if it is more than 20, what are the causes? Ethanol intoxication, methanol intake, isopropyl alcohol intake or ethylene glycol. So these are toxic alcohols which may be taken by some patient for whatever reason. So here now, let's come to this another example. A 24-year male is admitted in coma, has rapid shallow breathing. Clinical examination CNS wise looks otherwise okay. CSF CT are done, they are normal. Young person who is unconscious. So ABGN admission is as follows. Anybody wants to have a comment on this case? So if you look at the pH, what is the pH? Acidic. If you look at bicarb, it is low. If you look at CO2, again it is so. Metabolic acidosis, we have come to that part. If you look at his sodium, potassium, chloride, so sodium is 131, chloride is 94 and bicarb is 16. So what is the anion gap calculation? So metabolic acidosis anion gap is 21. Now his measured plasma osmolarity is 324. How much is the calculated osmolarity? It comes to around 276. 2 multiplied by sodium plus. Yes. So therefore the osmolar gap is almost 50, 48. So high anion gap metabolic acidosis with an increased osmolar gap. The causes we have already discussed is methanol, ethanol poisoning, ethylene glycol poisoning. So most likely that young boy has ingested one of these things. So what happens after 24 hours? He develops fixed dilated pupils. So what is the cause? Mostly he has taken methanol. He had tried to take alcohol, maybe it was mixed with methanol, and therefore he has developed symptoms because of formation of formic acid, because of degradation of methanol. In some patients you may not have primary metabolic acidosis, metabolic alkalosis, or respiratory acidosis, respiratory alkalosis. They may have more than one problem. It may be because the patient already has chronic renal failure and then he develops a respiratory problem, or he has a respiratory problem all throughout, chronic respiratory problem, and then he develops renal failure or something. So these patients, they will have mixed acid-base disorders where compensation may not be adequate. Okay, now coming to, if you have a patient with metabolic acidosis and he has low calcium, so this is a peculiar combination. What are the causes? Causes may be pancreatitis, renal failure, rhabdomyolysis, tumor cell lysis syndrome following chemotherapy for a patient with malignancy, ethylene glycol toxicity, or hydrofluoric acid poisoning. So once you have metabolic acidosis and you want to search for diagnosis, try and take help of as many things as you can. If you have sent calcium and calcium is low, then you have a clue as to, you can narrow down your spectrum of diseases which cause metabolic acidosis. If metabolic acidosis is associated with hypoglycemia, then these are some of the causes. Liver cell failure, patient has had convulsion, or he has taken metformin and developed metformin toxicity, or adrenal insufficiency, or there is starvation ketosis. So ketosis part will cause the metabolic acidosis and starvation will cause the low blood sugar. Okay. Now straightforward case, severe decay in ICU, so you expect that this patient will have high anion gap metabolic acidosis, but he continues to have acidemia despite aggressive treatment. So now his glucose has come down from what, 400, 450 to it is now 180. So now is the time when you will see Qrs, now I don't want to give him normal saline, now I will give him covered pint of say dextrose and insulin. So now let's look at the acid-base status. Now the pH is 7.25. It's not that bad, but still it is acidosis. Bicarb is 11. CO2 is 26. So metabolic acidosis. Yeah, sodium, potassium, chloride. If you calculate, so again acidosis. But if you look at his corrected bicarb or the delta gap which I was saying, further you will see that he also has developed, because in diabetic ketoacidosis you are going to give lots of normal saline, so NaCl, so he is going to develop hyperchloremia. Hyperchloremia is one of the causes of developing normal anion gap metabolic acidosis. So this patients with decay, when you are treating them with large volumes of normal saline, you should be aware that you may also be causing some or the other problem. If that is the case, then you may shift over to some other fluid. So now this is the case of multiple myeloma with asthma, is admitted with status asthmaticus, put on ventilator, 100% FiO2, you have done his ABG. So ABG is, PO2 is very high, so 100% FiO2 he doesn't need. PaCO2 is 47, so it is elevated, so he also has respiratory acidosis. pH is 7.23, so acidosis is there, but bicarb is also low. So this person has metabolic acidosis as well as respiratory acidosis. He has a low albumin. So if you are going to calculate his anion gap, you have to correct it for this albumin level. So you have gone through oxygenation, ventilator, come to the acid-base status where you have diagnosed that he has respiratory plus metabolic acidosis. Now what to do? So now you get electrolyte reports 131, 3.4. So he has hypokalemia also. So anion gap expected for that correction. because of low albumin you have done anion gap expected is 6 plus minus 2. Actual anion gap is 8, so fair enough, he has normal anion gap, doesn't have high anion gap metabolic acidosis. The next step, what I said was calculate urinary anion gap if it is normal anion gap metabolic acidosis. So these are the urinary sodium potassium chloride levels. So he has positive urinary anion gap, therefore his diagnosis will be renal tubular acidosis, and renal tubular acidosis with hypokalemia, what I said it was diagnosis. There are 4 types, 1, 2, 3, 4 types of renal tubular acidosis. Low potassium and urine pH which was more than 5.5, therefore this is distal or type 1 renal tubular acidosis. So you can reach a diagnosis once you start doing the steps of analysis. So what about our case which I had discussed? So her ABG was 7.38, CO2 was 16, bicarb was 10, sodium potassium was there, so the anion gap was 19. So she had high anion gap metabolic acidosis, which was most likely because of the raised creatinine or AKI that she had, and it must have also been because of lactic acidosis, which was due to septicemia, multi-organ failure that she was having. Do we have time to go to this case? Yeah, just one case. So all this knowledge, how will you apply to the bedside? So let's look at this fellow. Family members discover a 35-year-old man in his garage, confused and poorly responsive. Paramedics find a suicide note and some fluid nearby. In the ED, he appears inebriated with tachypnea, tachycardia, but BP is normal, and his investigations are given there. So what would be your next steps in managing the patient? So first will be diagnosis and second will be managing. So whether you will give normal saline, soda bicarb, fomepizole or everything, obtain levels. First we'll see what is, let's just analyze, we'll go to the next slide. So again pH is low, so acidosis, metabolic acidosis, high anion gap metabolic acidosis. Osmolar gap we have calculated, which is very high. So what we had seen was if osmolar gap is high in a person who has high anion gap metabolic acidosis, then he has taken ethanol, methanol, isopropyl alcohol or ethylene glycol. The clue to the whole case was that he was in a garage, and in the garage what are the different types of alcohols that are available? I thought in the garage only you had dirty clothes there, but no, there are lots of alcohols which are there in the, so windshield washer fluid, carburetor cleaner, antifreeze, engine coolants, sanitizers, all these are present in the garage and which somebody might take. So toxic alcohol are easily available, which people might take, and then they will come to our casualties being unconscious and presenting with high anion gap metabolic acidosis. So what do you do for that? You have to give IV fluids or forced alkaline diuresis. So first you have to load the patient with fluids, give him soda bicarb, make him to have dialysis, make him to have lots of urine. You can send all the levels, but you don't have levels of methanol, ethanol, they are not easily available. So what you have to do is start treatment. And that's what they say. In the garage you have antifreeze, windshield washer which can contain methanol, brake fluid and all those things. I think we'll, once again just a reminder for causes of high anion gap metabolic acidosis, that is mnemonic is mud piler, methanol, uremia, diabetic ketoacidosis, paraldehyde, isoniazide, lactate, ethanol, rhabdomyolysis and salicylates. Thank you.
Thank you, Khalid sir, for this informative lecture. If anyone has queries or questions from the audience, if you want to add something from the chairperson. Okay. So I would like to request Dr. Anirudh Garud sir, head of the department pathology, to felicitate Dr. Khalid sir. Our next topic for the lecture is acute breathlessness in pregnancy. How do I manage? I request Dr. Nitin Rane sir to deliver this lecture. Dr. Nitin Rane sir, he has done his MBBS, DNB medicine. He is a consulting physician and head of the Apex Hospital, Akuluz, since 2011. Apex Hospital is a multi-specialty hospital with 100 beds, with 25 bedded ICU, cath lab, and radiodiagnostic center. Presently, sir is a secretary for IMA Vancha Akuluz. He has a special interest in the gastroscopy, colonoscopy, bronchoscopy, and USG interventions. Over to you, sir.
Sorry.
Pointer. Good afternoon, everyone. Good afternoon, chairpersons. At the outset, I would like to thank Vishwaraj Hospital for giving me this opportunity to present the lecture over here, and also thank to Dr. Kapil for providing me this opportunity. So today we'll be discussing about acute breathlessness in pregnancy. So acute breathlessness in pregnancy, how we'll be going about the lecture? So dyspnea is a common dyspnea is a common complaint during pregnancy, and many times it is physiological, because those who are primees getting pregnant for the first time, they're not aware of the physiological changes that are going to happen in the body. So many times they interpret as breathlessness or dyspnea or dam lagtoy kiva aswastha vattay. So that is how they present to you. So these patients can be due to physiological causes, or there are other underlying pathological or organic causes such as cardiac diseases or respiratory diseases which the patient is not aware of, or the patient already has the disease and that has been exacerbated now. So physiological dyspnea in pregnancy is a very important term. This can be itself the cause of acute breathlessness in pregnancy when the patient presents to you. So this is about 60 to 75% of women experience breathlessness in pregnancy. So this is what normal pregnancy, and this is physiological causes of pregnancy, dyspnea in pregnancy. It generally starts between the first and second trimester of pregnancy, and it stabilizes around the third trimester. Mechanism is exactly not clear. It is just not about the expanding uterus or the growing baby in the stomach. Apart from that, there are various changes which occur in the body which is responsible for it. So what are the causes? The causes can be, so these are various postulated things which have been studied, like progesterone. Progesterone induced hyperventilation. There are various hormonal changes. Progesterone levels significantly rise, and progesterone is a stimulant that is itself responsible for hyperventilation in pregnancy. So it is a normal finding to have a high respiratory rate in pregnancy. low partial pressure of carbon dioxide, subtle diastolic dysfunction, and these can be seen on echoes. So these are various causes which the patient might have, but this physiological dyspnea in pregnancy, it is not associated with. So there are various certain pointers that tell you that this breathlessness is not due to physiological causes. So what are those causes? Cough. So these are the various symptoms: cough, wheezing, fever, hemoptysis, sputum production, hypoxemia when the saturation is less than 95%, tachycardia, irregular heart rhythm, urticaria. So these causes tell you that this is not a physiological cause of breathlessness in pregnancy. So there are clues which tell you that there is urgent need for evaluation, or the patient needs to be monitored extensively, like heart rate more than 120, respiratory rate of more than 24, SpO2 of less than 95, use of accessory muscles of respiration, difficulty in speaking full sentences, stride or asymmetrical breath sounds, auscultation, you find crepitations, patient is profusely sweating, there is neck or substernal pain, cyanosis, hemoptysis, and altered mental status. So these things are very important. If you find these in a pregnant patient who comes to you and has any sign of this, you need to evaluate the patient further. So what is the most important initial evaluation in this patient is to ask the patient that whether the patient has any underlying asthma or any underlying pulmonary disease like interstitial lung disease or previous history of spontaneous pneumothorax for presenting as breathlessness. Does the patient have any underlying heart disease, like any valvular heart disease, any previous history, any significant family history, any cardiomyopathies in family? So that history needs to be asked in detail to the patient. And the most important question is the dyspnea sudden in onset. Because the crux of this lecture is we are looking for causes of acute onset dyspnea in pregnancy. So the patient is apparently all right and suddenly patient there starts developing breathlessness. So there are various important causes. I'll list them one by one. I will, just the causes, will not be going about all of these. Asthma, allergic bronchitis, pulmonary embolism, arrhythmia, coronary ischemia or dissection, amniotic fluid embolism, air embolism, pulmonary edema, and pneumonia. These are just to list few of them. Actually, these itself are topics in themselves. So we'll not be taking in details about all these things, but we'll be discussing some important aspects as related to physicians managing a pregnant patient who presents with breathlessness. So asthma in pregnancy, we'll talk about this in detail because this is the most common pulmonary disease in pregnancy when the patient presents to you. About 3 to 8% of women are affected in this. So there are two important questions. That how does pregnancy affect asthma, and how does asthma affect the outcome of the pregnancy? So asthma affecting the outcome of pregnancy is the baby going to be delivered early? Are there going to be premature deliveries? Is the baby getting hypoxiated? Will there be IUGR due to asthma? So all these things, asthma is going to affect the baby. And how does pregnancy affect asthma? The disease, the patient already has the disease. So how we go about it? So respiratory physiological changes in pregnancy is an important thing. When a mother becomes pregnant, when a female becomes pregnant, there are various changes, various pulmonary changes that occur in a patient. The maternal pulmonary function, the tidal volume increases, the functional vital capacity of the patient increases, there are various diaphragmatic changes, the chest wall circumference changes, so the thoracic cavity diameter changes, the maternal airway hyperresponsiveness, so that also changes. The patient becomes hyperresponsive and the airway, like we see in asthma, there is significant bronchoconstrictions, there is increase in secretions due to hormonal changes. Maternal ABG, if you do an ABG, we had an excellent talk about ABG just prior to this. There are various normal changes in pregnancy. Because of hyperventilation, there is CO2 washout leading to some respiratory alkalosis, which is physiological in these patients. And fetal oxygenation, this is also an important, a PO2 of at least 95. SpO2 of at least 95 is needed, so a PO2 of 105 is needed so that fetal hypoxia doesn't occur. So that SpO2 of 95 is important in pregnant females. In other patients, we can wait till 90, 92, but in pregnant females, 95 is the cutoff because below 95, fetal hypoxia sets in. So how does asthma affect pregnancy? The pregnancy affects asthma. The asthmatic patients who are known asthmatics, some of them, it's the ratio of 1:3, 1/3. So about 30%, 33% of patients worsen, 33% patient remains the same, and 33% patients improve. So this is how the asthma is affected due to pregnancy. Some important points when a patient asthmatic who improve. The improvement is gradual as the pregnancy progresses. So initially the patient might be needing reliever medicines, repeated inhalational therapies, but the asthma improves and the dosage decreases. That is how some women improve. In other women, the asthma worsens, and the worsening is generally seen in about 29 to 36 weeks. Less severe in last 4 months of pregnancy. The asthma is less severe in last 4 months of pregnancy, and there are generally no substantial symptoms during labor and delivery. So when the patient goes into labor and delivery, due to various hormonal changes, the exacerbation of asthma is not during that time. And in successive pregnancies, if the patient is asthmatic and becomes pregnant for the next time, what we have seen in the first pregnancy, it generally remains the same in the other pregnancy as well, the second pregnancy. Management-wise, there is no big difference. When a patient as present to you is acutely, it is the same as you would treat a patient of a non-pregnant patient. So asthma patients with pregnancy and without pregnancy, the treatment in acute cases remains the same, because the benefits of the drugs are way higher than the morbidity which can be caused in mother. And in general management, obviously a stepwise recommendation, like normally we treat the patient, that is how we go along treating those patients. So that was first about asthma. Second most important thing I would like to discuss is pulmonary embolism. This is very important thing when a patient of acute dyspnea in pregnancy is seen, because Vt occurs in about 1 in 1600 of the pregnancies, and it can manifest as only isolated lower limb DVT or along with PE. Because many a times these pregnant patients attribute their breathlessness to pregnancy, and they are not aware that their breathlessness might be due to some other reasons. When you examine the patient and if you find that the patient has got lower limb edema unilaterally, or there are signs of pain, signs of DVT, and you see the patient and you can diagnose these patients of pulmonary embolism. So the clinical presentations, as you know, even in non-pregnant patients, or in other patients also, the clinical signs and symptoms are non-specific for pulmonary embolism. It is not that you have a particular sign that tells you. There are a wide variety of presentations. The patient can be absolutely asymptomatic. The patient might have a DVT, might have an underlying pulmonary embolism, but the patient might be asymptomatic, or patient might present to you in a state of shock, or patient might sometimes present in a state of sudden death. So that is how the varied presentations are. So we need to have a clinical suspicion. Lab studies, obviously, X-rays, ABGs, D-dimers, echocardiography help you in the diagnosis of pulmonary embolism. The most important thing is doing a CT pulmonary angio in these patients, because when we understand about pregnancy, we think of radiation exposure and all those things. So even in those cases, CT pulmonary angio is the investigation of choice. This is a small diagnostic algorithm for the patients. How you go: you suspect a patient of PE in pregnancy, you look for leg symptoms in these patients. If you have leg symptoms, you do this is what's called compression ultrasound of the lower limb. And if it is positive, you directly treat the patient as pulmonary embolism. If the patient doesn't have any leg symptoms and the compressed ultrasound is negative, you do a chest X-ray of the patient. Chest X-ray is abnormal, you do a CTPA of the patient. If it is positive, you treat the patient as pulmonary embolism. If it is negative, you stop. If it is technically inadequate, sometimes the report says that there might be filling defects, there might not be, it is inconclusive. In those cases, you might follow up the patient with a repeat ultrasound or repeat CTPA later. VQ scan, it's not generally done routinely in our patients. There are some benefits, some cons of doing a VQ scan, but generally CTPA is considered safer. I'll show you in the next slide. Radiation exposure and contrast. In general, the risk of radiation from VQ scan and CTPA and iodinated contrast is considered low. So it is not that if you have the patient, then you can't do a CT pulmonary angio in pregnant patients. In animal studies, it has been shown that doing a contrast study is teratogenic, so we would avoid doing a contrast study in these patients. Most important, this slide I would like to show you that the maximum tolerable radiation exposure by fetus is about 50 milligray. And when you do an X-ray, chest X-ray, the exposure is just less than this when you use proper shielding of the babies. If you do a CT chest, the exposure is just 0.3 milligray, coronary angio is 1.5 milligray, and PCI is about 3. So the exposure is significantly low. Doing a 1 CT pulmonary angio in these patients will not be harming the fetus. Treatment, some important points: low molecular weight rather than IV heparin or the unfractionated heparin. So you need to use a low molecular heparin, which is preferable in these patients. Second, no vitamin K antagonist in early because it is associated with embryopathy. So in first trimester up to 12 weeks, you need not use that. You need to use extensively heparin till the 3 months. Sometimes they are continued throughout the pregnancy, but generally it is said that for till 12 weeks, you use heparin, then shift the patient to warfarin or any other drugs when you match, but no vitamin K antagonist in first 12 weeks of the pregnancy. If possible, go with heparin throughout the pregnancy. No dabigatran, no rivaroxaban. Till now, they have not been approved in pregnancy. Anticoagulant therapy at least 6 weeks postpartum. So if you have diagnosed the patient in the first month of the pregnancy, you continue for 6 months, then additional 1.5 months later. Duration of therapy needs to be at least 3 to 6 months. That is what we say. Pregnancy itself is a thrombogenic state. So if the patient presents you with a DVT, if pregnancy is the only risk factor, you treat the patient for 6 months and then you discontinue the medicines. If there are some other causes which is responsible for DVT, then in that case you need to extend the therapy of DVT for long duration. Thrombolytic therapy, giving thrombolysis is reserved for hemodynamic and unstable patients who present you in shock. When you diagnose proximal clot in those patients in the pulmonary arteries, then you might think of thrombolytic therapy in these patients. Thrombolysis is not contraindicated, it can be done. The third most important point, severe case which might present to you, a pregnant patient with breathlessness, is amniotic fluid embolism. This is a catastrophic condition that typically occurs around labor or about 30 minutes postpartum. So the timing of presentation is also important. It is rare, about 1 to 12 cases per 1 lakh deliveries. But the most important thing is the pathophysiology is not understood. The underlying mechanisms it might be vasospastic, it might be inflammatory, immune reaction to the presence of amniotic debris or other antigens in the maternal circulation. So amniotic fluid embolism pathophysiology is not clearly understood. But the most important points are, you should be when to suspect this, because when the patient presents to you and the patient is in labor and suddenly they starts developing hypoxia, the BP drops, patient goes into shock, then the sudden cardiovascular collapse, hypoxemia, hemorrhage in association with DIC during delivery and labor in absence of other possible explanations. So you don't know that there are any other possible explanations and the patient develops this, then you might think of amniotic fluid embolism. So basically it is a diagnosis of exclusion. DIC may be the only presenting feature in these patients. So what are the various clinical sequelae? First, cardiovascular symptoms which we discuss about. It might present with respiratory symptoms like hypoxemia, pulmonary edema, ARDS, respiratory arrest. Hematological in the form of coagulopathy, DIC might be only presenting symptom. And neurological like seizure or altered mental status might be the presenting symptom. So amniotic fluid embolism might present in various systems in this manner. Management is always multidisciplinary. You need to treat the system. First, you need to stabilize the shock of the patient. You need to look for ABS, look for the breathing of the patient. If needed, do a rapid sequence intubation. You take the patients with load the patients with crystalloids and try and pick the BP up. If necessary, if there is a cardiac arrest, you need to give CPR to the patient. But it's a grave disorder. And if the patient is showing any signs of bleeding, if you have DIC, if the FDB is high, D-dimer is high, then if the PTTK is prolonged, in those patients you need to give proper blood products supplements. And need for immediate delivery is determined on the case-to-case basis. If the baby is less than 24 weeks, you need to think of continuing the pregnancy, try and stabilize the patient, try and see how the patient makes it. If the mother's condition is deteriorating in spite of all the efforts, then you might think of doing a C-section or delivering the baby just to save the life of the baby. Prognosis is very bad. Maternal mortality remains very high. It's about 20%. 20% of patients succumb in spite of all the resuscitative efforts. The morbidity is also significant because even if the patients survive, due to the cardiovascular collapse, due to the neurological insult and everything, the patients have some underlying residual morbidity or mortality in those patients. So it's very difficult for treating these patients. One important two important things, acute pulmonary edema. When a patient of breathlessness has shown signs of pulmonary edema on chest X-ray, then you need to think of some different causes. It's very rare, it's not that significant, but I would like to bring this important point in view of use of tocolytics, because nowadays you see many preterm labors and tocolytics agents which we use nowadays like isoxaprine, initially terbutaline was used, nifedipine is also used significantly. Those are responsible for pulmonary edema. So this was one important point. Preterm labor also increases the risk of edema. Pulmonary edema, obviously we know, is significantly associated with cardiac cases. Preeclampsia and eclampsia has been also been cited as a cause of pulmonary edema. It is a multifactorial thing. If you see, so slide is not properly visible. This is fluid overload, decreased plasma oncotic pressure, increased pulmonary capillary hydrostatic pressure. So these are the underlying physiological mechanisms which is responsible for pulmonary edema. One important point about tocolytics. Tocolytics like terbutaline, nifedipine, magnesium sulfate, these all might cause pulmonary edema in patients. So you need to closely monitor this patient. And who are the patients who are at risk? These are patients who have multiple gestations and maternal infections and who have been given simultaneous multiple tocolytic agents. Because this is very common. Many times the patient presents in labor, contractions are 32 weeks, 30 weeks, amount patient la nifedipine chalu ke liye, and the patient presents with breathlessness and saturation is low. Treatment is very easy. Just you need to discontinue the tocolytic agents. For that, you need to diagnose it properly, give the supplemental oxygen, fluid restriction, diuresis, mechanical ventilation may sometimes necessary, but generally the condition weans off in about 12 to 24 hours. So the mortality is very uncommon and the outcomes are good. A word about preeclampsia and eclampsia. It is an uncommon symptom of pulmonary edema presentation, but pulmonary edema is often associated with some underlying, yes sir, just 2 more minutes, with DIC, ARF or hypertensive crisis. Cardiogenic causes, we know some underlying valvular heart disease or underlying cardiomyopathy might be responsible for heart failure, and that might be responsible for this. Most common, we know that mitral stenosis, mitral regurgitation, aortic regurgitation, because we being in the area where we have lot number of patients of rheumatic heart diseases, these are the patients that we come across. And generally, regurgitant lesions are well tolerated in pregnancy as compared to stenotic lesions, so you need to monitor them properly accordingly. A small word about peripartum cardiomyopathy. It occurs in about 1 in 3,000 to 15,000 pregnancy, but it has viral myocarditis has been postulated as the reason for it. Maternal mortality is very high, it's about 20%, but the fetal outcomes are good. This needs to be monitored very properly because many times the peripartum cardiomyopathy is diagnosed during pregnancy. The patient presents with breathlessness, pedal edema, and the symptoms are attributed to pregnancy and the patient is missed. It has got a high mortality if it's not diagnosed and treated properly. So that needs to be monitored and seen properly. So to summarize, I have prepared a slide based on the trimester of the pregnancy. If you see the first trimester, second, third trimester, there are some physiological causes which might be there throughout the pregnancy. Anemia might be the presenting symptom in breathlessness. Asthma can occur throughout the pregnancy. Pulmonary embolism, as we talked about, it is more common throughout the pregnancy. Postpartum period, sometimes the patient post-LACS might not get out of the bed for 3 or 4 days and might develop a DVT. Peripartum cardiomyopathy, it is later in the pregnancy, about 3rd month. And spontaneous pneumothoraxes and pneumonias can be seen at any time during pregnancy. So thank you very much for your time. Thank you very much.
Thank you, Nitin Rane, sir, for this elaborate lecture. If you have any queries, questions, please raise your hand. Sir, you want to add something to this lecture? Yeah, thank you. Now I would like to request Dr. Mateen Syed, sir, consultant ENT surgeon, to come on the dais and felicitate Dr. Ramjan Spencer. Please come, sir. I request Dr. Mateen Syed, sir, to felicitate Dr. Kadodar, sir. Thank you, sir. I would like request Dr. Matin Syed, sir, to felicitate our speaker, Dr. Nitin Rane, sir.
I will
Thank you,
request
sir.
Dr. Nitin Rane sir to be pleased on the dais because my questions are not yet over. So I would first of all congratulate him for his excellent endeavor and excellent talk. We have one more hall where this talk can be seen. I was going through all his slides. I have two questions to him. One is how frequently you encounter IUD into your practice, and what is your experience about IUD coming with sepsis? Any insights on that? And second thing, how common is bleeding in particularly postpartum period? Any take homes, because at that setting where massive transfusion protocol becomes very, very difficult. So what are the tips where we are facing the same issue here?
Yeah. Thank you for the questions. Actually, these are very practical points, and when you practice in a limited resource setting, it is very important that you anticipate these things properly. Because if you are late at doing these things, you are going to lose the patient. And looking at the present scenario, you know it's going to be difficult to manage the things. So the most important point is when you are managing a pregnant patient, it is a physiological thing that you are managing. So the patient's relatives don't expect any complications. So if they come with complication, it is a grave thing, and you need to counsel the patient very properly regarding that. My setup, we actually run a high-risk obstetric center. My wife is a gynecologist. She does every high-risk obstetric work. So we have done coarctation of aorta in pregnancy, everything aortic stenosis in pregnancy, multiple valvular disease in pregnancy, cardiomyopathy in pregnancy, every diabetic in pregnancy. So all these kind of bleeding patients are referred to us. And many times PPH, patient presenting with PPH, DIC, patient presenting with traumatic PPH, these patients do come to us in a frequent basis. So the most important thing when a patient of bleeding comes to you is you need to ascertain immediately what the patient's coagulation status is, because DIC needs to be ruled out first. Because just prior to coming here, 2 days ago, we had a patient who presented with abruption, abruption being the most common presentation in patient of DIC in pregnancy, that also presented with IUD. So managing an IUD, abruption, DIC becomes very difficult. Because in that case, we had to transfuse that patient with about 9 PCVs, 16 FFPs, 2 SDPs. And today's the patient hemogram shows about hemoglobin of 9.4 and platelet count of 88,000. Today morning's patient, that hemoglobin had dropped to 3 in spite of giving about 4 PCVs. So that was how critical she was. She was in shock, but the patient came out. The blood support needs to be very significantly better. You need to have a good communication with the blood bank if you are managing a high-risk center. You need to have people over there who can immediately cross-match the blood and give it to you on a priority basis. Because emergencies in gynec aspect, in obstetric aspect, is very critical. Because the blood, if you don't give blood to that patient on emergency basis, the patient is going to land into many various problems and go into multi-organ failure. So first question, IUD, counseling of the patient is very important. And one experience recent that I had, that patient was reported as IUD outside. The patient came in, my wife has got a routine way that she already checks the patient on an ultrasound first, and the patient had, fetuses had heart rate. So that patient was managed again, did an LACS, was a previous LACS patient. She was a case of PIH. So that also needs to be done. Just don't accept the report, do the clinical examination yourself, get it confirmed. What we follow at our private practice protocol is we at least have 2 ultrasounds in cases of IUDs. In cases of misabortions also, don't do it in a local setting. In individual setup, that's okay, but in institute like this, it is okay if you get an ultrasound done. But IUD, at least I would request you have 2 ultrasounds so that there are no problems. Then managing the IUD part, counseling of the relatives, I would say, is the first important thing. If you don't counsel them properly, if the IUD is referred from outside, it's a different management. If the patient has been in regular follow-up with you and presents with IUD, that becomes a totally different kind of a thing. Recently, we had experience with a gynecologist in a nearby area who had this problem. The patient was late to him. The patient presented with some, patient had passed water, but she didn't come to him early. Then the patient had an IUD. So they blamed the doctor and they were throwing tantrums at that place that how did it happen? It shouldn't have happened. But the patient was at home for 2 days. So in that cases, counseling is the most important thing. We had to involve the police personnel and everything. So in obstetric setup, that is also very important. Having a good personal relation with the police department. Second, the blood bank department is very important. I need to train our people in our hospital that obstetric emergency and medical emergencies are a bit different. When you manage a patient of asthma who is non-pregnant and who manage a patient of PPH, it totally differs. So we need to train our personnel in that way that these patients need to be managed properly. So IUD, yes, the number is very high which is referred to us, and we do manage these patients. We need to look for most important dreadful I have seen till date is DIC. We have had many patients of DIC who have come out significantly. We have had 2 maternal mortalities due to DIC because of being presented late to us. And the second part, PPH, yes, it is very significant because many a times the babies are delivered at home and sometimes in our peripheries. So we still have those patients. Second, traumatic PPH is also very common. Sometimes they try and apply forceps and everything. So after that, there's a traumatic PPH and those patients comes to us. Then we have to manage them accordingly. We have opened the patients of PPH also who have atonic uteruses, done various like Beeline suturing. Buckley's balloon is an important thing that you need to have for managing of PPH at periphery because you won't be able to do everything. My wife has specialized in doing internal artery ligation. So internal artery ligation is very helpful in cases of these PPH patients, which is very helpful in those cases. Obviously, the radiological part of doing a embolization is not possible at our place. We do have a cath lab and DSA, but the doctor who does it is not available. So that is not an option for us. So internal artery ligation, Beeline suturing, proper packing, using a Buckley's balloon, it's very useful. It's about 7,000 cost. And if you put in the balloon and just inflate it, it gives significantly better results. So these small things you need to do at periphery so that you can anticipate things and treat them properly. So timely intervention is very important in these patients.
Thank you, Nitin sir. I think after this session of 7 lectures, we will have the time for the lunch. Before that, let me take the opportunity to introduce for our ICU team. In Vishwas Hospital, we have around 250 beds. Out of these, 110 beds are right now operationals. In the ICU, we had around 28 beds that are divided into 4 ICUs. We do routinely cardiovascular surgeries, CVT surgeries, post-CVT surgeries. We do have advanced ventilators, monitors, IVP machines. Recently, we had done our first renal transplant surgery in last month. I would like to introduce my team. From the critical care unit and emergency department, I would like to request first is Dr. Sushant Sinde sir to come on the stage. He is the head of the department of emergency medicine. He is the single point of contact for the casualty. From the ICU team, our head director, Dr. Kapil Borake sir, to please come on stage, sir. Myself, Dr. Vijay Khandale, I am head of the department as single point of contact. From our ICU consultant team, I would like to introduce Dr. Satish Sarode, our senior consultant, ICU intensivist, had an MBBS, MD anesthesia, and FMB critical care. Our consultant, Dr. Debashish Banerjee, would like to invite you to come on the stage. He had done his MBBS, DA, and IDCCM. Our third consultant, Dr. Sanesh Garde, he had done an MBBS, DTCD, and he's a fellow of CTCCM right now. And our consultant, Dr. Sarita Bharadwaj, she had done her MBBS, CTCCM, and she's a fellow in IDCCM. Please come on the stage. So we are working since last 5 to 6 years, and in this ICU, we have a round-the-clock 24/7 coverage for ICU intensivists along with ICU registrars. They work in shifts, and we are tried always for the betterment of the patients. It is just not treating for the patients. We do have academics for the basically doctors who are post MBBS or post MD. We have 2 seats for IDCCM and 2 seats for the CDCCM fellowship. We do have a IDCCN fellowship for the nurses. So thank you everyone. This is time for the lunch now. I request all the delegates to head towards the lunch dining hall. Thank you, sir. Thank you.
Yeah, I think we should all break up for lunch. And very proud to say that critical care team for last year on 9th of October we have ISCCM day, that is the inception of critical care in India. On that day our student Dr. Bajaj has won first prize for his poster competition across India. His poster was on COVID encephalitis, first prize. And recently concluded conference in Ahmedabad, our respiratory therapist Dr. Shilpa Kasbe, she has won 2 prizes for best photograph in humor section. So probably we are setting up our standards high to represent at national level. And very proud to say that Vishwaraj Hospital ICU was involved in COVID steroid 2 trial. That is the largest steroid trial across world, which was published in all the major critical care journal across world. So we were very important part of that trial. So we are trying from our side our best to contribute to the betterment of the society plus betterment of academics. We are trying our best to give. We are still in a learning process. We are always welcome for inputs for such VRS Gyaan programs. Again, just reminding about selfie contest, and then we will break up for lunch, and we are coming here again because selfie contest winner will be declared at the end, and who is present will be getting the award. You can register at the counter outside. There will be ladies sitting, you can register at the counter.
The process is, once you take a selfie, please put as a WhatsApp status. Once you get more than 50 views, you can register your name and forward your selfie status with a screenshot to Bhavna, basically. And at the end of this session, basically, at that 5:30 p.m., we will announce the lucky winners. And just a reminder, at the end of this CME, everyone has to submit their feedback form. After that, you will basically able to get the CME certificates. Thank you. Please enjoy your meal. We'll start in about 20 minutes, 1:45, 1:50.
delegates, we have a small announcement to make. Today is the birthday of Mrs. Archana. She is the ICCM manager and is with me in ICCM since last 10 years. So we would like to felicitate her on her birthday. So I would request her to be on the dais, and I would request Dr. Vijay Khandale to felicitate her.
Whatever ISCCM activities are done, a lot of mails you get, lot of reminder, phone calls, election reminders, everything single-handedly is done by Archana. She is doing this for more than 10 years, not even COVID, no break. She was continuously working with us. And in Best of Brussels conference, she makes almost 3,000 phone calls in 10 days time. So I thank Archana and wish you a very happy birthday from Vishwaraj Hospital and entire team.
Moving to the afternoon session, this would be a difficult session because you'll have to battle your sleep and you will have to keep your brain awake and focus on the lectures. So we'll be having a little bit shuffling of the lectures. Kothari sir is having some urgent surgery, so we have preponed his lecture. So we'll be having 2 lectures back to back. For the 2 lectures to chair, I would request Dr. Riaz Pathan to be on the dais. Sir has done his BHMS CCMP. He has completed his BHMS in 2004 from Lokmanya Homeopathic Medical College, and he is currently the director of Adarsh Hospital since 2007 in Indapur. I would request the second chairperson, Dr. Amol Raskar, a good friend of mine, to be on the dais. He has done his MBBS, MD Medicine from Bharati Vidyapit. He has done his IDCCM from KM Hospital, and he has been working as an intensivist at reputed hospitals like KM, Sahyadri. Currently, he has his own hospital. He is the director of Chintamani Hospital, Indapur and Life Care ICU, and is working since last 8 years. So moving on, I would request the speaker, Dr. Kshitij Kothari, to be on the dais. He has done his MBBS, MD Medicine and DM Gastro from St. John's Medical College, Bangalore. He has 35 publications on liver and gastroenterology. He has done his fellowship in advanced endoscopy from PGI Jalandhar. He is currently working with Vishwaraj Hospital in the gastroenterology department.
Thank you, everyone. Thank you, Dr. Sinjay. And thank you, VRH team, for appreciation. And I'm extremely sorry that I'm just troubling you in the post-lunch period. I know it's very difficult to listen, but I will try that not to bore you much. So today my topic of discussion is how do I manage? Oh, I'm so sorry. I didn't. So today my topic of discussion. This hand is hand mic there. Hello. So, oh God, I think I'm extremely unlucky. So today my topic of discussion is how do I manage liver abscess. But I thought I will precise everything about, a little bit about liver abscess because it will be revision for everyone, including me. So first, I will start off with the introduction. As we all know that there are various ways to classify liver abscess, but on the basis of etiology, it is classified into the amoebic and the pyogenic. The word pyo means the pus. So in cases of the pyogenic liver abscess, we get the pus in that liver abscess. And coming to the, in India and worldwide, that amoebic liver abscess is more commoner as compared to the pyogenic liver abscess. In the USA, that scenario is typically ulta, means you will get the pyogenic liver abscess more common. Now, coming to the organism, amoebic liver abscess is caused by protozoa Entamoeba histolytica, and pyogenic liver abscess is almost and always caused by bacteria. But in some cases, you may find the culture, a negative culture, or a fungus or mycobacteria also can cause a liver abscess. Though it is very rare, but it's common in the patient receiving a chemotherapy of malignancy. Now, I'm just telling one line about the pathogenesis of the liver abscess. It's very interesting. When the Entamoeba histolytica when the Entamoeba histolytica reaches liver, it directly causes the hepatic apoptosis, and it eats out the neutrophils. That's why in the aspirate of amoebic liver abscess, you won't get any neutrophils. So you can directly say the amoebic liver abscess, this word is a misnomer, because you won't get any neutrophils in aspirate of amoebic liver abscess. Anyhow, that pyogenic liver abscess is directly causes necrotic inflammatory necrosis and leads to the suppurative infection of the liver parenchyma. As we all know, for amoebic liver abscess, metronidazole is considered as a treatment of choice. And in the pyogenic liver abscess, initially we start with empirical therapy. Then we use a treatment on the basis of culture. Anyway, it's very difficult to differentiate between amoebic and pyogenic liver abscess. But if you can do this, we can manage the liver abscess very nicely. That's why the confirmation of the diagnosis is very important. But it is difficult in the resources of limited settings, specifically in the rural India. So now I will move fast. So coming to the epidemiology, the amoebic liver abscess. So amoebiasis, as you all know, amoebiasis is endemic in Indian countries, and amoebic liver abscess is the most common extraintestinal manifestation of it. And it is seen in the 3 to 9% cases of amoebiasis. It's like the parasites being carried out to the liver via portal vein. And it is commonly seen in the patients living in a poor condition, or anyone is drinking the contaminated water. And young males or the middle-aged males are at the risk of getting amoebic liver abscess. Along with that, the alcoholics and malnourished are also at getting the amoebic liver abscess. But as compared to amoebic liver abscess, pyogenic liver abscess has a global distribution. Means it is not related to the poor living condition or the unhygienic condition. Incidence varies significantly between the different countries, and it is predominantly commonly seen in the older people or diabetic or the people with malignancies. Now coming to the Indian perspective, unknown, in this they have given the reason because in Indians that you can get the antibiotics easily, and when the person is having a fever or the pain in abdomen, directly they will go to the pharmacy and ask for the painkiller or antibiotics. So lot of research is saying that the reason for the cryptogenic liver abscess is that getting antibiotics from pharmacy. Now, there are a lot of causes. I think now I am clear about my ideas that amoebic liver abscess is caused by Entamoeba histolytica. Now, I would like to move on the causes of pyogenic liver abscess. So, traditionally, I think in 1980s or 1970s, appendicitis was considered as the most common cause of pyogenic liver abscess. But just because of the advancement in the treatment, hepatobiliary causes are most common, and it can be benign or malignant. So in hepatobiliary causes, whatever is causing the stasis of bile and leading to the organization of a bacteria may cause the pyogenic liver abscess. Then any infection from the abdomen or the malignancies from the abdomen via portal vein, it can be carried out to the liver, and this may lead to the pyogenic liver abscess. Now, if there is any septic focus anywhere in the body, such as endocarditis, ENT infection, and dental infection, that may also cause the pyogenic liver abscess. And even trauma is also one of the common reasons. Why I am telling all this? Because this is very important in taking histories. I know it's very boring, but it is important taking history. Now coming to the microbiology of pyogenic liver abscess, E. coli and the Klebsiella are the
most common cultured organism from pyogenic aspirate, followed by Proteus, Pseudomonas, and the Streptococcus. Bacteroids and the Fusobacterium are the most common anaerobic species. In children, the Staphylococcus aureus is considered as the most common cause of a liver abscess, and it is also common in patients with impaired host resistance, including chronic granulomatous disease. As I already mentioned, that fungal abscess of the liver may be occurring in immunocompromised host. Now I'm coming to the diagnosis. So everyone knows that nothing is like important than a clinical presentation. But in such cases, that clinical presentation of all the liver abscesses are subtle. Means it's very difficult to distinguish between the pyogenic liver abscess and amoebic liver abscess. And most of the patients present with pain in abdomen, fever, and anorexia. And these types of symptoms are common with lot of diseases. Most of the patients comes to the OPD, and if you ignore a little bit, and we can diagnose it as acute gastroenteritis or acid peptic disease. So it's very important to take a thorough clinical history or a thorough clinical examination in the cases who presents with all these three features. So on clinical examination, you can get tender hepatomegaly in approximately in the 80% of the cases. Jaundice may or may not be present, but if the jaundice is present, it may denote the abscess is large or multiple, or it is compressing the biliary tree, or sometimes in cases of alcoholic hepatitis or the concomitant alcoholic hepatitis may cause a jaundice. This liver abscess sometimes may irritate diaphragm or pleura and may lead to the cough with or without expectoration and cause a pleuritic chest pain. Now, all these symptoms are common with when the abscess is in the right lobe. But sometimes that this abscess may present in the left lobe, and the left lobe is may present with a very severe symptoms. Sometimes it may present with toxemia, deep jaundice, or encephalopathy. Or when the abscess is obstructing when it is obstructing the inferior vena cava, it may lead to the ascites or the other symptoms such as the pedal edema. And when the patient of a liver abscess presents with cough with copious expectoration, then you have to suspect the rupture. There are other features that's not much important, such as leukocytosis, raised inflammatory markers, inflammatory alkaline phosphatase, or abnormal liver function test. All these are they don't have real value in differentiating the liver abscess and the pyogenic liver abscess. Imaging technique is extremely useful to demonstrate the space occupying lesion in liver. And ultrasonography is initial investigation of a choice when you are suspecting a liver abscess, and it can detect up to 2 centimeter or more size of the lesion. CT is indicated only when that suspicion of a complication is high, or the report of sound report is little bit in dilemma. Now coming to the next things, like for the confirmation of the pyogenic abscess, blood culture has a very important role, and about in the 50 to 70% of the cases, this blood culture is positive in cases of pyogenic liver abscess. That's why it's advisable to perform a blood culture of any patient in suspected of liver abscess on entry. For entamoeba histolytica, this ELISA or the serology has a limited value in cases of in countries like India, but the antigen testing or the lateral flow assay has a good role in diagnosing the entamoeba histolytica. Coming to the fine needle aspiration, it is the gold standard for the pyogenic liver abscess, but it is not the case. It is not a case with the amoebic liver abscess, because in aspirate shows only the less than 25% cases of amoebic liver abscess shows the tropocytes in the liver aspirate. But macroscopically, that can give preliminary information about the kind of abscess. Means amoebic liver abscess, it is odorless, chocolate brown or thick. And pyogenic liver abscess is usually purulent and foul smelling. It's just because of the anaerobes. now I think there is no confirmatory test to diagnose or to differentiate between amoebic liver abscess or pyogenic liver abscess. But I think this is our amoebic liver abscess and this is our pyogenic liver abscess. I'm not explaining much about this X-ray and all these things. But in this amoebic liver abscess, we can see that there is a border is regular. And this is homogeneous hypoechoic mass with regular border. But in the pyogenic liver abscess, you can see that this is irregular borders with some hyperechoic spots. So the lot of people says that this can be the differentiating features to specifically in the rural Indias or where the situation or where the resources are limited. This can be useful to differentiate. This feature is useful to differentiate between amoebic liver abscess and pyogenic liver abscess. This is about that. I just mentioned about aspirate. This is a chocolate brown, and this is the pinkish fluid. This chocolate brown is known as anchovy sauce. Actually, it is because of like when anchovy sauce is admixed with blood, then it is known as chocolate brown. And this pus is admixed with blood, then it turns to be pink. So from these two, we can differentiate that what is amoebic liver abscess and what is pyogenic liver abscess. This is just the difference between amoebic liver abscess and pyogenic liver abscess. One thing I forgot to mention you, that the amoebic liver abscess is usually single and typically presents in the right lobe. While the pyogenic liver abscess is either single or multiple, and it can present in any lobe. Now the real topic I'm coming to for the discussion, that is the treatment of the liver abscess. So it consists of it comprises three types of management. First is medical management, radiological drainage, and the surgical management. And the evidence for the guiding the treatment of decisions such as timing and indication of radiological intervention. That is one of the most important thing. There is no, that is limited, means there are no clear-cut guidelines that when to drain and how to drain. But coming to the antimicrobial guidelines, they says that, this is the Indian guidelines, which says that if you are suspecting a liver abscess, you have to start with empirical therapy targeting both amoebic liver abscess and pyogenic liver abscess. Now first I will cover the management of the pyogenic liver abscess. So here the principles are: you have to drain the pus, institute appropriate antibiotics, and deal with any underlying source of infection if present. So percutaneous drainage combined with antibiotics has become the first line and mainstay of treatment for the most of the pyogenic liver abscess. So the initial antibiotic coverage and pending culture results should be broad in spectrum. And you should start with any third generation cephalosporin or fluoroquinolones along with the metronidazole to cover the anaerobics. Alternative regimens are like carbapenems or the beta-lactams can be used. So these antibiotics you have to add initially parenterally, at least for the 2 weeks. Then after 2 weeks you can think about oral medications for 6 weeks. But in cases of multiple pyogenic liver abscess, those are too small, then you need to start with only antibiotics, because it's very difficult to drain those things. Now there is controversies between the researchers that when to do a single time aspiration and when to do a percutaneous catheter drainage. So in cases of a pyogenic liver abscess, when the pus is too thick to be aspirated and abscess is greater than 5 centimeter in diameter, or the wall is thick, or the abscess are multiloculate, then only you have to go for a percutaneous catheter drain. Otherwise you can do a single time aspirations along with antibiotics. But even when the patient presents with intraperitoneal rupture or the failure of a non-operative treatment, or if you drain the pus and it leads to a complication such as bleeding and intraperitoneal leakage, then you have to go for surgery. And the mortality of a surgery depends on the multiple factors. So these are the factors such as septic shocks, jaundice, coagulopathy. All these things will determine the mortality due to the surgical things. Actually, this slides is I thought this is interested, but this is actually for the surgeons, the people who are going for a surgery. So I think most of the people must be aware about it that, and generally the surgeons, that abscess located in the dome of the liver can be approached through the bed of 10th or 11th transpleurally. I just want to make this point that Herman et al. Advocating the surgical drainage as a good alternative as a first step in septic patients where delay in adequate drainage can lead to the high mortality and morbidity rates. So this was published in 2015 Journal of Visceral Surgery. Now, just last 5 minutes, sir. So as we all know, the amoebic liver abscess is caused by Entamoeba histolytica. So here the nitroimidazole is a treatment of a choice, and it leads to it cures approximately 90% cases. And the therapy should be given for at least 10 days. But the relapses rates are very common with the 10 days. That's why it should be given to the 3 weeks. And the dose of metronidazole is 40 mg per kg in a divided doses. Now the aspiration, the routine aspiration of a liver abscess is not indicated for diagnostic and therapeutic purposes. But the indications of drainage are when there is a lack of clinical improvement in 48 to 72 hours, or when there is a left lobe abscess, or the thin rim of liver tissue around the abscess, or if the abscess is very large, then you have then only there is indication of a large liver abscess. So just because of a less time, I am not going to discuss the studies. But there was one, this study was like published by Khanna et al. In 2005, so which says that approximately 50% of the cases were not manageable with the metronidazole. And this study was published in World Journal of Gastroenterology 2008, and which says that that early aspiration of a liver abscess may lead to the response to the antibiotic treatment and reduces the hospital stay. Then ERCP should be done in the patients with abscess, biliary communication, biliary stenting hastens the clinical recovery and allows the early catheter to drain. So these are the studies I have mentioned. Just because of less time, I cannot discuss the things. Of all, I want to just concentrate on this study. So this is a systemic review and meta-analysis they studied the 570 patients from the 10 randomized controls trial, and it is recently published. It is in 2019. It is by the AIMS Delhi people. So the some bullet points about this study that they have mentioned that mainly about the therapeutic drainage. So therapeutic drainage of uncomplicated liver abscess is still an area of controversy. And we can see the failure rate of metronidazole monotherapy from 7.1% to 72%. So here, what they have mentioned that adjunct percutaneous aspiration compared to metronidazole alone results in early resolution of pain and tenderness in a patients with medium to large amoebic liver abscess and not with the small amoebic liver abscess. So this means that you have to drain the abscess of size more than 5 centimeter. And this one, that percutaneous catheter drain is better than aspiration for larger amoebic liver abscess. However, quality studies on catheter drainage plus drug versus drug alone are still lacking. And in this study, they also mentioned that this pain in abdomen and tenderness may be considered as an indication for drainage, whatever may be the size of the liver abscess. So these are the all studies, like 10 studies. I am not going into the detail of it. And there are some points on the drainage that percutaneous catheter drainage is preferred over the catheter drainage is preferred over the percutaneous needle aspiration, and catheter removal is usually recommended when the drainage output is less than 10 ml per day, and the duration of catheter removal may vary. However, early removal is not associated with higher healing rate, and there are some evidences which says that even if any patients present with rupture of the cyst into the peritoneum, which can be easily managed with the the catheteral drainage. So long-term follow-up is like the mean time of disappearance is on sonography is approximately 6 to 9 months. And relapses are very uncommon with this amoebic liver abscess, and the sonographic abnormalities does not warrant any continued therapy. So this is whole, this flow chart says a lot about liver abscess or the liver abscess. So if we do the ultrasound and if we get the liver abscess, if it is present in the right lobe of the liver and the size is less than 5 centimeter, then you can directly go for the medical management. If the size is more than 5 centimeter, then you can go for drainage plus antibiotics. And if this less than 5 centimeters, you have to wait for 3 to 4 days. Even on this also, there is a lot of controversies that when we should consider that the failure of a medical treatment. But still, that lot of researchers say that even after if the 4 to 7 days the patient is not responding, then you have to go for drainage. So this is again that summary of the management of the pyogenic liver abscess. So at the end, I just wanted to say that there is like there is a lot of involvement in the management of the liver abscess. In the 1970, there was like a surgery was the treatment of choice. Nowadays, only the percutaneous drainage and antibiotics are the treatment of choice. That's why the precise diagnosis of the etiology and the complication is a pivotal for appropriate management. Thank you. Any questions, sir? Yes, sir. Yeah.
We see liver abscess.
Yes, sir, yeah.
As the intensivist.
Yeah.
It's most of the time reported on ultrasound.
Yes, sir.
Liver abscess. So it's still a gray area. It's liquefied, non-liquefied. Should we go ahead with CT? Should we go ahead with MR? Should we tap it? Should we not tap it? So this is a bit gray area as an intensivist we always feel. So
Yes,
what
sir.
a guideline says, and are there any indications where we have to go ahead with CT or MR or percutaneous drainage?
Sir, actually for the CT there is no clear-cut indications. Most of the research or most of the paper says that initial investigation of choice is ultrasound only. But still, when the clinical suspicion of liver abscess is high, then and then only you should go for the CT. This is the indication of CT, because on the ultrasound most of the time we can say that the liver abscess is liquefied or not, means it is drainable or not. So CT is not indicated unless and until we are suspecting the liver abscess just below the dome of the diaphragm, because which can be missed by the ultrasound abdomen, or when you are suspecting the rupture of the cyst or any complications, then only the CT scan is indicated. Otherwise, yes, it is. Please.
Actually, I'm Dr. Oswal. I'm a little late in this session, but CT is indicated if you plan a surgical intervention in this case, because we not only come to know how close it is to the surface of the liver, how deep it is, and how we should go ahead, whether a laparoscopic drainage is feasible or whether we need to do a open drainage.
Yes, yeah.
That is also one of the indication for doing a CT. If you plan to go ahead for a surgical intervention.
Yes.
Yeah.
Yeah, but even like nowadays, like concept is coming that intraoperative ultrasound, that is also the...
Intraoperative ultrasound is...
I know it's very difficult.
But it is very, it is not very commonly available.
Yeah.
But CT will give you a technical in which segment of the liver it is and how difficult it is going to be to dig the liver and go into that abscess.
Yes.
And whether it will be feasible to do it laparoscopically.
Yes.
The surgery, I'm not saying, but the indication for CT is to plan the surgery well.
Yes.
To plan the surgery. Yeah, when to go ahead with the surgical intervention. That is, sir wants to ask is, do we require surgical intervention in all cases of liver abscesses?
No, actually, sir, all there has like a little bit difference in in case of amoebic liver abscess and the pyogenic liver abscess. What the guideline says that if suppose that in cases of amoebic liver abscess, if the size of the lesion is less than 5 centimeter, you should always try for the medical management, and you have to see for 4 to 7 days. And if it is not responding, then you should go for the percutaneous drainage. And if this percutaneous drainage is not responding, this is again for like 4 to 7 days, then you can plan a surgery. This is what I read. And otherwise, in cases of, for example, if the patient is having the percutaneous drainage and it has a complications, means like it started bleeding or again the pus is oozing out in the abdomen, then you can plan the surgery. And in cases of the laparoscopy,
Basically liver abscesses, the pyemic liver abscess, pyogenic liver abscess are, the patient is also very toxic.
Yeah.
And they are not a single abscess, they are multiple abscesses. So doing a surgical, just aspirating one or doing a surgery for is not indication. So these abscesses are more commonly tackled with medical line of management. When do you go ahead with the surgery for a liver abscess is, it is a single large abscess and patient is not settling down with medical line of management, and you foresee a complication in these patients, you go ahead with the surgical management.
This actually
Surgery is only indicated if we are seeing that the patient is turning to be non-responding to medical line of treatment, and we are expecting a complication in that he might rupture or he might burst into the abdomen or into the chest cavity and not responding to the early line of management.
Okay. But still...
Why this question? Probably there are two things when we look from the views of intensivist. As a part of source control, we are always happy taking out whatever pus wherever we collected, whether it's a percutaneous drainage, a surgical drainage. This is what we are mostly interested in. And second, more important thing probably, the choice of antibiotics for the pyogenic liver abscesses.
Initially, actually, I have mentioned, sir, actually we should start with this mention that the third generation cephalosporin or fluoroquinolones.
So my question here is not about that.
Yes,
my question is about the dose of metronidazole in this, because this is very important to highlight the dose of metronidazole, particularly in liver abscess, is different.
It is double the dose, means it's like 800 mg milligram per day. Generally, it is a 40 mg per kg per day. The dose is double compared to the acute gastroenteritis. I think so.
Okay, so it's very important when you are dealing with liver abscess, the dose of metronidazole what you are using has to be the double the dose what actually you are using for other conditions, and you have to be aware of that. Otherwise, you will not expect that abscess to get resolved. Then our surgeon friends will be happy that we don't know the adequate dose.
Anyways, like... No. That was the percutaneous drainage. That's what I wanted to mention about it. This you are talking about, sir. This one, no? So actually, that generally in the pyogenic liver abscess, people think that we can do the single needle aspirations. But in such cases, we have to do the percutaneous catheter drain. Yeah. Pigtail we use. Pigtail we use.
You can start with the pigtail, and if not, you can even put in a larger drain than a pigtail. If the pigtail is not solving the issue, you can put a larger drain also.
Okay, but what do you say about this? Laparoscopy is better or the PCD is better?
Laparoscopy is always better because you can do it under vision, and you can see that everything is cleaned out well. You can give a good betadine wash and put the drain under vision into the cavity.
And but how we manage with wash and all this? Is it okay to give the lavage?
Yes.
It's okay.
Yeah.
Okay.
There is very less chances of spillage.
Okay.
Because it is always the suction is under control.
Oh.
So we first drain the abscess completely, then give a good lavage also.
Okay, sir.
Yeah.
Sorry? Yes. This. Yeah, TAP and ERCP, both the things. This I wanted to mention the study. This MEB cleaver abscess I mentioned, but just because of the less time, I could not discuss the study. So this was my topic, that endoscopic biliary drainage in a patient with MEB liver abscess with biliary communications. You wanted to ask this only, no? So this, here you can see, but this is a bit old study which was published in 2008. In this, so sorry. So they studied 586 patients, and there was a fistula. So they did the catheter and ERCP both together. So they found out that in which the ERCP was done, that drainage was. I think you asked the same question, or did, okay. Then you have to do. No, both the things you have to do. You have to give a trial of ERCP and the drainage.
Sorry to interrupt, there was a lot of discussion, good discussion actually, but we are running short of time. Thank you for the short, crisp and to the point presentation by Dr. Kshitij Kothari. I would like to request Dr. Shashank Adgudwar to felicitate Dr. Kothari sir. And thank you Oswal sir for his inputs. Of late, the patient-doctor interactions or altercations has been on rise, and most of the time the topic related to pregnancy is present. So maybe that's why we have kept 2 lectures on complications in pregnancy. We had an excellent lecture on breathlessness in pregnancy by Dr. Nitin Rane sir, and now we have other dreaded complication in pregnancy, that is bleeding or coagulopathy. So I would like to invite Yogini Patel madam for the lecture. She has done her MBBS from KIMS, DGO from Wanless Medical Hospital, Miraj. She has a vast experience in this field, working in various prestigious institutes, and currently she is with Vishwaraj since last 4 years. So I would invite her.
Good afternoon, everyone, and thank you VRH management and Dr. Kapil sir especially, and all of his critical care team to give me this opportunity, and thank you so much to the chairpersons too. Topic given to me today is coagulopathies in pregnancy. Now this is again a very vast topic which includes a very minor thrombocytopenia to the dreaded DIC which Dr. Shinde was talking about. I won't be attempting to go into the detailed pathophysiology in front of all these intensivists and physicians, but I would stick to my gynac side and what we can do to prevent such catastrophic events. That would be my main topic today. Now pregnancy begins from a good news and is expected to end with a good news, and usually it does. And thankfully it ends with a good news only, but then of course once in blue moon there is a patient who needs, who lands up in emergency and is admitted to the ICU. And most common and dreaded complication of pregnancy again is coagulopathy, and that is DIC. Having said that, not all coagulopathies are severe, but then yes, the severest is the DIC. Now let's begin. Yeah. Okay. So this is a hypothetical case. Mrs. XY XYZ, 25-year-old, 32 weeks of gestation, and she has no complaints. She's a regular registered patient. She has done all her investigations on time. Her pregnancy so far has been uneventful, and when you do a third trimester CBC, which we do routinely, she comes up with this report. Hemoglobin a little on the lower side, and platelets mainly are 1 lakh. Okay. So I think those who are, if there are any gynecologists in this audience, we see such patients a lot in the OPD where the platelet count is a little on the lower side. Now less than 1.5, of course 1.5 lakh, ranging somewhere around 90,000 to 1.2. Okay. So what do you do for these patients? I really think that there is no active management in this patient, but yes, we have to keep a watch on such patients, and maybe a repeat CBC in 2 weeks to just ascertain that this is nothing more than the usual gestational thrombocytopenia. Of course, if she comes later with any symptoms or her platelet count start dropping, she needs further investigations. This is case 2, Mrs. ABC again, a 21-year-old, okay, early, she's her age is 21, 28 weeks of gestation, and she comes to your OPD with complaints of petechion, lower legs, bleeding gums since 2 weeks. Past history of easy bruising is there when you take her history, and maybe she has neglected such small bruises and bleedings in the past. Not investigated, that's why not investigated before for that, and we do a CBC, and then this is her report. Okay, so now this patient is a patient whom we can't just reassure and send home. Investigation for the whole coagulation profile, and such patients of course need reference for physician and hematologist for further investigation and management. And case 3, Mrs. XYZ, she's a 35-year-old female, 33 weeks of gestation, known case of PIH, diagnosed at 28 weeks of gestation, on tablet labetalol 100 mg twice a day. Her ANC visits have been irregular. She comes with pedal edema, urine protein, and her last recorded blood pressure around 10 days back was 156/108. And then she comes to you with the complaints of pain in abdomen, PV bleeding since 2 hours. On examination, her blood pressure is 160/110, proteinuria 3+, uterus is stony hard, FHS not audible, bleeding PV present, and this is again a nightmare case. Now this is most likely this case is of abruptio placenta. Abruptio placenta doesn't need any further investigation. You can just initial examination of the patient, and you come to know what you are facing. The baby is lost already, but now we cannot waste time to save the mother. I can't reiterate the importance of immediate treatment in such patients, and of course the consumptive coagulopathy which sets in after abruption, it needs a multidisciplinary approach, so many people working together at the same time. Like cardiologists have their golden hour, of course these such patients also, obstetricians have their golden hour for such patients, and the earlier you start the management, there is more likely the chance of saving the patient at least. Now, coagulopathies in pregnancy, they precede pregnancy. Some patients already give you the history of coagulopathies when they come to you. They develop during pregnancy or they are induced by pregnancy. Okay. Now, the list is endless, but let's see at the important ones. Now, 75% of all thrombocytopenias which come in pregnancy are gestational thrombocytopenia, thankfully. 20% are DIC in pregnancy, which we'll be talking about, and 5%, the remaining 5% are immune thrombocytopenias and others. Gestational thrombocytopenia, like I said, the platelet, they range between 1.5 to 1 lakh. Less than 1% cases, they have less than 1 lakh, and if they go below 80,000 or develop any bleeding symptom, they start with any bruising, bleeding anywhere, then they need further evaluation. Then it is not just gestational thrombocytopenia, it can be something else. Now the cause of gestational thrombocytopenia again is hemodilation, which occurs in pregnancy and especially in the 3rd trimester. Also increased splenic mass can be implicated. It does not need any active management, like I said before, except repeat CBC in 2 to 4 weeks, and of course the counseling the patient regarding what is happening to her and to remain calm. Immune thrombocytopenia, again most common what we see in pregnancy is primary ITP. Secondary to SLE, lymphoma, leukemia, Apla syndromes, hemolytic anemias also come with thrombocytopenias. The one-line pathophysiology is the IgG antibodies are directed towards platelet surface glycoprotein, which are destroyed in the RA system, as simple as that. How does pregnancy affect ITP? Does pregnancy affect ITP as such? Yes, frequent relapses have been noted in patients who are in remission. So, when you take a history and you know she tells you that she's a diagnosed case of ITP, you have to be alert that you may have to face a relapse in pregnancy, and that may be because of the hyperestrogenic state which is there in pregnancy. Management, again, meticulous ANC, best treated at a multispecialty hospital. Very few cases have spontaneous remission when they are pregnant and they have an active case. Most patients need platelet transfusions. Platelet, if they go, if the count drops to less than 30,000, and again corticosteroid therapy can be given, IVIGs can be given. Very rarely patients need splenectomy, and sometimes splenectomy can be paired with a C-section, and such patients then they go in remission very nicely after they are delivered. Cytotoxic agents which are usually used in ITP, of course they can't be used in pregnancy because of the teratogenicity. Fetal effects of such extreme thrombocytopenias in immune thrombocytopenias are the IgGs, they do cross the placenta leading to thrombocytopenia in fetus as well. ICH and other bleeding tendencies are very common in such fetuses, and many times they land up in stillbirth, IUDs, or we have to deliver the patient preterm in order to prevent such catastrophes. There is something called a thrombocytosis of pregnancy too on the other end of the spectrum, but it is very less common. Platelets can go to more than 4.5 lakh, by definition maximum up to even 8 lakhs. The causes being iron deficiency anemia, which is very common again in India in pregnancy, infections may be inflammatory diseases, and very rarely malignancies too. And the treatment for thrombocytosis is just treat the cause and nothing else to be done apart from the treatment of cause. Now, why do we have to talk so much about coagulopathies in pregnancy? Is because pregnancy has certain effect on the coagulation cascade in our body. Pregnancy itself is a procoagulant state, everybody knows that. And that is because of the hormonal and physical changes, of course, hypoestrogenemia, pressure of the womb which slows down the venous return to heart. All these things have been implicated, and that's why we are especially worried for obese patients, patients who are on bed rest, who can't move a lot, and we have to take extra care for such patients. And all this is nature's way to prevent PPH. Okay, so the procoagulant state is a nature's way of preventing PPH. And of course, again, it is seen that the plasma concentration of factor 1, factor 7 to 10 are increased, platelet activation is enhanced, but platelet count is reduced by 10%. So I think nature has its own way of balancing things, and augmented yet compensated coagulation to maintain the uteroplacental interface, because that is very important. The baby should not be affected because of the procoagulant state. Now we come to the severe coagulopathies caused by pregnancy, and many reasons are there why patient lands up in DIC. DIC is again the systemic activation of coagulation cascade by circulating thromboplastic material with secondary activation of fibrinolytic system. This is a rate 0.03 to 0.3% of all pregnancies develop DIC. Though we see that it is 0.03% to 0.3%, taking into consideration the huge number of pregnant patients in our country, this number amounts to a lot. So causes of DIC in pregnancy, the first and foremost again is abruptio placenta. Next would be amniotic fluid embolism. HELP and preeclampsia, again HELP is an acronym for hemolysis, elevated liver enzymes and low platelets, which is a complication of PIH. And if it is left untreated, it again progresses to abruption and DIC. MTP, during MTP when there are perforations and shock. PPH again, basically it is hypovolemic shock, but then later it can lead to DIC. placental retention, IUD, especially if the IUD is retained for more than 4 weeks. Sepsis, though it is uncommon in the urban areas, it is extremely common in the rural areas, H-mole pregnancies and malignancies again. So abruptio placenta by definition is the separation of placenta from the implantation site, partially or totally before delivery. Now every word is important here. After delivery it has to separate or else there is a DIC, but when it separates before delivery, that is abruptio, and the types are concealed, revealed, mixed and chronic. Concealed is the dangerous one where we have no idea how much the patient has bled inside the abdomen. The diagnosis, again, like I said, history and physical examination is enough to diagnose a patient of abruption because she comes with that stony hard uterus. She may complain of, loss of, sometimes they do say that the fetal movements were less since 1 or 2 days, but then since today morning I am not able to pursue any movement. Then she will, initially she was a patient of PIH, but when she comes to you, she has hypotension, tachycardia, all these things. Immediately we have to send blood for cross matching. Sonography only if the patient is stable and it is easily available. Sonography is not needed for treatment of abruption. Routine investigations, of course, with the PIH profile and coagulation profile has to be sent, and all these will of course confirm our diagnosis of abruption. Management is immediate delivery, of course. Removal of the cause is the treatment for abruption. It doesn't matter whether the patient is preterm or term. C-section is needed very rarely. Even obstetric hysterectomy may be needed, and so it is better to, when you are counseling the patients, for such patients' relatives, we have to tell them about obstetric hysterectomy too. Of course, replacement with blood and blood products to facilitate adequate perfusion, which restores the hepatic and endothelial circulation. This is again a multidisciplinary approach. A team is needed. I mean, when a patient comes with abruption, it's not like the doctor will come and then she will take the history and then she will, try to arrange for the OT, arrange for the blood. No. Everything has to go on simultaneously. One large bore needle in one hand, catheter, somebody else has to do the catheter, cross matching, very detailed and empathetic counseling and all necessary consents. This I am telling, again because patients come, like I said, patients when they are told that they are pregnant, they are in that sort of mood, and then when they land up in such complications, and when we tell them that you have lost your baby and you may have to, your mother, even the woman has to be in ICU, maybe she may land up in DIC, we may have to remove her uterus if needed to save the patient. The reaction that comes from the relatives is extreme. So a very empathetic counseling is needed for such patients. Amniotic fluid embolism next is, of course, hemodynamic compromise, respiratory compromise and DIC, that is the triad. Hemodynamic and respiratory compromise, if treated, patients don't land up in DIC for AFE. Predisposing factors, when you will have to be alert that this patient will go in AFE, rapid labor, meconium stained liquor, tears and extensions into the uterine vessels when we are doing a surgery, elderly multipara, post-term pregnancies, eclampsia again, abruption, and rate is more in C-section than in a normal delivery. The causes of AFE is again fetal cells and amniotic fluid when they reach the maternal circulation and they cause the endothelial damage. Cardiorespiratory arrest during labor, C-section or within 30 minutes of delivery of placenta has to ring a bell that the first diagnosis that should come to mind is AFE. Deranged coagulation profile again ABG. Hypertension followed by hypotension, and then such patients usually don't have any kind of infectious indicators like fever or something, and then land up into DIC. Management again is mostly the same. If CR resuscitation and ventilatory support works, if successful, DIC will be prevented, but most patients progress so rapidly that they usually end up in DIC. Now, having talked all this about coagulopathies, is there any way that we can prevent coagulation disasters in pregnancy? Now, everything cannot be prevented. Some things occur so suddenly that we can't help.
But few things always help. Detailed history taking of past and present events and illnesses. Now, when patients come to us, we are very busy in, confirming pregnancy, doing the UPT and their sonography, or dating scan, this test, that test, investigation. We are all, we tick all the boxes of what has to be done. But I really think that first ANC visit has to be dedicated a lot of time with talking to the patient, and this is going to help you in future to deal with this patient. When you ask the patient about history of, like I said, easy bruising, or is there any malignancies in the family, she had any major illness in the past, all these things you have to ask her. Only then we can come to a diagnosis. Family history again is very important in some thrombocytopenias. Patients of PIH, mostly who land up in DICs and coagulopathies, counseling is very important, and even noting in your OPD sheet that you have counseled the patient about warning signs. What is the worst case scenario that she can have if she lands up into complication, when and which hospital to reach. Like I said, we have to maintain that golden hour treatment. Again, very high degree of suspicion in all patients who come to you with PIH. Very meticulous antenatal care, frequent visits. It's okay if you want to see the patient and call the patient every week for checking her blood pressure or doing her investigations. Identifying best and nearest tertiary care center, like I said, because it is a multidisciplinary approach, and transport services again, and treating the cause. Patients, if the patient has IUD, you have to terminate the pregnancy as soon as possible with a very good antibiotic coverage. Treating all infections. If the blood pressure is uncontrolled, you try to control the blood pressure, but if it is not being controlled, even if the baby is preterm, please deliver the patient and don't, reach the stage of HELP or eclampsia or DIC. Perforations again, best be avoided. Now, just 2 minutes about this. What I have been seeing in my recent practice is that there is a shift of type of patients coming to the OPD. Patients nowadays are working in the house and outside the house too, and they already come with certain level of stress. Maybe they are treated for infertility before, and then they have that stress of getting pregnant very soon. They have the stress of managing the home and the office and everything, and all the investigations that we bombard them with. So stress has been implicated in so many chronic diseases and even malignancies. Now, can it be implicated in coagulopathies also in pregnancy? That is what I was just thinking about. Because I had a patient, she was diagnosed with PIH at 28 weeks. In 2 to 3 weeks, I haven't seen such fulminant PIH develop in a young female. She was again in IT industry. Whenever she came to me, she never talked to me. Okay, it was just she will come and sit, very intelligent patient, but she will never ask me any questions. When I ask her any questions, she will just answer me in 2 to 3 words. No relative with her anytime when she came to the OPD. And she always seemed on the edge and very tense. And she came with such fulminant abruption, extreme hypotension and tachycardia in the ER. Her baby was already lost, and only because I'm lucky to be working in a multidisciplinary setup, we could save the patient. The patient was on ventilator for 3-4 days, but then she came out of it. And then I tried to retrospectively investigate that why was she so tense when she came to me. I even did her APLA test. Everything was normal, nothing to point out. And then when I talked to her relatives especially, and then they said that she has been like this since we know her. And then I sent her to a psychologist, and that psychologist digged her history, and it came to know that she had extreme personal trauma in her childhood. She had lost her mother and so many other events in her family, and that was the reason she always used to be tense. So I really think when we see patients in our OPD, our ANC care should be a holistic care aimed at reducing stress too. Now, this may seem like, out of syllabus for us. There are psychologists, there are counselors which we can hire to, reduce this kind of stress, and indirectly stress is causing rise in blood pressure and is causing such catastrophic events, though not directly. So I really think if we can, go home with this thing in mind, there is something, one new thing which I have told you. Okay. Thank you so much. Anything, sir?
Thank you, Yogini madam. Any questions? I would request Dr. Kiran Shinde, senior gastroenterologist, to felicitate madam. I would request Kiran Shinde sir to felicitate Dr. Riaz Patan sir. Thank you, Patan sir. I would request Kiran Shinde sir to felicitate Dr. Amol Raskar. Thank you, Dr. Raskar.
Thank you, Riaz sir. Thank you, Amol Raskar sir. We'll move to the next session. The next topic for the presentation is non-hemorrhagic acute stroke and how do I manage by Dr. Rajendra Sawan sir. For this session, I would first like to invite on the dais Dr. Sumit Kakade sir to moderate the session. Please welcome sir. Dr. Sumit Kakade sir has done his BMS, MD Ayurvedic. He is the chairman of Anandi Multispecialty Hospital and CT Scan Center in Jejuri. He is the secretary of Purandar Medical Association, Saswad, and he is also the director of Anandi Cooperative Multispecialty Hospital, Pune. For this session, I would like to invite second chairperson, Dr. Sushant Shinde sir, to please come and sit on the Dr. Sushant Shinde sir is head of the Department of Emergency Medicine and Medicine Department in Vishwas Hospital. For this lecture, I would like to invite Ajna Chavan sir to please come on the dais. Dr. Chavan sir, he had done his MBBS, DMRD, DNB, Irregular Diagnosis from BJ Medical College, Pune. He has done his DM Neuroradiology from the NIMAS, Bangalore. He did his fellowship in interventional radiology. He has multiple publications, papers, and guest lectures in various conferences. His main areas of interest are aneurysm coiling with and without neck remodeling techniques, cerebral AV malformation, immobilization, carotid and vertebral artery stenting. Over to you, sir.
Thank you. So I'm a neuroradiologist, so I'll stick to neuroimaging and neurointerventions. I won't be talking about IV thrombolysis. So about stroke, ischemic stroke is more common compared to hemorrhagic, and that is what we are going to discuss. In 2000, I think around 2000, there was a NINS trial, and that trial has changed the entire scenario of stroke therapy. People started giving IV thrombolytics, and in those cases, those trials, the imaging played very important role. So one important aspect of imaging is to differentiate whether the stroke is hemorrhagic or ischemic. And after that, is there anything which can be salvaged, which can be saved? That is the most important aspect of the imaging finding. And there was a concept called penumbra. So the umbra, the central portion, which is infarcted tissue, is not discussed. Only the peripheral portion, which can be saved, which can be salvaged, is called as penumbra. So what is a penumbra? It's basically the peripheral portion of the brain parenchyma where the blood flow has decreased compared to the normal value of 50 to 60 ml to 20-25 ml. But the function of the neuron is still preserved. The neurons are not functioning, but they are not dead also. And those neurons can be salvaged with either IV thrombolytic therapies or intra-arterial thrombolysis therapies. And that is what the most important aspect of the stroke treatment. So we need to concentrate on the imaging findings which tells us about the penumbra, what is the size of the penumbra, is there any penumbra or not, and can it be salvaged. This is the routine question, whether we should go for CT, whether we should go for MRI. The best thing is CT because time required for CT in brain imaging is hardly 20 seconds, 30 seconds nowadays. While MRI takes almost at least 3 to 4 minutes. Most of these patients, especially with large vessel occlusion disease, they are drowsy and they are moving a lot. So to monitor these patients in MRI gantry is very difficult task. So CT is ideal thing. It can differentiate hemorrhagic versus non-hemorrhagic patients. And plus, the monitoring of the patient is also important thing. Now suppose the clinical findings and the imaging findings are suggestive of large vessel occlusion. The routine protocol is you rule out hemorrhagic stroke, you give IV bolus of thrombolytic therapy, and then in the same setting, in the CT itself, you go for the CT angiography. So the IV bolus is given in the CT room, and then the CT angiography is planned to see the extent of the thrombus involving the large vessel. Initially, we used to do CT perfusion, but now we think the CT angiography is ideal and best substitute for CT perfusion study because most of the setups won't have softwares to process those CT perfusion images. So this is the routine thing. Hemorrhagic stroke, acute hemorrhage looks like bright thing. This is the hypoxic insult. Again, these patients are ruled out of IV treatment. You can have a large bleed or tumor with large bleed. We can have a large EDH, extracellular hematomas, subdural hematomas. All those things can be differentiated from ischemic stroke based on plain CT study. Now we'll move to the imaging findings which tells us about the cause of the stroke and the effect of the stroke. So the first sign which was described was hyperdense vessel sign. It was initially described as a hyperdense MCA sign, which is suggestive of thrombus lying in the M1 segment of the MCA. And that thrombus gives hyperdense appearance compared to rest of the normal vessels. And whenever you see this, which is focal in one of the vessel, that is suggestive of abnormality. That is suggestive of acute thrombus occluding that vessel. Now, most important things, these are highly specific but less sensitivity. We can have an atheromatous plaque in that M1 segment, which can look like hyperdense. The patients with raised hematocrit value can have an increased density, but differentiation will be these patients will have a generalized increased density of the vessels, while thrombus will have a focal hyperdensity. We can have a hypodensity occluding the vessel, and that happens especially if we have a fatty plaque in the cavernous or in the carotid bulb region which ruptures, migrates distally. So we can have a hypodensity in that region occluding the vessel. If you have a pathology of the adjacent brain giving rise to hypodense appearance of the surrounding brain parenchyma, can give relatively hyperdense appearance of the vessel. So these are some precautions which need to be taken while interpreting the acute CT brain study. Same thing, you have a thrombus in the distal M2 segment of the MCA. We can have a hyperdense thrombus in the basilar artery. And then after seeing this, this is the first sign which can be appreciated on CT study. Hyperdensity of a vessel, artery can be the first sign. And then we can have a parenchymal changes. Parenchymal changes usually take some time, usually 2 to 3 hours to be seen on CT study. They are better appreciated early on diffusion imaging, MRI technique. We'll see that later. But on CT, it takes usually 2 to 3 hours. Now, we can have a very subtle signs which can be appreciated within the first hour. And those two signs, important signs, are loss of insular ribbon sign and obscuration of the deep nuclei. I think for intensivists, these signs are very important because we are routinely getting patients who have reached hospital, who have received IV therapy, but somehow these signs were ignored and those intra-arterial options for the thrombectomies were not offered to those patients. So these are very important signs which will suggest you there is a possibility of large vessel occlusion in that patient. So this is a plain CT. If you see here, the insular ribbon is hyperdense, and on left side, that hyperdensity is lost. So this is called as loss of insular ribbon sign, the earliest sign seen in cases of MCA thrombus. Similarly, if you see here, this is the caudate nucleus, lentiform nucleus, thalamus. Those gray matter structures are relatively bright, hyperdense compared to the white matter internal structure. Here, that hyperdensity is lost in the caudate nucleus and in the lentiform nucleus. So these two signs should be always seen, especially if the clinical status of the patient suggests large vessel occlusion. So go for that hyperdensity in the Sylvian fissure, in the prepontine cistern, and then look for these parenchymal subtle changes, which will tell you that this patient has an early MCA stroke. You can ask your radiologist to adjust the windows because adjusting those window widths and window levels can make the finding very appreciable. Very subtle hypodensity, better seen after adjusting the window. Now this was the issue initially when the DEEDS trial came, whether the half of the MCA territory is involved, whether it is 1/3 of the MCA territory involved. So that was a very subjective thing. So after that we got aspect score. You know that used for MCA territory, the MCA territory region was divided into 10 regions. The normal score, the normal parenchyma shows 10 score. If you have an infarct, score will be less than 10. And usually the aspect score of 6 to 10 by 10 show good recovery. Lesser than that will have a poor recovery. So these are the regions in the MCA territory. Each region is given 1 mark, so 10 regions. If they are normal, the score is 10. If you have a hypodensity in the caudate nucleus, score will be 9 by 10, like that. So similarly for posterior circulation, we have a posterior circulation aspect score. But again, it is very difficult to appreciate. The pontine hypodensity is very difficult to appreciate on CT study. It is better to use diffusion imaging for posterior circulation. We used to do CT perfusion studies, but technically challenging procedure. And now that is replaced by the CT angiography, which will tell us about the collateral score, because CT perfusion tells us about the penumbra, and penumbra depends on the collateral flow in the MCA occlusion. In CT perfusion, we get those 4 maps, and most important maps are cerebral blood flow and cerebral blood volume. Obviously, if you have a large vessel occlusion, the cerebral blood flow to that region will be compromised. But because of the autoregulatory mechanism, the vessels get dilated and the volume in that region is maintained normal, and many times even the volume is increased. So compromised cerebral blood flow but maintained cerebral blood volume or increased blood volume in that region tells us that there is a significant chances of good recovery after the thrombolysis. And that is suggestive of large area of penumbra. Okay? So penumbra, decreased blood flow, normal or increased blood volume, infarcted tissue, umbra, central portion, both are reduced. So this is the important thing. Okay, so obviously we should have a large penumbra. If the penumbra is small, no point in doing costly therapy for that patient. So it has a direct relationship with the collateral score, and that this is commonly done nowadays if you don't know the onset of stroke. Wake-up strokes, CT perfusion or MR perfusion is done, but not otherwise. Now these are the maps. This is the CBF, CBV, MTT, TTP. So this is the area where the cerebral blood flow is compromised, but on volume, the area is maintained. So this is a good candidate for thrombectomy. Compromised blood flow, compromised cerebral blood volume, less collateral circulation, less atrioregulatory mechanism, won't have a good benefit after thrombolytic therapy. Now there are limitations, we'll see that later. So nowadays we are using CT angiography rather than perfusion studies, because CT angiography tells us about the collateral circulation, which defines the size of the penumbra. And most of the centers, hospitals have a good CT angiography softwares. These are the CT angiography images, occluded left MCA, few MCA branches are opacified here. And this is the important concept as far as outcome of the stroke treatments are concerned, whether there is a collateral flow seen on CT angiography or not. So we go for at least 2 sets of acquisition. So the first acquisition starts after the bolus of contrast injection from arch of aorta to the vertex, and the second delayed phase covers the entire vein parenchyma. So that second phase shows the collateral circulation very well. Now there are various grading systems, but ideal thing is just use moderate or poor collateral flow. If more than 50% of the MCA branches are seen, then can be considered as a good collateral flow and patient can be easily taken for thrombectomy. But if the collateral circulation is poor, then those patients won't be benefited, rather will be increasing the chances of free perfusion injury in those patients. So this is the patient with occlusion of the right MCA. This segment of the M1 is not seen, but see this, all those M2, M3 divisions of the MCA are very well appreciated. Occluded MCA, so what is collateral? The ACA is filling from this side, and all those ACA branches are retrogradely opacifying the MCA branches. So this is called as collateral flow. There is no antegrade flow here, but this retrograde flow from ACA are maintaining the MCA circulation. Compared to CT perfusion or MR perfusion images, these don't require good software. Those can be easily interpreted, and we think CT perfusion is, CT angiography is better than CT perfusion technique. MRI, as I mentioned, CT is the best modality, but MRI is reserved for few patients where the patient has a wake-up stroke or the onset of the stroke is not known. So in those patients, we go for MRI stroke protocol and perfusion study. Stroke protocol includes diffusion flare and SWI images. Diffusion tells us about the cytotoxic edema of the ischemic stroke. JRE or SWI rules out the hemorrhagic patients. Flare can tell us about the mismatch between the diffusion and the flare. Acute infarct will be seen on diffusion, may not be appreciated on flare, can be used as a mismatch. So these are the images. Most of you have seen diffusion image and the ADC, apparent diffusion coefficient image. Anything which is hyper on diffusion, hypo on ADC is called as restricted diffusion or cytotoxic edema. So there is an increase in the intracellular fluid which has a restricted movement, and that has a restricted coefficient of the movement. This is the acquired image. This is the coefficient image which is produced by using the software. If you ask, this is just to mention the significance of the B values. Diffusion findings can be exaggerated by using the higher B values. This is the B value of 3000 and 1500. Multiple infarcts are seen here. So you can go for higher B value diffusion technique. Though flare may not show the obvious parenchymal findings on acute or hyperacute ischemic strokes, these can be used by a good intensivist or the neuroradiologist. Normal vessel should be black, should show flow voids. The ACA, MCA, they should not be seen on FLAIR images. But whenever that flow void is lost because of occlusion, because significant stenosis, you will have these findings. So even FLAIR imaging can be used to comment on the compromised blood flow in the circulation. This is the SWI image. Okay. Stroke in thrombus in the right MCA, sorry, left MCA with corresponding occlusion of the MCA. We'll go to cases immediately. This is the mismatch. Diffusion imaging, ADC imaging, the infarct is seen, but FLAIR images are normal. So this is a mismatch between the FLAIR and the diffusion, can be used in cases of wake-up stroke or where the patient's onset of symptom is not known. So we'll see few cases. CT was grossly normal. There was an old PCA infarct. Right MCA was occluded. We went in, this was done in 2010. We went in with a microcatheter, injected chemical TPA there. I think I injected almost 8 milligrams of TPA there. And we got revascularization of that MCA. So this is just a chemical thrombectomy. The stent retrievers or mechanical devices were not available that time. This is the protocol. After 6 hours, after 24 hours, we should have a follow-up imaging just to rule out reperfusion injury. Here there was a reperfusion injury, but manageable. No significant mass effect, midline shift. Now here, this is the case of mechanical thrombectomy. Posterior circulation stroke. The right vertebral was occluded, left vertebral small, had a stenosis. The mid-basilar was occluded, distal basilar was not seen. This is the normal anatomy of the basilar artery. So I went in, microcatheter through which the stent retriever was deployed. I could recanalize that distal basilar artery and few of the basilar branches. This was the thrombus which I could retrieve, and patient showed very good recovery next day. Third, combination of thrombus aspiration and thrombus retrieval. This is the common angiography. Only the ECA is seen. ICA is totally occluded. No ICA circulation. Only the ECA branches are seen. Good cross flow across the midline from the right ICA to the left ICA circulation. This is the collateral circulation coming from ACA. Now, since the thrombus load was very high, whole of the ICA was occluded, I started with aspiration. I aspirated thrombus through the guide catheter, started visualizing the ICA now with few filling defects. And then for MCA thrombus, I used microcatheter and thrombectomy device. And this is the normal, almost normal appearance of the ICA and MCA branches. So combination of mechanical thrombectomy, which initially was done by aspiration. Now combination of balloon angioplasty and mechanical thrombectomy. This I did a few days back in Ruby, in the midnight, 0 power. The left MC was totally occluded, hyperdense sign. Now this is a fallacy. It need not be thrombus. In this patient, it was an atheromatous plaque with stenosis. Why atheromatous plaque? Because I tried to open that vessel with the stent retriever. Whenever I used to deploy the stent retriever, I used to see the flow across the MCA. But nothing used to come along with that thrombus retriever device. So that finding is suggestive of underlying stenosis. So I did balloon plasty with a small balloon, 2 by 12 mm balloon, and that showed focal stenotic lesion. I observed that for next 15-20 minutes, it remained open. So I stopped at this level. Patient showed good recovery. This is the follow-up imaging done next day. The left MCA is still open, hardly less than 1/3 or half of the MCA territory infarcts, showed very good recovery. Combination of stenting and lysis. This I had done long back in Jahangir because he had this focal stenosis at the IC origin, which through thrombus in the MCA, hypoperfusion in the MCA territory. This was the finding, significant stenosis at the ICA origin. So I went in, I used to inject TPA into that MCA, but nothing used to work out. Then I realized I need to open that ICA. So we decided to put a stent there, pre-dilatation, stenting, and immediately after deployment of the stent, the whole circulation improved and the filling defects disappeared. So follow-up imaging was okay. So summary, go for CT brain to differentiate hemorrhagic from ischemic. Ischemic, then your job is done. If the clinical findings are suggestive of large vessel occlusion, give IV bolus in the CT room and go for CT angiography to assess the collateral circulation and underlying focal stenosis. If you don't know the onset of the stroke, go for perfusion imaging or MRI study. If the thrombus load is high, I go for aspiration, followed by, if required, mechanical thrombectomy. I usually do 2 to 3 passes of the stent retriever. If the thrombus or the vessel is not opening even after 2-3 passes, that means there is something underlying stenosed lesion. So in those cases, I do stenting, I do plasty. I avoid stenting in the intracranial circulation on acute basis. In carotid, we do go for immediate stenting. In the intracranial circulation, we try to avoid and then get patient back after 3-4 days, assessing the recovery, and then take a call. Thank you. Questions?
Thank you, sir. Is there anyone having any queries or questions? Yes, Dr. Bajaj. Yeah.
Hi, sir. Good afternoon. Just a small question. What happens to the collateral circulation? Like we saw a few of the very extensive collateral circulation formed. After the resolution of the thrombus, what happens? How fast those collaterals are resolved, or what is the significance?
We are not interested in dissolution of the collateral circulation.
So any harm, like
no.
if
collateral circulation is good.
Yeah, it is good, but also I wanted to know that if we are seeing such extensive collateral circulation, then how soon is the indication of...
No, I think your question should be, if the collateral circulation is good,
yeah,
should we go for thrombolytic therapy or no?
Yeah.
Or no, exactly. Now, this collateral circulation should be maintained with hypervolemia, and BP should be kept on higher side. Okay. The moment BP drops, this collateral circulation will be compromised.
Okay.
So that is the trick. So whenever you have a patient, acute ischemic stroke patients, clinically suggestive of large vessel occlusion, bleed is ruled out, try to maintain BP on a higher side.
Okay.
Try to push more blood into the intracranial cavity, which will maintain the collateral flow.
Nonetheless,
but I think
yeah,
if possible, should be treated with thrombectomy, because there is that BP thing plays a huge role in collateral circulation.
If we are maintaining adequate blood pressure, so can we extend the time of doing the thrombectomy?
Can be, yeah. We can go beyond the window period, yes.
Okay.
If patient comes to me at 8 hours, the infarct seen on diffusion is very small, but the large vessel is compromised, but the large penumbra is seen on perfusion study, I will definitely go beyond 6 hours also.
Okay, sure. Thank you so much.
Thank you, sir.
We have thrombolized the patient, but are there any pointers that we would need thrombectomy or say further intervention? So are there any particular points in CT or MR that we would consider this patient in spite of giving thrombolysis and the patient has improved, but still we need to go for neurointervention?
So most of the patients which I have showed or which I am doing, those patients have already received IV therapy. Now the clinical importance is the most important thing here, clinical presentation. Higher NIHS score invariably tells us that patient has a large vessel occlusion. And plus the imaging findings which I showed, large MCA, hyperdensity, the MCA parenchymal involvement, insulocortical D1 sign is gone. So those patients definitely need, rather in European countries and in America, they won't go for IV thrombolysis, they go directly for a mechanical thrombectomy. In our situation, invariably our patients have already received IV thrombolysis, so stenting is avoided, that is because of that reason.
In spite of improvement, you still go for these interventions?
Or
if there is no improvement, then you go for this?
If patient doesn't improve after IV bolus, we go for mechanical thrombectomy. Any question? Now, if the clinical findings are suggest of large vessel occlusion, as I mentioned, in most of the hospitals, the IV bolus is given in the CT gantry itself. Then they go for CT angiography. CT angiography shows large vessel occlusion. I think immediately patient should be shifted to cath lab. That IV bolus doesn't work if you have a high thrombus load.
Sometimes what happens, we thrombolize the patient. We know that is a large vessel occlusion and the symptoms are worsening. But somehow after 1.5 hour, patient shows some improvement. And then further he deteriorates.
Collateral circulation.
Yeah, the collateral, that is the
The collateral circulation was maintained, and then after some time the circulation compromised, or the thrombus got fragmented through multiple emboli distally, and the major vessels, M2, M3 vessels are not now occluded.
And then should we send the patient to?
M1 we can reach, M2 we can try, we can't reach into M3, M4 divisions.
Okay.
Thank you.
Thank you, sir. I would like to request Dr. Chandrakant Sahare, sir, to please come on the dais and felicitate our chairperson, Dr. Sumit Kakade, sir. Please, sir. Thank you so much, sir. I would request Dr. Sahare, sir, to felicitate Dr. Sushant in this. I request Dr. Chandrakant Sahare, sir, to felicitate our speaker, Dr. Chavan, sir. Thank you, Chavan, sir. Thank you. Thanks, sir.
Moving on to the next lecture. The next lecture is about anaphylaxis. It is one of the most dreaded word actually for each and every doctor, be it a general practitioner giving injection in his OPD, or it could be intensivist giving some basic multivitamins in the ICU. So to present the lecture, I would invite Dr. Vijay Khandare, and to chair the session, I would request Dr. Kunal Oswal to be on the dais. He is an eminent surgeon. He has done his MBBS from Pune University, completed his DNB surgery from KEM Hospital. He is a consultant in KEM, Inamdar Hospital, Noble Hospital and Vishwaraj Hospital. He has special interest in laparoscopy and minimal access surgery. Currently is the director at Parasmani Hospital, Hadapsar. I would also request Dr. Vidyanand Bilare, very close friend of mine, to dais. He is a MD Medicine, and currently he is a director and physician at Sai Seva Multi-Speciality Hospital, Someshwar. I would request Dr. Vijay Khandare to be on the dais. Vijay has completed his MBBS MD Anesthesia from Tata Center, Mumbai, Tata Cancer Center. He has done his FNB critical care from Kokilaben Hospital, Mumbai, and he has been in the field of intensive care since last 12 years and is currently the head of the department Vishwaraj ICU. So over to you.
Thank you, sir, for your kind introduction. We are running short of time, so I would like to sum up my lecture within 50 minutes. So anaphylaxis, yes, it is one of the nightmare for every clinician, physician or surgeon. There are a lot of problems with the anaphylaxis. Basically, first problem is there is no any universal definition for anaphylaxis. Second, there are no any laboratory test or imaging that can diagnose anaphylaxis. Third thing, treatment is there, but no one wants to give it. The treatment of choice is basically giving adrenaline, and everyone is basically scared to give this drug because there are conceptions that this causes basically tachycardia, even arrhythmias. So I'm going to cover introduction, definition, etiology, what is the pathophysiology, what are the clinical features, diagnosis, and management. So there are various types of hypersensitivity reactions. So anaphylaxis is a type 1 that caused by reaction to any foreign substances like mostly food, medications, or insect bites. There are various societies, World Allergy Organization, Australian Society, European societies, and they have different definitions among themselves. So one of the common definition is a severe life-threatening reaction that is rapid in onset, that happens within a minutes, involves mainly the airway, and it involves skin and mucosa. Ana means without, means against, and phylaxis means protection basically. So it's a medical emergency. Just for example, if you can consider one of the patient has come to your OPD or IPD and you have prescribed some medications, antibiotics, and that patient gets a reaction. And the reaction is so dreadful that it can become fatal. So obviously problems are there. That first thing, the patient and relatives are always there to blame you. They will say कि आपने medicines दिया और patient खराब हो गया. Second thing, the patient will suffer. Third thing, there will be increase in the cost. There will be increase in the hospital stay. So these are the problems that basically we face with anaphylaxis. And it has some reactions, and that leads, if not immediately recognized, in less than 5% of cases, the patients basically can die. So it involves multiple systems, cardiovascular, respiratory, GI, and cutaneous, the classic form. There is another term called as an anaphylactoid reaction. There are two things separate, anaphylaxis and anaphylactoid reaction. Both things clinically and by treatment wise are the same. The only thing is how basically the mechanism of action. The anaphylaxis is basically mediated by and hemoglobin E mediated. And anaphylactic reactions are basically non-IgE mediated reactions. Anaphylactic reactions are clinically same as anaphylaxis. Non-IgE mediated reaction in anaphylactic reaction, it is caused by release of basically histamines and activation of complement pathway, C3, C4. And the most common drugs that comes across are the contrast medias that causes anaphylactic reactions. We next come to the part, etiology. So yes, obviously there are some inciting factors. In food, peanuts, fish, egg, insect stings, vaccine, contrast medias. Some of the time the cause is not exactly clear. Idiopathic, latex, rubber latex that we naturally use. There are some drugs, colloids, dextran. Second thing is muscle relaxant. Most common is atracurium that has a potency to release histamine, and penicillins. So these anaphylactic reactions, yes, they can be unpredictable, but there are some risk factors. Patients having some comorbidities, patient having atopy, or patient having some poorly controlled asthma, patient getting some drugs, beta blockers, patient having drugs on AC inhibitors. So these patients are more prone to get anaphylactic reactions. So this photo sums up about what exactly are the risk factors. First is IgE dependent. So there are various peanuts, tree nuts, shellfish, cow milk. It's most common in basically infants and children's. Egg, peach, sesame, insect stings, and drugs. In foods, in natural rubber, latex, occupational allergens, seminal fluids, radio contrast medias. If you see Ig independent, there are radio contrast again, dextrans. In non-immunological, there is a mast cell activation. So there are some things called as a exertional type in physical factors. Consumption of alcohol, some of the medications, morphine, one of the common cause. This patient can get a allergic reaction because also it has a potency to release histamine. And some of the cases, there is idiopathic anaphylaxis. There is exactly no apparent trigger factors are there. So which other patients there are more prone for the allergic reactions? Yes, infants, because they cannot describe the symptoms. In adolescents, they have a risk-taking behavior. Elderly patients, because the immunity has decreased, they are increased, having multiple comorbidities. There are other common diseases, patient having asthma, CVS diseases, mast cell disorders, allergic rhinitis. There are some concurrent medications that also can cause risk for causing the anaphylaxis, patient on beta blockers and ACE inhibitors. So we come to the pathophysiology. So whenever the allergen is patient gets exposed to the allergen, there is sensitization of an antigen that causes release of IgE. IgE binds to the antibodies. Antigen antibody causes binding to the mast cells and basophils. And when the second hit happens, then the mast cells and basophils causes degranulation and it releases multiple mediators. Leukotrienes, cytokines, interleukin 4 and interleukin 13 are the one of the most dreadful mediators that causes anaphylactic reactions. And what exactly they cause? They cause a smooth muscle spasm. So if patient having some airway disease, so patient can become hypoxic. They have a difficulty in breathing. Patient, these mediators can cause a vasodilation. Patient develops angioedema, swelling over the airway part. It causes increased vascular permeability. It causes increase in the mucosal secretions. It causes increase in bronchial muscle tone and airway edema. What are the clinical features after starting this anaphylactic reaction? Skin. As we say, the skin complications that are present in about 80 to 90% cases. But yes, anaphylactic reactions in about 20% cases, they will have no skin lesions. The patient will have a involvement of CVS or RS. So in skin lesions, the patient will have a urticaria, erythema, red color pruritus, angioedema, eye itching, periorbital edema, and conjunctival congestion. In respiratory symptoms, patient have a sneezing, hoarseness, tightness in the throat, and stridor. In cardiovascular system, if patient has some coronary artery disease, it can cause coronary artery spasm. Patient can have a chest pain, chest tightness, impedic doom. If patient has taken some oral allergen by food, so patient can have GI symptoms, vomiting, diarrhea, abdominal pain. On examination, what exactly the findings will be there? The patient will have a skin lesions. Obviously, the red raised blanching patches are there. In respiratory, there will be a wheezing, spasm will be there. We can basically heard the audible stridor. There will be airway obstruction, and we can say the peripheral cyanosis. In cardiovascular system, we can get a tachycardia, feeble pulse will be there. Patient will be restless because of the anxiety, pruritus, itching, and even because of the decreased blood supply, hypotension or hypoxia. So for the anaphylaxis, as I told, there are no obvious tests. So there are some criteria based on which we can basically consider a diagnosis of anaphylaxis. So one of the following, if the criteria is fulfilled, the patient can be diagnosed as anaphylaxis. The first criteria is patient doesn't have any previous history of anaphylaxis. Okay, so he has came to you within minutes or hours with basically a skin and mucosal lesions. And one of the following, patient can have a respiratory symptoms or patient can have a decreased blood pressure. This is the first criteria. कनेक्शन करेगा लाइट बैटरी कनेक्ट कर बैटरी कनेक्ट कर बोलो कोणाचं नाही आहे बंद आहे. Second criteria is if the patient got allergic reaction, but as we know, there are some common allergens that cause anaphylactic reactions. If patient has some eaten a fish or crab or had taken some peanuts and they had come to you, and patient has two of the following. That one is a skin reaction, second is a respiratory symptoms, third is a severe symptom, that is decreasing blood pressure, and fourth is a GI symptoms. Third scenario is patient is known allergic to some basically allergen, and now he had come to you with decreased blood pressure only. So this is the third criteria. So there are basically three criteria. One of the criteria is fulfilled, the condition is diagnosed as anaphylactics. As I told, so it's basically a clinical diagnosis. There are no any laboratory tests. There are few tests that can help to differentiate from the other conditions. There are some differential diagnoses for anaphylaxis: acute severe asthma, carcinoid syndrome, Redman syndrome, after getting the vancomycin drug. So to differentiate from these conditions, we can check actually the blood test of histamine and tryptase. The problem is that this histamine and tryptase, they rapid causes sudden increase in the blood levels and they subside immediately. So histamine level that increases within 10 minutes and subside after 30 minutes. So before you basically treat this patient, obviously the histamine level has subsided. The second thing is a serum tryptase level that increase within 1 hour and then persist for next 6 hours. Obviously there are other tests, urine histamine test, 24-hour histamine test. There are other skin testing, that is in vitro IgE testing, radioabsorbent test for detecting the inciting factors. So we'll come to the last part, that is the treatment. As I told, the treatment of choice is always adrenaline, epinephrine. So it's a medical emergency. First thing is we have to identify exactly the condition, and we have very short time, and within this time we have to give this drug. Oh, great. So epinephrine, as I told, the 1 ampule comes in a 1:1000 concentration. Drug of choice is adrenaline. The dose is 0.5 mg maximum for any adults. If the patient, the adult having a lesser weight, then we can consider as a 0.01 mg per kg as a dose. It should be given as an intramuscular dose, and the site should be a lateral side of your thigh. It should not be given in a deltoid or should not be given as a subcutaneous route. The reason behind that, vascular arteries has a very good blood supply, and if you give the drug immediately, it achieves very good blood concentration. How the adrenaline works? Basically, it acts on alpha-1, beta-1, and beta-2 receptors. It causes alpha-1 by causing a vasoconstriction to decrease the airway edema, angioedema. Beta-1, beta-2 receptors. Beta-1 receptors, it causes the heart to basically pump better. Beta-2 receptors, it causes a dilatation, bronchodilatations. So, drug of choice is giving a epinephrine. Second thing, there are other things called as a EpiPen or autopain. The patients who are known to be allergic and they get frequently anaphylactic reactions. For these patients, there are available basically already filled syringes called as a EpiPens are there. Problem is that they are more costly. Usually they have 2 cartridges inside. If the patient doesn't respond to first treatment part of the adrenaline injection, we can give a second part. So these EpiPens has a dose of 0.15 mg to 0.3 mg. 0.15 mg is mostly used for children's, and 0.3 mg is used for mostly the adults. 0.5 mg is almost available. So for this, basically you have to just open this cap part and grab the autopain like in a fist, and you have to directly basically take a nick on a lateral of thigh. You can basically take a nick over the dress, clothes also. You don't have to remove your basically clothes or pants to give these medications. So these guidelines has been given by World Allergy Organization, American, even the European societies. Okay. So first is epinephrine. Yes, we have to always ask these patients go by airway, breathing and circulation to see for airway patency, because rapidly increased airway edema can cause obstruction of the airways. Supplement of the oxygen if SpO2 level is less than 94%. We have to make the patient supine with leg lift so that there will be a venous drainage. You can take a IV cannula, wide bore, 16 or 18 gauge, and then give a fluid bolus of 15 to 20 ml per kg. Supporting the ventilation is the important part. Next thing is, if the patient's airway is getting more compromised, obviously, first thing is to give adrenaline, but if with that also, if the airway is getting compromised, the next thing is to go for the invasive airway. Because if the edema again worsens, then it will be not able to intubate, not able to ventilate condition will be there. So you have to always keep on ready with the smaller endotracheal tubes. If that fails, then we have to go ahead for next thing is to cricothyrotomy or a tracheostomy. As I told, the drug of choice is epinephrine. Its dose is 0.01 mg per kg, maximum 0.5 mg intramuscular. We can repeat the dose every 10 to 15 minutes, depending on the response. Even if you can repeat the dose after 5 minutes also. There is other alternative technique is to give a IV dose. Problem is that when we are treating this patient on OPD basis, we need to have some continuous monitoring of ECG and blood pressure. If patient is in your ICU setup, yes, we can consider for giving a slow infusion of IV adrenaline rather than giving a bolus. So 50 to 100 mics, gradually slow as over 1 minute. Next part, the first thing I told is a drug of choice is epinephrine. Second is a antihistaminics, and third is the steroids. As you see, we always prefer to give first the Benadryl or steroids. But we need to understand that these drugs are having a slower onset of action, and even the guidelines says there is actually a lesser role in anaphylactic reactions. Antihistaminics, first, they are slower onset of action. They should not be used alone. Not just a H1 blocker, we have to use both H1 and H2 blockers. Diphenhydramine 50 mg dose and ranitidine 50 mg IV dose. Diphenhydramine problem is that it causes vasodilatation and it can cause decreased blood pressure also. Second is by giving us steroids. Obviously, in immediate anaphylactic reactions, the steroids are not going to help. There are 3 types of anaphylactic reactions. One is a uniphasic, second is a biphasic, and third is basically a prodromal. Uniphasic means the anaphylactic reactions comes and within 3 to 5 minutes, patient get improved and patient can be discharged. But biphasic reaction is the one patient after anaphylaxis treatment, he improves, and after 4-6 hours, again started dropping pressures. It happens because we are not treated the patient adequately, or the allergen is still present or has a delayed onset of action. These are the problems. So why the steroids has basically a better action to prevent this biphasic reaction. Drugs that to be given are hydrocortisone. Other treatment parts, if patient has a severe asthma, then we should consider for bronchodilators, giving a salbutamol or terbutaline. If it doesn't respond, then consider for giving aminophylline IV, 5 to 7 mg per kg, the slow, or give a racemic mixture of adrenaline. We should consider a discharging patient. Yes, if the patient comes to you OPD, and if the patient has responded within 4 to 6 hours, we can discharge. But the patient requires some tertiary care or ICU admission in 2 to 3 conditions. If the patient has anaphylactic reaction that requires intubation, if patient having this persistent reaction despite giving intramuscular adrenaline, or third, the patient having some cardiovascular or secondary complication, getting a chest pain, coronary vasospasm. In this condition, we should always advise for ICU admission. Last part is prevention. For the anaphylaxis reaction, whenever we are discharging any patient, we should always mention the allergen. Refer the patient to your immunology specialist. Obviously, confirm the specific targets and counsel the patient and the family about the same. And as rightly said by Dr. Sushant Shinde sir, avoid giving unnecessary medications. I'm telling you, I have seen the patient getting allergic reactions to MVI and opineuron also. And there is always a trend to fill our prescription chart. You know, IV PAN, 40 mg BD, MSET, 4 mg TDS, opineuron, MVI. Okay. So we have to always think before writing something. Okay. Thank you everyone. Yeah.
Being short of time, we'll take the question answers during the tea session, if any. So I would request Dr. Vittal Shenge, the head of Department of Anesthesia, to be on the dais to felicitate Dr. Vijay Khandare sir. I would request Shenge sir to felicitate Vidyanand, Dr. Vidyanand Villare. I would request Shenge sir to felicitate Dr. Kunal Oswal sir. Coming to the last and the most important lecture, declaration and certification of death related to the medical legal issues. Now, medical legal issues is the most important thing. Whenever we write any medication, we start thinking about, will it have some interaction? Will it cause some problem? Will the relatives come and sue me after 10 years, 15 years? So medical legal is now the hot topic of the time. So for that lecture, I would request Dr. Rajendra Bangal sir to be on the dais. Sir is an MBBS. He has done his MD, DNB. Further, he has gone to do his LLB, PGDL, PO. He is a medical consultant and forensic expert. He is the professor and head department at Navle Hospital. He is an advisor, Medical Association of Maharashtra. He is a member, National Advisory Board, Indian Academy of Forensic Science, Medicine. He is a member, Board of Research at the MUHS Nasik. He is a member, Ethic Committee of MUHS. He is an editor emeritus and editor-in-chief of Journal of Forensic Medicine, Science and Law. He is a former dean of Srimati Kashibai Navle Medical College. He is a recognized PG teacher, guide for MD Forensic Medicine and PhD guide. And we, Vishwaraj Hospital, are very privileged to have him as our medical legal expert. For each and every potential case, we call him and take expert advice. To chair the session, I would request Dr. Sachin Abne sir to be on the dais. Sir has done his MBBS from Program Medical College. He has done his D Ortho. Further, he has gone to do his AO International Advanced course, and he is an established trauma surgeon and has treated more than 1,200 hip surgeries of more than 70 years or advanced age. In his career spanning more than 15 years, he could boast of doing more than 5,000 surgeries, and it won't be wrong probably to call him as the leading orthopedic surgeons in Hadap, sir. Thinking about the awesome numbers, one would think that he would be sitting in this hospital 24/7, but he has a lot of interest in extracurricular activities. He is an executive member in Pune Orthopedic Society and also the president, one of the most active presidents of Hadapsar Medical Association. For the second chairperson, I would request Dr. Om Kumar Halinge. He is also a very prominent name in the Hadapsar medical faculty. He is a BMS from Latur. He is currently the director of Lotus Multi-Speciality Hospital, Manjri. He has been working as a physician intensivist since 2010 and he gives a lot of ICU backup to many hospitals in Hadapsar. Welcome, sir.
Hello. Very good afternoon for this last session, probably. Now, this issue of declaration and certification of death was allotted to me. But before starting, I wish to congratulate Dr. Aditi Madam and Dr. Kapil Borawke sir for organizing this particular, and please give a round of applause to both these things. And I could see some familiar faces which I always do in the monthly meeting at the back benchers, back side. And I think they are here because of Dr. Kapil Borawke sir. वो थोड़ा डिसिप्लिन टेरर जो है सर का ओके बट दैट्स गुड ओके विल स्टार्ट ये जो दो लफ्ज़ है डिक्लेरेशन एंड सर्टिफिकेशन ऑफ डेथ इसके अलावा भी देर आर टू मोर वर्ड्स दैट इज डिक्लेरेशन के पहले और सर्टिफिकेशन के बाद दोज आर एक कहाँ होता है यार आगे कहाँ होता है before declaration and before that I also I came in the afternoon session. I heard lectures of Dr. Kothari, Dr. Ragini madam, Yogini madam and Dr. Chavan sir. Fantastic lectures and I definitely wish to congratulate. बाहर कोई पठान सर बाहर कोई अगर है तो बुलाओ अंदर उनको कुछ काम आएगा उनकी ज़िंदगी में ओके ठीक है okay so before declaration there is a diagnosis and after certification there is intimation or reporting. So we'll start with this deaths in ICU because this particular scenario, since today morning we are discussing about all the ICU scenarios in this case. Deaths in ICU, there are some certain considerations which are different from any other scenario, maybe a death in wards or death in your clinic or private practice or whatever. These are the illness in the ICU. The patient is a critical patient. Secondly, the cost of hospitalization or treatment is very high. Age of the patient matters, does matter. वो बच्चा है या 80 years का patient है और pregnant lady है, definitely it does matter. Nature of illness and injury also matters. Uncertainty of the outcome. This is also one of the important factors of a patient who is admitted in ICU. And of course, the issues pertaining to the family. Now, this particular issue pertaining to family, I am discussing in view of the court cases or legalities or potential litigants, what we call it. Education status है या IT वाला है या insured है या what not. Now, these are the few situations which we come across in ICU. ICU में patient क्यों आता है, कैसे आता है? How does it arrive in ICU? Maybe ward का ही patient है अपने खुद के hospital का and he is required to be shifted to ICU. Second is transfer from other ICU to ICU hospital. Now I have seen or I have worked in such hospitals in which they strictly do not allow ICU to ICU transfers because they feel that the GPs or other hospital owners should not think my hospital as a dumping yard for dying patients. They have already extracted or whatever, monetarily and whatever, all the investigations and everything they have done at their hospital, and when at the fag end the patient is dying, then they refer to the, so it will be a hospital policy, whether it should be allowed or not, that is the hospital policy. Patient admitted in wards collapses and suddenly, same hospital, but on the way to ICU, it collapses and dies. Post-operative patient shifted to ICU. This is again an area in which I will be elaborating on the further slides. Next is shifted to ICU to delay the announcement of death. Now, I am not a clinician. I don't know. I only tackle the legalities. But the issue is whether this happens or not, and even if it is happening, it is not wrong. Out of desire to avoid shocking the family and from fear of violent reaction, yes, definitely, on-table death hai, and then though all the facilities are available for resuscitation and everything in the operation theatre, we shift the patient to ICU for declaration of death. Or it may be to buy time to let the relative feel that something is still being done. And this is a major thing. जिस तरीके से, as far as justice is concerned, justice is not only to be done, but it should be seen to be done. Similarly, treatment is not only to be done, but the other people should also feel that treatment is being done. And that's why we can buy time. We are not doing anything wrong. And then shift it to ICU at the insistence of family, even if the treating physician feels that it's no use shifting to the ICU, but still, because the family insists, they have money, they have insurance, they have contacts or whatever, and they feel that it should be insured. Whatever the situation may be. Only these two words, clarity and consistency. My topic is declaration of death and diagnosis and certification of death. So as far as declaration is concerned, clarity and consistency does matter, and it must be practiced by all. And what do I mean by clarity and consistency? ये नहीं कि whatever maybe the nurse, a patient in the ICU, a nurse comes out and says, "No, patient is okay, there is no issue, he is doing well." And then वो junior doctor आता है, वो बोलता है कि नहीं, वो उसका अभी इंट्यूबेशन करना पड़ेगा, वो वेंटिलेटर पे चढ़ाना पड़ेगा. And फिर थर्ड कोई आता है, maybe a ward boy, and says कि नहीं, अभी डिस्चार्ज होएगा, कल हो जाएगा. And then the consultant says वो मर गया अभी, he is no more. So this inconsistency gives rise to more allegations and litigations than any other thing. So that should be taken care of. Few things to be kept in mind as far as declaration of death in ICU is concerned. Clarify the circumstances surrounding the death with the relevant staff and family members. Update. Regular, periodic, often update. क्या हो रहा है? What is the situation of the patient? And factual update. No false hopes. Nothing. कि हो जाएगा, हो रहा है, या nothing like that. Whatever is the situation of the patient should be told to the patient. Do not speak without authority. A hospital should have a policy who should be speaking to the relatives on behalf of the hospital. We often see कोई maybe a politician एम्स में एडमिट है, या लीलावती में, या जहांगीर में, जहाँ पर भी एडमिट है, and then when it comes to the media, there is only one spokesperson who comes often, वो मीडिया पे आता है and he speaks. नहीं, उनकी तबीयत आज खराब है, ये जो भी है, वो उसने खाना खाया, जूस पिया, whatever. He is the only person who is speaking to the media and nobody else. Now it's a time to have this policy with everybody and not only VIPs. Each and every person who is admitted in the ICU is a VIP for the relatives. It may not be VIP for the media or you, but he is a VIP for the family. So this policy of spokesperson should be followed and in the hospital. Explain the need to confirm death. See, people in the ICU or the doctors in the ICU, they have already diagnosed that the person is already dead. Now he is no more. It is only issue of declaring to the relatives. So you can buy some time. You can tell to the relatives, ki, okay, now he is almost collapsed. He is pulseless and breathless and everything. And still we are trying. And give them or you can show them if it is possible to show them what efforts you are doing, or you can tell them, give me 15 minutes, we will try once more, and then we can declare. And simultaneously, during that time, when you already know that the patient is no more, and declaration of death, during this period, you give orders or directions to your colleagues, to your subordinates, to prepare the records. Because you don't know the reaction of the patient, what it will be. It will be, whether it will be a reaction of the grief or anger or whatever. So you tell them to prepare the records within that 15, 20, 30 minutes and then declare the death. Now, what I mean by documentation, what is to be done within that period of 30 minutes, 20. Many hospitals, they have a policy of e-records, EMR. So in that, or maybe a hybrid record or documented record, you write the chronology of not only what you have done, but what are the results of whatever your efforts were. You did CPR, likhte kafi hospitals, 9:15, 9:17, 9:19, CPR diya, are like, what is the result? It is not written. Whether he has been revived or not, you write the efforts done and also the efforts, attempts made at resuscitation, medication details, clinical signs to diagnose life or death, instrumental confirmatory ECG agar use kiya hai to wo likho, documents that death has been confirmed including the time at which this occurred. On this issue, I will deliberate on further slides, the time of death. Declare death. Now document that the death was declared to the relatives along with the relationship with the patient. Kisko declare kiya? It is only mentioned in all clinical notes ki declared, death declared or expired at this. But to whom this death was declared? There is no document. आजकल मतलब जितने हॉस्पिटल्स में मैं जाता हूँ वहाँ पर ये कोई नहीं लिखता है कि किसको डिक्लेयर किया, to whom death was declared. Yes, consent है, it is there, everything is there. But declaration of death, उसका documentation भी है, but to whom the death was declared, whosoever they may be. What happens? It is one of the paradoxes of the medicine. The more junior you are, the more often you have to declare death. No senior consultant or nobody comes forward to declare death. So effort should be taken to make sure that the family hears the news of death from a doctor with whom they are most comfortable. Meaning thereby, if the patient is in ICU or hospital for say 7 days, and during those 7 days, maybe one of the representative of that team, if you are medicine or surgery team or gynec team, one of the person, he may be a registrar, maybe a PG student, GR1, GR3, or a lecturer, or even the consultant, who is very much familiar with that. He may be knowing that family, or he may have established that close association with the patient or the family during those days. How you can know this? When the patients or the relatives ask, "Nahi, wo doctor sahab kahan hai?" You should sense the pulse. Ki no, they have established that relationship with them and they believe, even though he or she is a junior, definitely they have established the relationship, and it will be more proper to send that person to declare death rather than anyone else, whether he may be a senior or junior. Where to declare death? Not in the corridor. or not in the just this thing. Plan and design a separate room. कुछ तो एक simple सी room जहाँ पर 4 कुर्सी है, एक टेबल है, पंखा है, पीने का पानी है. That's enough. इतने बड़े structure में definitely that is not impossible. लेकिन to declare a death, वो कर्टन लगा के हॉस्पिटल में, आईसीयू में, you can ship that body to that particular place and you can have a counseling as well as this thing. What to declare? 4 ही चीज बताना है. What was the diagnosis? How the condition worsened? What efforts were made to save him? And then some words you should find depending on the culture of that patient or the language he knows or understand कि वो किस तरीके से बताना है that the patient has expired. And this is important. The tone of the doctor's conversation with the family before death is mirrored in the conversation after death. The doctor or a nurse, need not be a doctor, anybody who is constantly corresponding with that family members and they have a faith in him or her, and the tone in which they were responding or corresponding with the patient's relatives before death, the same replicates even after death. So it is better that that person, and it definitely, there are some language barriers. Maybe a Keralite or a Northeast person, if you say कि नहीं नहीं तू ठीक है आज ज्वाइन हुआ है लेकिन वो डेथ हुआ है डिक्लेयर कर, अरे दे मे नॉट बी नोइंग कि पेशेंट मर गया है, इसको हिंदी में क्या कहते हैं या मराठी में कैसे बताए. पेशेंट वो दे मे टेल इट ब्लंटली कि नहीं नहीं वो मर गया है, वो जूते खाएगा वो जो भी है, whatever. Now, and if at all, if you feel that there is a something has gone wrong, it does not go wrong, but if at all, then it's a mistake to think that a patient's relatives are not intelligent enough to understand what has gone wrong. ये जो assumption or presumption है, that should not be there as far as death is concerned. This also happens. I worked in I'm a forensic person, postmortems and everything in Sassoon we used to conduct 24 hours. Joe police constable, in his duty, if a death occurs and if that police constable is deputed for that particular body, he or she has to complete that particular protocol. वो मॉर्चरी में हमारे लेके आता था, उसका पीएम करने के बाद वो रिलेटिव्स को हैंड ओवर होने तक, मे बी मेनी टाइम्स इट यूज टू टेक ओवरनाइट, उसकी ड्यूटी रहती थी. अगर शाम को 6 बजे कोई डेथ होता था तो पोस्टमार्टम अगर मैंने सुबह 8 बजे किया तो दैट कांस्टेबल इज ऑन ड्यूटी टिल 8 AM in the morning. It's very difficult for them. Similar way, this issue of declaration of death is to be considered. अगर किसी का ड्यूटी 8 बजे खत्म होता है और 7:45 बजे अगर कोई डेथ होता तो you cannot expect the same level of conversation or method of declaration as a person who has just joined the duties. So again, it is a policy matter how it should be tackled. Now, what agitates the family? Sir, मुझे बताओ ना 30 मिनट होने के बाद. I will stop there and then. What agitates the family? First is no correspondence, total silence. कोई कुछ बताता ही नहीं है हॉस्पिटल में. और ये मैंने खुद आपने भी एक्सपीरियंस किया होगा. When our own patients are admitted in some other hospital in Bombay, Kolkata, Bangalore, nobody tells anything. बस आते हैं जाते हैं, ये वो टाई, वो गले में पट्टा और ये सब. They roam around here, but nobody corresponds with you. Second is the unavailability of ICU beds. ठीक है, पेशेंट सीरियस है बट नॉट एबल टू गेट एडमिटेड क्योंकि ICU बेड्स नहीं है. शॉर्टेज ऑफ हॉस्पिटल सपोर्ट स्टाफ एंड द रिजल्टेंट डिलेज. शॉर्टेज ऑफ हॉस्पिटल स्टाफ है या नहीं है, द रिलेटिव्स डू नॉट नो. व्हाट दे नो इज काम नहीं हो रहा है कि मैंने एक एक्स्ट्रा तकिया मांगा या ब्लैंकेट मांगा लेकिन मिला नहीं है. सो डेफिनेटली दैट इरिटेट्स देम व्हेन दे आर पेइंग द हॉस्पिटल fees. and being asked by doctors to procure out-of-stock life-saving drugs or blood. So this is also a thing to be remembered. Now what are the solutions? The first is efficient PRO. PRO of the hospital, I don't know, उसके क्या qualifications है, क्या है, वो है, previous hospitals में उसने क्या किया है या results he has given, but he should be an efficient PRO who is available and who is approachable at all times. ये नहीं कि PRO, हमारा PRO तो मेदांता हॉस्पिटल दिल्ली का आया है, होगा ना? He may be a good PRO, but he is not devoting time, and if he is not being available and he is not approachable, then he is useless. Second is insurance coordinator. Today's medical practice or medical profession is totally insurance based, and without this efficient insurance coordinator, a hospital cannot run efficiently, and if he is inefficient, then definitely there will be more problems as far as allegations are concerned. Transparent billing policy. There is no such thing as packages or something unless and until you inform each and everything to the patient कि package है, knee replacement का package है, उसमें क्या है, inclusions क्या है, exclusions क्या है. If it is not, and it is not only the issue of conveying this to the relatives, it is the issue of documentation also. Not only conveying, but also documentation that you have conveyed. Effective periodic communication with patients, relatives about the cost of treatment packages. Okay. Consultant to build good rapport with the patient. Consultant meaning thereby the admitting consultant or the chief consultant who is under whose care the patient is. It's not that only for billing purpose or only for legal purpose we are writing the names of a consultant, but it is our moral, legal and mandatory duty to build a rapport with the patient or the relatives when our name is written as an admitting consultant, and meticulous documentation which has no other option. Now coming to a second, sir, continue. Second aspect of my topic. ये statistics है इसका. Again, this has a relation with declaration of death. Declaration of death. आपने पढ़ लिया होगा कि कितना deaths होता है और कितना human organs donation होते हैं. 2011 में you all know अरुणा शानबाग का case, everybody knows कि वो passive euthanasia ये whatever, ठीक है, वो कोर्ट ने, which was a very ineffective and useless piece of litigation as far as Supreme Court is concerned, Aruna Shanbag case. Because till date, in my knowledge, there is no writ petition which has been filed based on this particular case. Ek hua tha, which was also the illness was not critical. So this is a useless piece of litigation as far as I am concerned, Aruna Shanbag. Usme, there was one sentence that the conclusion was based on Article 226, and they said, we are laying down the law in this connection which will continue to be the law until Parliament made law on this subject. Parliament till date has not made any law on this subject. This was 2011. Then in 2014, your very effective and efficient body, that is ISCCM and palliative care wala, IAPC, they have formulated a very good document, this end of life care policy, an integrated care plan for the dying. It is a comprehensive and very good piece of documentation, and we must all congratulate these two associations for this. But after this, what happened? They were only guidelines. Guidelines cannot have the strength of law. Then in 2016, see, Rajya Sabha as well as Lok Sabha, in both these houses of parliament, the medical treatment of terminally ill patients, protection of patients and medical practitioners bill 2016 was introduced. It got lapsed in Rajya Sabha as well as Lok Sabha. Koi nahi. Nobody bothered about it, and after 2016, it has never been introduced, this particular bill. And if you read this particular bill, there are very considerate and very good options which can take care of all these our practical difficulties. 2016 में 2014 में IAPC ने किया SSM में, तो 16 में उन्होंने इंट्रोड्यूस किया, 17 में इंट्रोड्यूस किया, they got lapsed, and then 2018 ICMR came with these guidelines, and these are not guidelines, these were only definitions. Definitions कैसे? Terminal illness का definition, futility का definition, all these definitions, they have nothing, no strength of any guidelines. And then 19 मध्ये this Manipal hospital came with Blue Maple. You must be all aware of this. If you, I will send all this on Patan Sir को मैं भेजता हूँ. You can circulate, read all these things. Blue Maple is again a very good piece based on ISCCM and IAPC के same thing, but they have modified and revised it 2019, and then 2020 में AIMS, these are all the signatories. 2020, March 2020, AIMS came with another document. कि Manipal ने किया, सब ने किया, ICMR किया, तो AIMS also came with, and again, this is a very good guidelines. Then in April, March में 2020 में AIMS ने किया, and then April 2020, ICMR came with this particular piece of guidelines, that is ICMR consensus guidelines on do not attempt resuscitation. Not DNR, but do not attempt resuscitation, that is DNAR. Now this is also, it's most recent, April 2020. And they have given an algorithm and a flow chart that how and what steps are to be taken before declaring a person as dead. What it states that it, and the limitations are, this DNAR relates only to CPR and not to any other aspects of terminally ill patients, only limits to CPR only, nothing else. It would apply to a patient with a progressive, debilitating, incurable terminal illness where CPR would be inappropriate. Compassionate care is integral to overall, and whatever they have mentioned in it. Futility of treatment is also mentioned in this do not attempt resuscitation. Now this futility of treatment, they have initially given a document in which they have clearly stated that futility of treatment is a misnomer. This term futility should not be used and all this. But again in 2020, they have given this futility of treatment as a, this thing. Again, coming back to my topic of pronouncement of death. Organ donation has become a regulatory part of end-of-life care discussion with the family as per 2011 amendment of Transplantation of Human Organs Act. The required request clause in the amended law makes it compulsory for ICU clinicians to provide an organ donation option to the family. This is mandatory. This has become mandatory. And in each and every mortality meet as well as clinical presentation meet, I do often present this particular slide that it is not an option now. There is a, if you compare 1994 of the Act and rules of 2014, if you read the last line, transplant coordination in hospital, it was optional in 94. It is mandatory in 2014. I don't know whether this hospital has still, I have already said that it should be appointed. Duties of registered medical practitioners, this is an act, this is binding. You see the last line, the above mentioned duties, all duties to convince the relatives for organ donation shall also apply to the RMPs working in an ICU in a hospital not registered under this act. Our hospital may not be registered under Transplantation of Human Organs Act, but still this clause mandates that we should have this transplant coordinator. And what are the qualifications? They are also mentioned. You can appoint any nurse. जरूरी नहीं है कि कोई transplant coordinator चांद से लेके आना है. अपनी ही कोई जो nurse है which is qualified, you can appoint her or elevate her to the post of transplant coordinator, or you can tie up with any other hospital which is this thing. ये only government of Maharashtra and government of Tamil Nadu, I think they have this 2012 का GR है, in which उन्होंने they have advertised कि those hospitals who want to opt for non-transplant organ retrieval centers, but there was no much response from any of the hospitals. Bombay, Pune में hardly 4-6 hospital में apply किया था ये NTORC के लिए. But again, there was same 2012 GR. Now this, I will read it for your purpose. Certification procedures have been elaborately laid down in Transplantation of Human Organs Act. It is hereby decided that the procedures outlined therein will also be adopted as brain death certification procedures in Maharashtra. जो पहला जो slide मैंने project किया था diagnosis of death का, diagnosis whether in cardiopulmonary sense or in neurological sense. In this particular case, this 2012 का GR है, only in some states, Maharashtra, Tamil Nadu, they have authorized doctors to certify death in the brain deaths, even for non-organ donors. So this we should be taken care. And latest judgment, that is this 2018, everybody we should read this 2018 judgment, जो Supreme Court में दिया था, and it held that Article 21, जो काफ़ी सालों से चलता आ रहा है कि whether 21 of the Constitution, whether it includes right to die or not, and this 2018 judgment has clarified that yes, it includes right to die also in addition to right to life. An individual has a right to die with dignity as a part of right to life. It permits discontinuation of life support. You can read this, but the only thing I want to state is that it is now the decision to be taken whether we should start certifying the brain deaths as far as this particular judgment or not. Sir, 2 minutes में खत्म करता हूँ sir. MCCD का only 2 minutes. Yeah, this was about pronouncement of death. Now coming to cause of death. MCCD. Death should be confirmed. This is a preliminary thing. Doctor should know the cause of death and everything. Unnatural deaths, only 2 things. It's not necessary that for filling in the form 4 and 4A of cause of death, the death should be natural. Even in case of unnatural death, stab injury, fall from height, snake bite, poisoning, drowning, you can definitely fill in form 4 MCCD. Only issue is you do not hand it over to the relatives. You hand it over to the police. When you are informing to the police, you tell them, yes, we are informing because this is an unnatural death, but along with this information, I have also determined that this was death due to hemorrhagic shock because of stab injury. This is my certificate. You give it to the police and let the police decide whether the body is to be sent for autopsy or not. Sending the body for autopsy is not the right or duty of a doctor. Please do not step into the shoes of police. Let them decide whether the body is to be referred to the for PM or not. You only end your clinical notes with these 2 words: inform police, and then close your pen or jeb mein rakh lo. That's all. Don't write anything else. Do not forget to inform police in unnatural deaths. Do not forget to enter details in MLC register. Do not hand over the MCCD to the relatives, even if you know the cause of death. And do not mention, not only do not write, but even do not talk about postmortem, autopsy to the relatives. So, okay. Again, within 24 hours, it's not, it's a myth. अगर 24 घंटे के अंदर अगर डेथ हो गया तो पुलिस को इन्फॉर्म करना है, जरूरी नहीं है. If you know the cause of death and if you are sure, you can definitely write the cause of death, and if it is natural, you can issue the certificate to the relatives and let it go. No need to inform the police. Now, what is the cause of death? I will skip these slides. Time, okay. Cause of death जो है, for example, 3 words in a cause of death certificate: immediate cause, antecedent cause and underlying cause. ये 3 ही लफ्ज़ है जो हमें याद रखने हैं. Now in this, ये सर्टिफिकेट का फॉर्मेट है. We everybody know पार्ट 1 और पार्ट 2 होता है. पार्ट 1 में 3 चीज़ है, 1 A, B, C. अभी इमीडिएट कॉज है डिसीज डायरेक्टली और कॉम्प्लिकेशन दैट डायरेक्टली प्रिसीडेड डेथ. डेथ किससे हुआ? हाउ द डेथ वाज कॉज्ड, दैट इज इमीडिएट कॉज. एंड व्हाट लेड टू दैट इमीडिएट कॉज इज एंटीसीडेंट कॉज. एंड द चेन ऑफ इवेंट्स स्टार्टेड फ्रॉम व्हाट, दैट इज अंडरलाइंग कॉज. इतना सिंपल है. एंड एनीथिंग एल्स इज पार्ट 2. But 80% of death certificates are not written properly. Duodenal ulcer is an underlying cause, which cause perforation of duodenum and which cause peritonitis. That's so simple. Strangulated hernia, perforation and peritonitis. Some correct and incorrect. CA pancreas leading to diabetes, leading to gangrene food, leading to septicemic shock. इसमें CA pancreas is the underlying cause, and then 2 antecedent causes, and then the immediate cause is septicemic shock. Polycystic kidney leading to hypertension, leading to renal failure. Similarly, all these things, hypertrophy prostate, retention of urine, uremia. So these you can, I will skip this. Do not attempt to mention as antecedent or underlying cause as pedestrian knocked over by a car. These examples I have taken from some standard textbooks which are being taught to UG students. And I also teach this to you, so you do not mention pedestrian knocked by a car. How do you know? You are sitting in your clinic or hospital, usko knock kiya ya whether he was assaulted, motor vehicle accident. No, you only write there was a trauma. You only write trauma and stop there. Don't try to investigate. Don't step into the shoes of the police. Tripped over loose floor rug at home. ये actual certificates है. No. Fractured neck femur, okay. Automobile accident. Whether it was accident or assault, you don't know. So don't write it. So these some of the things I will skip. We'll see some how did the injury occur, manner of death, matter. Okay, I will stop. Any issues you can.
Thank you, sir.
In fact, it's not only declaration of death which has to be done under camera or something. In today's era, each and every conversation, communication with the patient, whether it is related to death or illness or admission or discharge or whatever, has to be done in camera. It's a very simple process. If you, मतलब अपना जो ये किसका है? Okay, if you take a camera, एक 250 rupees का आता है, and definitely you can fix it in your cabin also. Need not depend on the hospital to provide you a separate room for conversation. You just come in your cabin, consultation room, you fix it, and it will record everything, all discussion. It's not at all costly, but everything should be recorded.
Any other queries?
Sir.
Photography in hospital, is it legal or it is offense?
लीलावती
बाईकवाला दाखवायचं सेल्फी काढतो, इज इट लिगल और नॉट?
नाही सेल्फी कोण काढते? तुम्ही काढता की? ओके, पेशंट जर काढत असेल ते सेल्फी, इनफॅक्ट देर इज नो, इवन इन केस ऑफ लीलावती ऑल्सो, इफ they were in private room, definitely in private room there is no issue of photographing or everything. If it is in a consultation room, hospital basically should have a policy ki whether it should be allowed or not, because it may be used in some other way. The first time patient comes, they may be very satisfied with you and they may want to say, "Acha consultation kiya, want to have a selfie and everything." Later on, if the issues go on in a different track, definitely they may, और आजकल वो change भी हो सकता है selfie, कि नहीं ये डॉक्टर नहीं था, दूसरा था, उन्होंने तो मुझे consult ही नहीं किया, whatever. So it's better not to indulge in those. But as far as the private life of a patient is concerned, and when we are providing a private room to them, in private room they can definitely have those possibilities. Sir.
So one more question. Most of the time we being consultant not in the hospital, patient is brought in the hospital, suppose brought in a bad state and next 1 hour he dies, but we have not seen the patient. And suppose today I am called, patient arrived, patient died. Am I eligible to write that death certificate, because most of the time it happens and they say you come and sign tomorrow?
Correct. See, in this case there are two circumstances. One is when we are in a teaching institute, like I am in a medical college, जहाँ पर professor, AP, lecturer and SR, JR सब hierarchy होता है. It's not necessary that every time the head of the department has to come. Secondly, there is a difference between declaration of death and certification of death. Declaration of death can be done by anyone, irrespective of whether he is a consultant or not. Even if he is not of your unit, other unit, आज emergency पे they can declare. But the certification, because you are the admitting consultant, you know the cause. And if you wish to give certificate, then he cannot give, you have to give. The person who knows the cause of death will give the cause of death certificate. Third issue is, if like Vishwaraj Hospital, for example, though it is a corporate hospital, but it is a research institute or it is a teaching institute. You have units. Medicine ka unit 1 hai, you are the HOD, and then you have. So definitely the policy of the hospital mandates that the patient will be admitted under the HOD. But and also as per NABH, you have to see the patient within 24 hours. But within that 24 hours, if the patient dies, definitely some other doctor of your unit was attending to the patient, and he will see to the patient and he will intimate you that such and such was the case, and definitely he can do it. But it should not cross 24 hours or the limit set by NABH. कुछ हॉस्पिटल में 12 hours है, कुछ में 24 hours है. कंसल्टेंट के लिए 24 hours है, मे बी एसोसिएट के लिए 12 hours है, वट एवर. इट डिपेंड्स ऑन हॉस्पिटल टू हॉस्पिटल. लीगल लिमिट नहीं.
ब्रॉड डेड कम्स इन कैजुअलिटी, तो उसका ट्रीटमेंट कहीं बॉम्बे में चल रहा है, तो उसके पास सब डॉक्यूमेंट्स है, नोन केस ऑफ मैलिग्नेंसी.
यस सर.
तो सर्टिफिकेट इशू करना है, नहीं करना है?
यस सर. सर सी, we as a hospital or even you as a consultant should keep this in mind that each and every broad dead case is by default MLC. By default MLC. वो मेरे पिताजी है और उनका मैं ड्यूटी पे हूँ और उनका डेड बॉडी अगर आता है ब्रॉड डेड, it is a MLC. I will inform to the police. Provided if you know the cause of death and if you want to, हमारी सर इस सिलसिले में डेक्कन और कोथरूड पुलिस स्टेशन के डीसीपी के साथ एक मीटिंग हुई थी वहीं पर कि व्हाट इज़ टू बी डन, जब ये सह्याद्री वगैरह सारे कुछ थे, तो उन्होंने बोला कि we don't expect doctors to inform each and every case to us. The issue is if they take that responsibility of certifying the cause of death of that patient, then they should handle it. Later on, if it turns out that it was not a case of MI, but it was a case of assault, it was a some concealed wound which was not detectable. And then if later on after a month or 6 months, if a case is filed in the court and we are not informed, then we won't be in picture at all. It is you and the court who should, it will be your responsibility to inform to the court or convince to the court that why I have given this certificate, issued certificate. So it is the issue of taking the responsibility whether to issue that certificate or not. Second aspect of it is, if somebody else is going to issue the certificate, he was already on treatment of cancer therapy, chemotherapy, and under treatment of some doctor, Bombay ko ho, Pune ka ho, and he is willing to give the MCCT, death certificate. In that case, you have no role to play. It is my hospital, Vishwaraj Hospital. यहाँ पर केस आई है, broad dead है. My duty is to inform the police. My role is over. Now, whether that body is to be sent for autopsy or not is the question. Now, for this, the relatives, they bring a certificate from some other doctor, labeling it as a natural cause of death. Vishwaraj has no role to play. It need not even maintain that copy also. They only refer the relatives to the police. कि हमने पुलिस को inform किया है. Now you have brought a certificate. You submit that certificate to the police and satisfy the police that it is a certificate from a RMP, registered medical practitioner, Ayurved ho, homeopathy ho, jo bhi ho, MBBS ho, and it is a natural death. Let the police decide whether it is sent to be sent to the for autopsy or not. Vishwaraj का issue पुलिस को inform करने के बाद खत्म हो जाता है. Sir.
Any document to be maintained when when we got the broad death in casualty, while we inform, after we inform the police?
Yes. See, when we say that broad dead, how we will know that it is a broad dead case? Ambulance से 108 ambulance से लेके आया है या कोई अगर relatives भी लेके आते हैं, तो we have to at least pulseless है, breathless है, body temperature, pupils, ये वो ECG, ये करने के लिए कम से कम we have to take it in the person in the casualty, and once the person or the body enters the casualty, there is some documentation. That particular documentation, as far as ER is concerned, has to be maintained. आप जो अगर ECG करते हो तो that strip is also to be attached to that particular this thing. But जो unique identification number होता है, क्या बोलते हैं उसको, UIR या जो भी है, that is not to be given to that case because that is to be given only to a live patient and not to a dead patient. Otherwise, all documentation, and then you certify, yes, it was brought dead. It was brought dead. You maintain that file in a separate MRD का अगर separate section अगर है कि brought dead cases, and that is to be informed to the police. Once we inform, our duty is over. Let them see. Custody of the body, maintaining the custody of the body is not the responsibility of the hospital. No government has provided any infrastructure, manpower, in machinery to protect that dead body. हमको कोई gunmen नहीं दिए है उन्होंने. लेकिन we only have duty to inform the police कि this particular patient was brought dead in this hospital, and that's all. Now वो स्टेशन डायरी में एंटर करते हैं, उनका ऑफिसर उनको बोलता है कि ये वो ब्रॉड डेड आया है, वो पंचनामा करो. नाउ इफ दे डू नॉट टर्न अप एंड द रिलेटिव्स दे एजिटेट कि नहीं हमको लेके जाना है, वी आर नोबडी टू स्टॉप देम. वी आर नोबडी टू स्टॉप देम. द मोमेंट दे लिफ्ट द बॉडी एंड टेक अवे, यू मेक अनदर कॉल टू द पुलिस स्टेशन कि जो मैंने आधे घंटे पहले बताया था वो बॉडी लेके जा रहे हैं. दैट्स ऑल. इफ दे से हमको मत बताओ, देन डायल 100. 100, whenever you dial, you identify yourself. Okay, I am such and such person from such and such hospital talking. You identify yourself, all are recorded. And then you say कि हमने ये किया था, and that particular police station is, we have already conveyed but we don't know the details. Batch number नहीं बताया, नाम नहीं बताया, and this is for your information. That's all.
Sorry to interrupt. We have a 15 minutes tea break session. We can continue with the question answers over there.
Yes.
I would request Shripad Kore sir to felicitate Bangal sir. Sir's lectures are always an eye-opener and always provide some more and more information. I could request Dr. Shripad Kore to felicitate Abne sir. I would request Kore sir to felicitate Om sir. I would now request Borauke sir to come on the dais and for the further proceedings, vote of thanks, declaration of the result of our selfie contest, and felicitation of the faculty members of the workshop.
Thank you, Sushant, for excellent moderation of the sessions. I thank all the speakers who have given their best today, taken time out, and without those speakers' devotion, this CME was probably not possible, not successful. Special thanks to start with Dr. Nirmal Tapadia sir, Dr. Nitin Rane sir, Dr. Ganesh Bokeh sir who travelled all the way, Dr. Amol Raskar, Dr. Riaz Pathan, and all the speakers who have given their time to make this CME possible. Without support from the management team and our own executive director, Dr. Aditi Karad, when we had a word with her, she immediately agreed. So, and Madam has wholeheartedly supported for this concept of continuing medical education, Vrh Gyaan. So I thank on behalf of Team VRH and Vrh Gyaan for supporting us for this event. I thank Dr. Vikram Agrawal sir and Dr. Rakesh Nirmedi sir also for giving us an opportunity to have this session. Special mentions Dr. Tabrez, who has worked hard. Please be on the dais. Day and night for last 2 weeks. We have changed his name. He is not Dr. Tabrez anymore. We have changed his name to Dr. Tarbez. Now he is so Tarbez in all these things. So I am very thankful to Tabrez for his all devotion. He was never mentioned anywhere. Then Mr. Sangle, our facility manager, who was on his toes over last 72 hours to make all things. Probably when I came in the morning and when his pictures were shared yesterday night about the arrangements done here, it was totally transformed into a very different atmosphere. So I thank him. Entire IT team, without a single interruption, the whole program, right from word go till now, not a single interruption. So I thank IT team for that. We have a special request at last minute to them that we want to continue these audiovisuals to our lunch area as well, because we thought during lunch and tea time people may get tired and be sitting there. So they have arranged an extra room there also. I'm thankful for that. Entire VRH management team, and not probably, it will be not correct if I don't mention name of Dr. Kiran Sawant, who was never ever in the picture, but like Paddamaksa Manus kind of a role, what Kiran has done, and whatever the program VRS team does, Kiran silently working
like Rahul Dravid is working for Indian team. So I thank Kiran also. I thank all the chief guests and delegates and all the chairpersons. So whatever chairpersons right from the day we started, right from Lokare sir, who was the first person actually who has started his private ICU, to Dr. Om and Dr. Sachin Abne sir, who is recently been elected as HMA president. All of them immediately agreed to support our cause and be here as a chairperson. Now, the presence of all these makes this CME a real success. That itself shows that probably how keen these all people are to support our cause. So I thank them on behalf of team and all this team led by Dr. Vijay Khandale sir. He's all the time working very hard to make this. I think a lot of phone calls. He must have made some 200, 300 phone calls over last 2-3 days. So I'm really thankful. Along with this, I'm also thankful to Meditune Pharmaceuticals for supporting us. And last to mention, I have to thank Allieds Pharmaceuticals who have supported us, because without this support, usually it's very difficult. And when we raised the idea of Selfie Contest, Allieds Pharmaceutical immediately agreed for this innovative idea which is never ever done before, this Allieds Selfie Contest. Now first, I will ask Rakesh sir to be on the dais to felicitate our workshop team, and then we will announce name for our winners for Allieds Selfie Contest. For workshop, we will have Dr. Vittal Shenge sir. So please on the dais, I request Rakesh sir to please felicitate. Dr. Satish Sarode, Dr. Debashish, and Dr. Kiran. So these will be our faculties for workshop, which will be there after this Thanksgiving ceremony. I have never seen Shenge sir so quiet throughout the day. Best time is, I think, keep meetings on Saturdays. But we want him to talk all the time because we always cherish his thoughts. So 1 hour, I think, next 1 hour he'll be interacting. Dr. Satish. When Dr. Debashish joined here, he was very reluctant. Sir, यहाँ कुछ academics भी होता है या सिर्फ patient देखते हैं? बोला slowly अब पता चलेगा आपको. We have some academics, and he is happy over last 2-3 months. Because it's not only what the work will go. I was discussing with Dr. Sachin Abne sir how important is this kind of activities, and HMA is also very proactive in having such activities. So same thing we are discussing. Dr. Kiran. जरा ताली बजाई जाए यार. Thank you. Now I will request Mr. Amit from Allieds to be on the dais. He is state head for Allieds Industries Limited, and I thank Managing Director and CEO of Allieds, Mr. Praveen Naik, who is not here. He is in Chennai today. I'll just display this Allieds Best Selfie Contest, and first award is, the best is always be together. That's a message today. There are many advantages of going together on a conferences. Always my wife asks me why all the time you have fun, why you are always going alone for conferences. So I think after this first award, I might change my thought. Please display the first awardee. First award. Any guesses? Let them see. Dr. Jayavanta Deshpande. So this I was referring. So please be on the dais, Dr. Jayant and Janvi Deshpande. फिर जोर से ताली. Now what to do to that first prize they will decide. So this is as we have promised 5,000 rupees and a trophy from. So it will be. It will be a great gift from Vishwaraj Vrh Gyaan team, and probably it's a big message for all of us why we should take our spouse for a conference. Thank you, sir. Thank you very much. Next award is to Best Selfie Contest, Dr. Komal Gaikwad. Again, I think she tricked. Not only alone, she has taken few other people with them, so they have more likes, and a lucky winner, Dr. Komal Gaikwad, is the second winner. You can call all of your friends, no problem. I'll request Mr. Amit to please hand over the gifts. Is it a cash money or check? Cash, okay. It's a cash money, so no problem. Thank you. Third award is to Dr. Sushma. Dr. Sushma. Dr. Sushma Bhairaukar. Madam is a consultant gynecologist, and I really appreciate her just to learn even at this age. Right from 9 a.m. she was the first one to have breakfast plate till now. I think it's a really great gesture, and it gives a lot of inspiration to a generation like us. Thank you very much. Now the second one more prize, that is for registration for Best of Brussels and conference in CME, and that is been awarded to your photographs and no biased, and that is awarded to Dr. Sadhna. So Sadhna is a lucky winner to get handover. So Dr. Sadhna will be one lucky winner where she has got free registration for Best of Brussels, which is the best critical care conference in Southeast Asia, where it's been attended by people from Sri Lanka, Bangladesh, Nepal, Bhutan, Maldives, and her registration will be done by me and details will be sent to you. This is a promise made on the dais, so because I am the head for registration for BOB. So really and one more consolidation award. That award, we have been forced to give this award, and that award is 1,000 rupees for none other than our own Dr. Praneeth. He has maximum number of likes to his WhatsApp status. So we have been forced to give this award. This award didn't exist, but we have been forced to give this award on public demand. Hope he will buy one good book out of that 1,000 rupees. Thank you. So this concludes why this selfie contest was there, because we love everybody, but we don't love ourselves. So at the end, you have to remember whatever you are doing, we are not doing anything for others, we are doing for ourselves. So when you start loving yourself, and if you start doing best for yourself, you automatically do best for your hospital, your society, your family, for everybody. So probably that is a mission we work on. Do best all the time,
and love yourself. Okay? बोलते हैं ना मैं अपना ही खुद का favorite हूँ. So you have to be favorite of your own first, and probably this concludes today's critical care update. We will be back with much more and a better themes and with lot of corrections. Whatever inputs you have, all of you have to submit feedback forms. Please submit 2 feedback forms. That gives us an opportunity to improve. Nobody is perfect. I know throughout the day there are a lot of shortcomings, but I assure you that in coming days, whatever shortcomings you will highlight, we will try to work on that, improve on that. We'll take that in a very good sense, and that definitely will make us better next time. Thank you very much. And workshop is on the next hall.
For the ventilator workshops, we have 3 tables. First table for the mechanical ventilation, that is for 30 minutes. It involves the basic and advanced settings of ventilation. Second table is for HFNC, and third table is for